medal for PG medal for case report. So I warm welcome to all the judges and my sincere thanks for accepting as judges for this session, sir. Dr. S. Ramakrishna sir, Dr. N. Venkatram Reddy sir, and Dr. M. Venkateshwar Rao sir, senior faculty member. So due to COVID pandemic, we are unable to conduct a physical conference. So for the benefit of the postgraduates, we think over this and we have to adapt to the change. So we are conducting this. So I think all the participants are ready. If you are ready, we will move with the program, sir.
Oh, sir, Dr. Venkateshwar Garu, good morning. Did Dr. Venkateshwar sir join?
Yeah, just joined, sir. Just call me. I will check.
Okay.
I'm online.
Yeah, yes, sir. Thank you, sir. Venkatram Reddy, sir.
Good morning, Venkatram.
Sir, Ramakrishna is also here, sir.
Happy to see you receiving the award of APJ Abdul Kalam Award. Congrats.
Venkatram Reddy, sir.
To you only. Are you able to hear? Venkatram, you are on mute, I think.
Sir, Dr. Ramakrishna is waiting for your wishes, sir. Good morning, sir.
Morning.
Thank you.
I was conveying my congrats to you for being awarded the APJ Abdul Kalam Award.
Am I audible, sir?
For you.
Yeah,
Am I
yes, sir.
audible?
Welcome, sir. Good morning, sir.
Am I
Morning, we are
audible?
proud of you.
Yes, sir. Venkatram Reddy, sir.
MB Rao sir is listening to me or not?
Yeah, I am very much.
Thank you, sir. Thank you.
On behalf of AOI Telangana, also, our heartful congratulations to Venkatram Reddy, sir.
Thank you, Ramesh. And let us go ahead with our program because it may be unnecessary delayed for the further program.
Yeah,
Right.
sure, sir.
If everybody is ready and the first, I think you may invite the first presenter.
Yes, sir. Yeah. K. Ramya.
Hey, Ramesh, it is
Sir.
5 minutes is the time for presentation, na?
Yes, sir. 5 minutes, sir. If
So
they
they are
finish,
supposed to
within
finish
15
4 and
5
a half
minutes
minutes.
only you have to ask, sir.
Put a bell.
They are supposed to finish within 4.5 minutes.
Yeah, yes.
And only half a minute is left for question.
Yes, sir. Yes, sir. I will give a ring, sir. First ring for starting, second ring warning at the 4 minutes, and final ring for finishing, sir.
Okay, that's good.
Yes. Yeah, Ramya, are you there?
Sir, Soumya, sir.
Soumya. First is Soumya. Yeah.
Yeah,
Go ahead.
Soumya. Okay. Okay.
Yes, sir, I'm done.
Share the screen.
Yes, sir. I shared that.
Share.
1 second,
Just...
sir. 1 second, sir.
Okay, right. Okay. I will put a timer. Just wait. Okay. Petrous.
Okay.
Good morning, everyone. I'm Soumya. Today's my topic for presentation is malignancy changing scenario. Laryngeal cancer, it is one of the 10 leading causes of cancer in Indian men. The association of the laryngeal cancer and tobacco smoking is well established. Most patients with laryngeal carcinomas are smokers. They present with the hoarseness of voice, difficulty in swallowing. Sometimes they present in stridor as growth is obstructs the airflow. It is uncommon in middle-aged females without any addictions. Here I'm to present a case of 37 years old female who presented with the complaints of hoarseness of voice for a duration of 6 months. There is no history of vocal abuse, no difficulty in swallowing. There is no other significant ER symptoms, no significant medical and surgical history. Family history is not contributory. Coming to the personal history, there is no addictions. We have done a video laryngoscopy. And these are the findings. We can see the exophytic growth seen over the right 2/3 of the cord, extending to the anterior measure. The mobility of the cord was normal, and the glottic chink is adequate. On neck examination, laryngeal crepitus is present, and there is no nodal enlargement. Differential diagnosis, ocal polyp, ocal nodule, chronic laryngitis, leukoplakia, ocal cord granuloma. Coming to the management, routine investigations were normal. Chest X-ray was normal. Patient taken up for direct laryngoscopy. We have done a biopsy under general anesthesia. The growth is mean consistency. It is bleeds on instrumentation. We have taken the biopsy and sent for histopathological examination. Histopathological examination revealed it as a keratinizing squamous carcinoma of the right two vocal cord. We have sent the patient for radiotherapy, and we have followed up for a period of 1 year, and there was no recurrence. Glottic carcinomas, they are defined as a malignancy involving the two cords, anterior commissure and posterior commissure. Squamous cell carcinomas is the most common malignant lesions affecting the vocal cords. Earliest presentation is hoarseness of voice. In this case, female patient who is a non-smoker, whose presentation is like a benign lesion, but a histopathological examination revealed it as a malignancy. Nowadays, in every case, malignancy is to be entertained as a differential diagnosis irrespective of age, sex, habits, and presentation. Studies conducted to identify important risk factors of laryngeal carcinoma are very limited, especially on diet and indoor air pollution. Hence, more researchers are required for identifying the etiological factors and development of scientifically sound laryngeal cancer prevention programs. Thank you.
So, Dr. Soumya, what do you attribute for the cause, probable cause? Any history of passive smoking is there? Any family of...
Yes, sir. Passive smoking was there, sir.
Do you think it is one of the possibilities? Even though
Maybe.
a female patient?
Maybe, sir.
What is verrucous carcinoma?
White patchy lesions are seen.
Pardon?
White patchy lesions are seen.
I'm asking verrucous carcinoma. Do you know anything about it?
No, sir.
Oh, good. Dr.
Soumya, you have
Sir?
sent the case for radiotherapy, isn't it?
Yes, sir.
What is the other best alternative method of therapy?
Endoscopic carbon dioxide laser excision, sir.
Yes, CO2 laser excision. Yeah.
Yes, sir.
What stage is it?
T1A and N0 stage, sir.
Good.
B. Vaishnavi.
Okay.
Okay, thank you, sir.
Thank you.
B. Vaishnavi.
Yes, sir. I'm present, sir. Good morning, everyone. I'm going to present a rare presentation of salivary duct carcinoma of the hard palate. A 50-year-old female patient 50-year-old female patient who is a BD worker came with a chief complaint of swelling in the roof of oral cavity for 3 months, and it was associated with dull aching pain and loose tooth. There was history of weight loss and loss of appetite. There was no bleeding, no difficulty in swallowing, no difficulty in opening mouth, and there is no history of exposure to radiation and no addictions. On examination, a patient is thin built, and on inspection of oral cavity, there is a single smooth sessile oval shaped mass of approximately 5 centimeters in length and 3 centimeters in width on the right side of oral cavity, seen on the posterior part of hard palate extending onto the soft palate. On palpation, it is firm, non-tender, and sensation over the swelling were intact. On palpation of the teeth, there is a mobile upper molar tooth, and there are no cervical lymphadenopathy. And examination of ear and nose are normal. We have investigated a case on diagnostic nasal endoscopy, no abnormality visualized. On FNAC, They were oval cells arranged in acinar pattern, which showed a possibility of salivary gland adenocarcinoma. And CT paranasal sinuses was done, where it showed a soft tissue mass involving the right side of hard palate, extending into the floor of right maxillary sinus. So based on the extension, inferior maxillectomy is done under general anesthesia, a transoral approach, where a right side of hard palate along with the mass and right side alveolar process along with the tooth are removed, and the specimen is sent for histopathological examination, where it showed a morula-like clusters features with fibrovascular intervening cores, which showed a possibility of salivary duct carcinoma, but it was not confirmatory. And margins of the specimen were free from the tumor cells. So immunohistochemistry was done, where it showed a possibility, where it showed positivity for cytokeratin C7 and androgen receptor, which confirmed the diagnosis. So the carcinoma has arisen from the minor salivary gland. Even though they are minor, they do contain ducts. So this carcinoma has arisen from the intraductal epithelium of the minor salivary gland. So coming to discussion, this carcinoma accounts for less than 2% of all salivary glands. It most commonly occurs in major salivary glands. Its occurrence in minor glands is very rare, and it is a highly malignant aggressive tumor where it infiltrates the surrounding tissue very early. Its peak incidence is 6th to 7th decade with male preponderance, and the widely accepted risk factor for salivary gland tumors is irradiation, but its cause in hard palate malignancy is questionable. So, because of its aggressive nature, surgery is by radical resection with 1 centimeter margin, with adjunctive chemoradiotherapy depending on the histopathological findings like margin positivity, nodal positivity, or perineural invasion. So, after the excision, the palate has to be reconstructed. In mostly malignant cases, obturators are preferred, and in benign cases, flaps are preferred to achieve a maximum functional outcome. So recently, trastuzumab therapy has been tried with promising results, which is a monoclonal antibody against the ERW2 receptor, which is expressed in the tumor cells. And the lymph node mets in minor salivary glands is less compared to major salivary glands with favorable diagnosis. So here I conclude that it is a rare salivary duct carcinoma is a rare aggressive malignancy, which if thoroughly evaluated and diagnosed early, can be treated with a favorable diagnosis. These are my references. Thank you.
See, what is your differential diagnosis in this particular case?
Sir, it starts from an inflammatory lesion, but here signs of inflammation and infection are absent. It could be any odontogenic or non-odontogenic tumors, but its consistency will be soft, but here it is firm in consistency. Or it can be any malignant tumors like pleomorphic adenoma, lymphoma, hemangioma, which are differentiated based on fine needle aspiration cytology, or it can be any malignancy. Other malignancies.
What is the commonest malignant tumor of minor salivary glands that is reported in the literature?
Yes, sir. It is a pleomorphic adenoma, sir.
Malignant, I am asking.
Malignant adenoid cystic carcinoma followed by mucoepidermoid cancer.
Yeah. Which is more aggressive between these two?
Adenoid cystic carcinoma, sir, because it has perineural. Mucoepidermoid carcinoma.
Yeah.
Yes, sir.
Basically, what is the treatment of all the malignant lesions of the salivary?
It is excision, sir, followed by radiotherapy.
Did you do the radiotherapy for this case as a sandwich treatment?
Actually, the margins of the specimen were free from tumor cells, sir. So radiotherapy was not advised.
What was the time interval between the operation and now? How many months passed?
It's just 1.5 months, sir.
Prognosis in this case.
Dr. Alina Khan.
Thank you.
Alina Khan.
Yes, sir.
Good morning, sir.
Share your screen.
Go ahead.
Yes, sir.
Go ahead. Please go ahead.
Yes, sir, just 1 minute. Shall I start, sir?
Yeah.
Yeah, sir.
Respected, I'm Dr. Khan, post ENT. Today, my topic is an presentation neuralgia, whether it's ENT doctor cephalgia, a sixth department of ENT with complaint of perception of foul smell in the left nostril since 4 years. The characteristic of the smell was rotten. The smell was constantly present in varying degrees, and occasionally it was associated with discharge, which was as little as a drop of water consistency in the left nostril, and this aggravated the smell. She developed the same complaints in her right nostril for a duration of 1 month. She was able to perceive real-time odors. For the above complaints, she was prescribed antibiotics on occasion. No complaint of which dilating type, bifrontal, 2 to 3 per week. Aggravated months, the headaches intensified, became hollow, causing heavy the head and making her unable to focus on work and also making her nauseous. For the past 4 months, she further stated bursting seconds to minutes, aggravated by touching of the face and no relieving factors. No complaints of frequent URTIs. No similar complaints in the past. She is hypertensive, hyperthyroid, and taking her medications regularly. Family history, personal history, general examination, nothing extraordinary. Systemic examination, CNS, higher functions intact, examination of motor, sensory, and cranial nerves, normal. ENT examination, ears on examination were normal, throat normal, no signs of postnasal discharge, oral cavity was normal. Nose was left on anterior rhinoscopy, left-sided deviated nasal septum was seen with the right inferior turbinate hypertrophy, and left-sided frontal sinus tenderness on palpation. Our differential diagnoses here are sinusitis, trigeminal neuralgia, migraine. Investigations were done, blood work was normal, except she was deficient in vitamin D. Diagnostic nasal endoscopy confirmed the anterior rhinoscopy findings. CTPNS suggested minimal mucosal thickenings in the left frontal and ethmoid sinuses and mild deviated nasal septum towards left side and right inferior turbinate hypertrophy. MRI brain, which was written by the neurology department with focus on trigeminal nerve, suggested superior cerebellar arteries causing indentation over the trigeminal nerves on both sides. This is CTPNS film, axial view, coronal, MRI brain films. This is a zoomed out image showing the neurovascular conflict. She managed a course of antibiotics and decongestant antihistaminic combination and weekly dose of vitamin D3 capsule. And by the neurology department, a 30-day treatment of carbazepine and gabapentin. Trigeminal neuralgia is a word encompassing varied presentations, and sometimes, such like in this case, the presenting complaints were of ENT side. The precise relation between trigeminal and olfactory system is still under a fog, but nonetheless, it has been considered. Generally, trigeminal neuralgia is characterized with spontaneous paresthesias of the face, which is triggered as simple as by a tactile stimulation. Headaches in trigeminal neuralgia is also a very common feature. Our main purpose was now to relate odor disorders and trigeminal neuralgia, and were intrigued on finding articles which I've referenced in the end, dealing with this rare relation of phantosmia and trigeminal autonomic cephalgias. These are the few of the treatments like oxymetazoline drops, saline nasal drops, cocaine hydrochloride drops, and also surgical approach like excision or excision of the olfactory epithelium. It has been a month now and the patient is substantially relieved of her complaints and has been asked to continue carbazepine. And we have advised her to use intranasal saline drops now and then in MECA position. So this paper report is an artificial by considering trigeminal autonomic cephalgia. Thank you so much, sir.
Did you get the dental opinion as well?
Sir, we usually when we send to dental examination for trigeminal neuralgia to neurology, we direct neurology.
So dental evaluation is not done.
Okay. Okay.
Dr. Aisha Tasneem.
Yes, sir, I'm here.
Aisha Tabassum?
Aisha Tasneem, sir, I'm here.
Yeah. Tasneem.
Aisha Tasneem.
Yeah. Go ahead.
1 second, sir. Is my screen visible, sir?
Yes, yes.
Yeah.
As they all say, the art of possibilities is not just by keeping your eyes open, but keeping your mind open. A very good morning to one and all present here. This is Dr. Aisha Tasneem, presenting you a rare case of capillary hemangioma on nasopharyngeal side of the soft palate. Let's start with a small introduction first. Hemangiomas, as we all know, are benign tumors of vascular origin, and they're classified into capillary, cavernous, and mixed types. Generally, 60 to 70% of the hemangiomas constitute location in head and neck. But out of this, the oral cavity remains an uncommon site. Among the oral cavity sites also, head and neck, hard palate and soft palate are relatively rare locations of the hemangiomas. The prevalence of females and younger children and infants is more in hemangiomas. The present case is of importance in view of involvement of nasopharyngeal side of soft palate, which is an extremely rare site, and the presentation in an adolescent male. So our patient was a 15-year-old male patient who visited our OP with complaints of bleeding from the left nasal cavity since 2 years, which was multiple intermittent episodes of spontaneous profuse bleeding associated with clots of blood, which was aggravated with bouts of sneezing and used to relieve with conservative management. The patient also had history of mouth breathing and snoring and history of left-sided nasal obstruction as well. No other comorbidities were present in the patient. So on examination, the oral cavity examination and anterior rhinoscopic examination were absolutely unremarkable. Whereas on diagnostic nasal endoscopy, we could see this single grayish-pink polypoidal pedunculated mass arising from the soft palate mucosa over the nasopharynx area, projecting upwards into the nasopharynx, and the major portion was occupying the left corner, whereas a minor portion was occupying the right corner. On probing and pushing the tumor a little backwards, we could see multiple polypoidal masses arising from the same stalk. And this was the stalk of the tumor mass. We did all the routine lab tests and all were unremarkable except for prothrombin time elevation. On CT scan, we could see the soft tissue density lesion, which was pedunculated and projecting into the nasopharynx and with a very with narrowing of the airway. These are the CT scans showing the same. We took the patient for endoscopic excision with cauterization of the base under general anesthesia, and this was the specimen. This was the major part which was extending into the left corner, and this was the stalk. And the specimen was sent for histopathology. On histopathology, we could see that the specimen was lined by stratified squamous epithelium, and the subepithelium showed numerous dilated blood vessels lined by single layer of endothelial cells. Hence, a diagnosis of capillary hemangioma was confirmed. The follow-up of the patient was, after 6 months, showed no recurrence. Finally, I would like to discuss a few points. Capillary hemangiomas are often sessile or pedunculated, soft, smooth, or irregular, and bulbous in outline, are painless unless traumatized. Hemangiomas affecting the palatal mucosa, if present, are solely of capillary type. Management, as in our case, is simple excision and cauterization of the base, and there are other modalities of management. I would like to conclude by saying that although hemangiomas are frequently observed in head and neck region, the soft palate is still considered an infrequent locus among other head and neck surfaces. In addition, instances of hemangiomas in male are very rare in literature. Till date, only one case of soft palate hemangioma has been reported in literature. These are my references. Thank you.
Last minute.
What do you think of other diagnoses?
Doctor, what is your differential diagnosis? Before histopathology, what are the things that come to your mind?
Lymphangioma, hemangioma was one of our differential diagnoses, sir. And any other minor salivary gland?
Before. Along with hemangioma, what other important things? Because lymphangioma is somewhat rare. It doesn't look like lymphangioma. See, you have put the diagnostic nasal endoscopy picture. As per that picture, there are 2 or 3 things that immediately strike your mind. What is it?
Sir. Actually, by going by the patient's age, adolescent male presenting with profuse unprovoked epistasis, we suspected angiofibroma, sir. But the origin of the tumor was not contributory to that. And
any other thing? Angiofibroma doesn't look. Angiofibroma doesn't arise like a stalk-like elevation from the soft palate. It can never arise like that. What other things? Very common thing. One of the common things.
Polypoidal tissue.
Polyp doesn't arise. No, polyp is from the antrum or ethmoid or maxillary or whatever it is. So soft palate is clearly you are showing there is elevated, pedunculated lesion from the palate.
Yes, sir.
So what are the other lesions that most commonly look like that?
Papilloma.
Rhinosporidiosis.
Yes,
Rhinosporidiosis.
Sir. Yes, sir. But
Rhinosporidiosis is a very common thing.
is more common on the anterior.
The more preferred site is the nasopharynx and palate.
Okay.
Right?
Yes.
Then hemangiopericytoma, lymphangioma, then granular lesions, tubercular granular lesions, they look like that.
Yes.
Okay. And some things like hematohidrosis, nasopharynx, then some infective lesions, so on and so forth. Okay, and you have done complete excision, and see what is the recurrence rate? What is the recurrence rate like in hemangiopericytomas?
Hemangiomas generally after excision, the recurrence rate is low, sir. But in case recurrence occurs, also it depends on the based on the articles. It depends on the procedure advice, sir.
So hemangiomas, hemangiopericytoma, there are different varieties, isn't it? Benign, intermediary, and then malignant.
Yes.
Right?
Yes, sir.
So in malignancy, in malignant variety, the recurrence rate is quite high. Okay, fine.
Dr.
Nice
M.
presentation.
Ravikiran.
Thank you, sir.
Dr. M. Ravikiran.
Ravikiran.
Yeah.
Sir, can you see my screen, sir?
Yeah. We can see you, your screen, everything. Go ahead.
Yes, sir. Thank you. Good morning, everyone. I am going to discuss a case of lipoma of neck. Lipomas are benign, slow-growing tumors of adipose tissue, and 13% of lipomas occur in neck, and majority of them are in posterior neck. Most of them are asymptomatic and below 5 centimeters. The commonest symptom is a slow-growing and painless swelling in the neck. They can sometimes grow close to vital structures in the neck, like carotid sheath, and compressing the jugular vein and carotid artery. The patient, a 35-year-old female patient, came with the chief complaint of swelling in the neck since 1 year, and the patient was apparently asymptomatic 1 year back. Then she noticed a swelling, which was insidious in onset and gradually progressive. There were no aggravating or relieving factors, and it was not associated with difficulty in swallowing or breathing, and no sudden increase in size, pain or fever, and no history of change of voice, foreign body sensation, throat, and no history of upper respiratory infection, cough or postnasal drip. The past history was not significant, and personal history was normal. She had no drug allergies or addictions, and the general examination was normal. On clinical examination inspection, it was a 5 into 3 centimeter swelling on the left side of neck, horizontally extending from 2 centimeters away from the midline to under the sternocleidomastoid laterally, and vertically from 1.5 centimeter below the hyoid bone and 0.5 centimeter above the medial end of clavicle, left clavicle below. And the skin over the swelling was normal. There were no pulsations, engorged veins, or scars. On palpation, inspector findings confirmed no tenderness or local rise of temperature. It was a soft swelling and freely mobile with ill-defined margins. Skin over the swelling was pinchable and swelling was slightly prominent on left sternocleidomastoid. Sorry?
How to share the screen?
And there is no audible breathing on auscultation.
Join with video, no?
Investigation. Ultrasound neck was indicative of lipoma extending from sternomastoid on left till strap muscles anteriorly. FNAC was suggestive of benign lipomatous lesion, and CT scan showed a well-defined encapsulated homogeneous hypodense lesion of fat attenuation of 6 into 4.1 into 2.5 centimeter size, and is noted in intermuscular plane in the anterior aspect of neck on the left side, likely a lipoma. And in CT scan images, these are the CT scan neck, which shows fat attenuating lesion, and this is the sagittal section, and the provisional diagnosis of lipoma of neck was diagnosed, and excision under general anesthesia was planned. The excision was done under general anesthesia, and the medial surface of the swelling was related to carotid sheath, and a careful dissection was performed at this point to avoid trauma to the great vessels. There were no adhesions of swelling with the surrounding tissue. The procedure was uneventful. The wound was closed on a drain, and the patient was put on antibiotics and analgesics. And the drain was removed after 3 days, and patient was discharged to review after 1 week for suture removal. Discussion. Lipomas of neck are rare, usually less than 5 centimeter. In this case, the lipoma was 6 into 4.1 into 2.5 centimeter over left carotid sheath, although asymptomatic, had complaints of visible swelling in the neck. The swelling should be differentiated from branchial cyst and lymphadenopathy and schwannomas due to its location. The preoperative FNAC will help in diagnosis and counseling, and extreme care is necessary while dissecting swelling over carotid sheath. Conclusion. A complete excision of lipoma with intact capsule prevents recurrence, and usually there is no cosmetic or functional morbidity. The location warrants handling while close to vital structures. Preoperative CT will help understand clear anatomy and close relation to avoid damage to them. A good knowledge of neck anatomy is needed to avoid damage to brachial plexus, carotid space, which has carotid artery, vagus nerve, and internal jugular vein. Thank you.
Lipomas can arise anywhere in the body. And second thing is, what is Refsum's disease? Any idea?
I don't know.
Okay, multiple lipomatosis, and it causes pressure on the nerve endings. You will get a pain as well, right?
Yes, yes.
But in the neck, rightly pointed out, it is a brachial cyst to be concerned, and strictly speaking, anatomy of the neck is mandatory, and definitely it needs a good amount of anatomical knowledge is needed. Thank you.
Dr. P. Sharada.
Sir.
Okay. Start.
Sir, good morning, sir, respected judges and my teachers. Today, I'm going to present a case report of capillary hemangioma of nasal septum. Capillary hemangioma is a benign, rapidly growing lesion of skin and mucous membranes. It usually involves gingiva, lips, tongue, and buccal mucosa. Nasal cavity is a rare location. In the nasal cavity, anterior septum is the most frequently affected part, followed by turbinate, but it has also been described in maxillary sinus, roof of nasal cavity, and floor of the nasal vestibule. We report a 14-year-old boy presented with left-sided nasal obstruction and mass in the left nasal cavity since 1 month. He gives history of 2 episodes of epistaxis. There was no history of trauma to the nose, nasal discharge, or allergic symptoms. No external nasal deformity was seen. On anterior rhinoscopy, a reddish mass was seen in the left nasal cavity arising from the anterior nasal septum. There was no active bleeding. Posterior rhinoscopy was normal. An endoscopic examination confirmed a mass arising from the anterior part of the nasal septum in the left nasal cavity. Routine blood investigations were in normal limits. CT scan revealed a well-defined soft tissue density lesion in the anterior aspect of the left nasal cavity from the cartilaginous part of the nasal septum, suggestive of hemangioma. So provisional diagnosis was capillary hemangioma of the nasal septum. This is the anterior rhinoscopy picture showing a mass arising from the nasal septum, and CT scan showing mass arising from the left side of the nasal septum. We surgically excised the mass under general anesthesia and subjected to histopathological examination. Histopathology showed multiple lobules of small blood vessels lined with plump endothelial cells and focal fibrosis, and thick muscular blood vessels in the central stroma, suggestive of capillary hemangioma. So capillary hemangiomas are benign tumors that originate from the vascular tissues of the skin, mucosa, bone, muscles, and glands. So in nasal cavity and paranasal sinuses, it is uncommon. Mostly in the nasal cavity, it arises from the septum. Trauma, hormonal influences, viral oncogenes, microscopic AV malformations, and production of angiogenic growth factors, cytogenetic abnormalities are postulated to play a role in the etiology. It most commonly occurs in the 3rd decade, but it is rare in children. Epistaxis and nasal obstruction are most common symptoms, and it can be pedunculated or wide-based. It most commonly arises from the anterior part of the nasal septum, that is Ritter's area or Kesselbach's triangle. And differential diagnosis, it should be differentiated from rhinosporidiosis, granulation tissue, vascular polyps, and angiofibroma. The treatment of choice is complete surgical excision. The use of CT scan can give a diagnosis without reporting to the biopsy, and the use of nasal endoscope both for diagnosis as well as surgery is the preferred method of treatment. Histologically, it is characterized by submucosal vascular proliferation arranged in lobules or clusters composed of central capillaries and smaller ramifying tributaries. So in conclusion, this is uncommon lesion should be considered as a differential diagnosis in all endonasal masses with bleeding. This case is reported for its potential for being misdiagnosed and highlight the advantage of nasal endoscopes in diagnosis and treatment. So these are my references, sir. Thank you, sir.
Have you done only excision or have you done anything further more after excision of the mass?
Only excision, sir. And we followed up the case for 6 months, sir. There was no recurrence.
Have you done cauterization of the base of the mass?
Sir, base of the mass was cauterized, sir.
That's what you have not mentioned. That's why I'm asking.
Okay, sir.
Desirably, you need to take a cuff of the perichondrium that is more needed. Right?
Yes, sir. Wide excision up to the perichondrium to prevent recurrence.
Yes.
Sir, Vadhuvan Simhadri.
Simhadri.
Hello, you can start.
Sir, good morning, sir. Today I'm going to present a rare case of Ewing sarcoma of the soft palate. So Ewing sarcoma is a small round blue cell mass. It most commonly arises in the skeleton of the adolescent and young adults. Extraskeletal Ewing sarcoma arises in the soft palate rather than in the bone. Extraskeletal Ewing sarcoma shares histological, immunohistochemical, molecular findings with the bone Ewing sarcoma. It occurs in the chest wall and paravertebral region and is rare in head and neck regions. A 47-year-old male patient came to ENT OPD with chief complaints of painless swelling over the soft palate since 2 years. It is incidence in onset and gradually progressive. There is history of weight loss. Patient was chronic smoker since 10 years, 10 cigarettes per day. No history of hoarseness voice, fever, and chronic cough. There is no significant past and family history. Local examination, throat, lips, gums, teeth, buccal mucosa were nicotine stained. A smooth globular mass measuring 5 by 7 centimeters seen arising from the soft palate. Ear and nose examination was normal. There were no palpable neck nodes. Systemic examination revealed no specific abnormality. So here we can see a large smooth globular mass arising from the soft palate. On H&D staining, we can see small to oval round cells which are with a fine powdery chromatin. So investigations, routine blood examination was done, X-ray, paranasal sciences, CT, head and neck showed a large lobulated heterogeneously enhancing mass lesion arising from the oral surface of the soft palate. Biopsy was taken and sent for the histopathological examination and immunohistochemistry. Light microscopy of the tumor showed closely packed small round cells with abundant thin-walled vessels. Most of the tumor cells have scanty cytoplasm with round or oval nuclei with fine powdery chromatin. So immunohistochemistry, tumor cells were positive for CD99, MIC2 and vimentin. They were negative for leukocyte common antigen, pancytokeratin, cytokeratin 7, neuron-specific inoles, chromogranin, synaptophysin, smooth muscle actin, and S-standard protein. CD99 MSC2 stain exhibited strong membranous staining. Histopathological examination and immunohistochemistry reports were consistent with diagnosis of Ewing sarcoma. The differential diagnosis include pleomorphic adenoma, malignant minor salivary gland tumors, neurogenic tumors, lymphoma, rhabdomyosarcoma, poorly differentiated synovial sarcoma. So treatment is surgical resection followed by multi-agent chemotherapy with ifosfamide, cisplatin, etoposide combined with 6,800 centigrade of radiotherapy for the treatment modalities planned for this case. Discussion. Ewing sarcoma was described by James Ewing in 1921 as a diffuse endothelioma. There has been remarkable evolution in the concepts regarding its histiogenesis and relation with other small round cell tumors, including the primitive neuroectodermal tumors. Schmidt suggested that a tumor was designated a primitive neuroectodermal tumor if it has homocyte rosettes on light microscopy or co-expressed two or more neural markers by immunohistochemistry. So in our case, the tumors showed no rosettes and were negative on immunohistochemistry for neuron-specific inoles, S-standard protein, chromogranin, and synaptophysin. Tumor cells only showed positive staining for CD99, MIC, and vimentin. So current case could exclude the possibility of other small round cell tumors by negative immunoreactivities for leukocyte common antigen, desmin, and cytokeratin. Although exact etiology remains unknown, more than 95% of the Ewing sarcoma pinnate tumors show the characteristic translocation of T1122 with Q24, Q12, or the variant of T21, 22, and Q22, Q12. Various therapeutic modalities have been developed for the treatment. Early and the confident diagnosis coupled with modern chemotherapy and radiotherapy has greatly improved the prognosis of the Ewing sarcoma pinnate tumors. The following are my references.
Okay.
It's quite rare.
Very rare. Hello?
Sir.
Ewing's is quite rare because I am coming across for the first time in almost more than 35 years. So if such lesion of the palate, which is very large and very fast growing, what are the most common things that come to your mind?
Minor malignant salivary tumor, sir.
Yes, minor salivary gland tumor, malignant minor salivary gland tumors, number 1. Number 2?
Pleomorphic adenoma, sir.
RMS. Rhabdomyosarcoma.
Rhabdomyosarcoma.
Yeah. Lymphomas, very fast growing.
Yes, sir.
They are the very common things which we have seen many cases.
Yes, sir.
Okay. Right. Good presentation. Nice presentation.
Thanks.
Sir, a note for judges, sir.
Yes.
8th and 10th are repeated, sir. K. Ramya.
Yeah, it is repeated. Twice. Its name is twice there.
Is she presenting 2 cases?
Yes, sir. No, sir. No, sir. Single one. You can present marks to only 8th number, sir. K. Ramya.
Okay. 8th number. 9th number is Ashwini.
8th number.
Yes. 8th and 9th repeated, sir, number.
10 to the can.
Just strike out one number, sir. 10th number you strike out, sir.
Ramesh, see the 8th and 10th K. Ramya. Which should we take?
Yes,
10th will delete.
Yeah, 10th you strike out, sir.
10th you strike out. Okay.
Yes, sir.
2 Ramyas.
Yes.
Now she is number 8.
Yes, sir. She is number 8. K. Ramya, you can share your screen.
I thought they are twin Ramyas.
Yeah.
Screen share.
Okay, sir. Good morning, sir.
Yes.
Today I am going to present pleomorphic.
Enlarge it.
Okay.
Ramya, start your slides.
Okay. Sir, today I am going to present pleomorphic adenoma of the submandibular gland. Sir, am I audible, sir?
Yes, fine. Go ahead.
Okay. Okay. Introduction. Pleomorphic adenoma is the most common tumor of the salivary gland, sir. It accounts for 60% of all salivary gland tumors. It is often called a mixed tumor because it consists of both epithelial and mesenchymal elements. Majority of these tumors are found in the parotid gland with less than lingual and minor salivary glands. We present a rare peak adenoma presented to our institute. A 30-year-old female patient gradually progressive to present size. It is painless without any pressure symptoms like difficulty in breathing, difficulty in deglutition, no history of loss of appetite and loss of weight. On local examination, inspectory finding, swelling was present over the left submandibular region, approximately 3 by 3 centimeters. Skin over the swelling was normal. No visible pulsations and ulcers over the swelling. Swelling was non-tender, non-compressible, non-pulsatile, firm in consistency, and no local rise of temperature. Swelling was palatable on bidigital palpation, and the trans-elimination test is negative. In investigations, blood investigations are normal. In USG neck, well circumscribed rounded mass, hypoechogenic, ultrasound about 3.5 by 3 centimeters. Rest of the structure were normal. In CT scan, heterogeneous with less prominent enhancement and foci of necrosis and delayed enhancement with small regions of and well circumscribed rounded mass, hypoechogenic and T2W. About 3.5 by 3 centimeter in submandibular space in axial plane, and the rest of the structures were normal. In the FNAC of submandibular gland, cells composed of epithelial cells and myoepithelial cells and chondromyxoid stroma. In MRI shows bright and T2W1 with homogeneous enhancement. In T1W1 usually low intensity in the plane of axial. In differential diagnosis, Warthin's tumor, myoepithelioma, mucoepidermoid carcinoma, adenoid cystic carcinoma, sialadenitis, and lymphadenoma. In management, surgical excision of the gland was done and the mass was sent for histopathological examination. Here we can see horizontal incision is given 2 centimeters below the mandible, and we have to secure the hypoglossal nerve, lingual nerve, and mandibular nerve. And here we can see facial artery and facial vein are ligated, and the gland was taken out. In histopathology, in microscopy showed parenchymatous glandular cells along with myoepithelial components with a variable amount of mucoid stroma and hyaline in background. In discussion, salivary gland tumors comprise only 1 to 4% of head and neck tumors and most commonly affected periosteum. In pleomorphic adenoma is the most common benign salivary gland tumor and is characterized by proliferation of epithelial and myoepithelial cells and increase in the stromal components. In pleomorphic adenoma is more common in parotid gland and less common in the submandibular gland, and its occurrence in submandibular and sublingual gland is uncommon. Although generally benign, the pleomorphic adenoma must be removed to eliminate the chances of infection and carcinoma and for cosmetic reasons. Recurrence are rare with the complete en bloc excision of the tumor, and prognosis was excellent. In conclusion, workup of a patient of swelling in submandibular region include detailed history, clinical examination, and relevant investigation to rule out the underlying pathology. Surgery is indicated when the swelling is progressive in size and cosmetic region, and when underlying malignancy is suspected. The aim of surgery is to arrest the disease and propagation. And pathological findings is severe malignant.
How did you take care of preserving the marginal mandibular nerve? Are you able to hear me? There is some distortion of the
voice.
Yeah.
Hello.
Hello.
Ramya.
Hello, Dr. Ramya?
She's off the line.
Yeah, she's off the line.
Okay, okay. Next presenter.
Okay. Dr. Ashwini. Dr. Ashwini, KMD. Hello, Dr. Ashwini.
Is he present?
Dr. Ashwini, are you there?
Not able to join, it seems.
Well, you'll go to
Hello,
next.
sir.
Are you there?
Okay, okay.
Yeah.
Ramesh, whom you are calling?
Sir.
Who is next?
Committee present or not?
Hello, Dr. Ashwini, are you there?
Yeah. So next candidate, sir. He will present up later.
No, Ramesh, I think she is there. She was. I could hear us, but somehow.
Yeah, she is in the line only, sir. Participant area.
She's there, but not visible. She just joined and missed line.
We'll call next person by the time she comes back. She may present later.
Okay.
Dr. Humaira Fatima.
Yes, sir, I'm here.
Yeah.
Humaira.
You can start.
Sir,
Humaira now.
Humaira, 11
sir,
number.
am I audible?
Yes.
Yeah, you are
Yes, yes. Go ahead, Humaira.
Okay, sir.
Just start skating your screen.
Yes, sir. 1 minute, sir.
Okay. Once Ashwini comes back, I think we can take her.
Yeah.
Yes, sir. I will speak, sir. Enlarge your screen. Yeah. can start.
Good morning, respected teachers. My topic for today is thyroglossal duct cyst of the suprahyoid region. Introduction: the thyroglossal duct cyst is a swelling which occur in the neck in the part along the thyroglossal tract. It is usually congenital and occur due to the failure of the obliteration of the tract. The most possible sites are beneath the foramen cecum, in the floor of the mouth, suprahyoid region, at the level of the hyoid bone, and the commonest site, and infrahyoid. Case history: a 17-year-old male came with the chief complaint of swelling over the neck just below the chin since childhood. Swelling gradually increased to present size about 3 by 2 cm, associated with pain of recent onset. There was no history of any hypothyroid or hyperthyroid symptoms. There was no history of draining sinus of fistula, no other swelling in the body, with no previous history of surgeries or any trauma. On examination, inspection, the swelling was situated in the midline of the neck, about 3 by 2 cm in size. The swelling moved with deglutition as well as with protrusion of tongue. It was non-pulsatile, no dilated neck veins were seen, skin over the swelling was normal. On palpation, all the inspective findings were confirmed. The swelling was smooth, soft, fluctuant, non-tender, and transluminate with no local raise of temperature. The trachea was centrally placed and thyroid gland was palpated in its anatomical position. There was no palpable lymphadenopathy. Ear, nose, and throat examination was normal. Potential diagnoses include ectopic thyroid, dermoid cyst, brachial cyst, and submental lymph node. Investigation: blood test and thyroid profile was normal. Ultrasound note showed a well-defined hypoechoic lesion measuring in the suprahyoid region with few areas of floating, with few cystic areas and floating echoes, and both the lobes of thyroid gland was normal, suggestive of infected thyroglode duct cyst. FNEC showed mucous background with foam cells, neutrophils, few lymphocytes, and follicular epithelial cells. There was no cytomorphic evidence of malignancy. Possibility of infective thyroglossal duct cyst. MRI showed cystic mass in the suprahyoid region. It was high signal intensity on both T1 and T2 images. There was no cyst wall enhancement. And thyroid glands was normal in size and position, suggestive of infective thyroglossal duct cyst. Management: the patient was planned for system operation and general anesthesia. Cyst and a tract up to the foramen cecum was removed along with the central part of the hyoid bone. And the mass was sent for histopathological examination. The cyst was lined by a ciliated columnar epithelium with lymphocytes and foam cells. There was no atypia, suggestive of infective thyroglossal duct cyst. Discussion: the thyroid gland developed from the downgrowth of the cells from the ventral diverticulum of the endoderm between the first and second pharyngeal pouches at the foramen cecum. As the diverticulum descends from the base of the tongue to its normal position. After the descent, the tract has to degenerate. If it persists, it may lead to the thyroglossal duct cyst.
Depending on the position of the incident, go ahead.
Normally that although generally it is benign, if the patient has symptoms, the duct has to get the cyst has to be removed to prevent of infection or to development of the carcinoma or for cosmetic reasons. Conclusion: thyroglossal duct cyst in suprahyoid region is less common. Most common presentation will be a painless swelling, and the cyst will move with both swallowing and also with the tongue protrusion. If infected, the mass will be tender and there may be a draining pus. Investigations include thyroid profile, USG neck, FNAC, and MRI. Cyst trunk operation is done in which a central part of the hyoid bone is removed to decrease the chances of recurrence. These are my references, sir. Thank you.
Did you comment on the protrusion of the tongue test?
Yes, sir. The tongue, the swelling moved with both the protrusion of tongue and with deglutition, sir.
So you are already ruled out the possibility of the malignancy.
Yes, sir.
Thank you.
Hello. Next.
Go back to Ashwini.
Ashwini, I think system problem unnadu, sir.
Ashwini is back. Ashwini is back, I think. No?
But system problem unnadu, sir. Call చేశారు ఇప్పుడే. ప్రశాంత్ తర్వాత తీసుకుంటా అన్నారు, సార్.
Okay. Right, sure. Go ahead.
Go with Prashant, sir.
Morning, sir. Am I audible, sir?
Yes.
Yeah. You can
yes.
Good morning, my teachers and respected seniors. Today, my case report presentation is about inverted papilloma, a benign tumor of sinonasal cavity. Coming to introduction, tumors of sinonasal cavity are considered to be rare entities. Inverted papilloma is included in the group of sinonasal papillomas, and it is considered as the second most common benign tumor of sinonasal tract after osteoma. Its incidence is around 0.6 cases per lakh population annually, and it accounts to 0.5 to 4% of all the primary nasal tumors. The tumor is well known for its invasiveness, tendency to recur, and association with malignancy. We are presenting a case of inverted papilloma presented to our institute. A 51-year-old male patient presented with a history of unilateral left-sided nasal obstruction since 1 year, which was insidious in onset and gradually progressive, continuous, temporarily on medication, and is associated with nasal discharge, which was mucoid and continuous. It is also associated with headache, temporal type, and hypospema was present. There was no history of epistaxis, foul breath, fever, facial heaviness, mouth breathing, crust formation, and any kind of allergy. He had a history of BD smoking since 30 years. On examination, anterior rhinoscopy revealed right-sided deviated nasal septum and pinkish mass was seen in the left nasal cavity. Ear and oral cavity examination were normal, and nasal endoscopy revealed pink polypoid mass, papillary in appearance, protruding from the left meatus. It was covering the whole of the left nasal cavity and blocking the left choana as visualized from the opposite choana. On probe test, probe cannot be passed along the lateral wall of the nose, and the mass was insensitive to touch and was not bleeding on touch. Differential diagnosis being sinonasal polyps, squamous papilloma, rhinosporidiosis, schwannoma, hemangiomas, hypertrophic turbinates, esthesioneuroblastoma, non-keratizing respiratory epithelial carcinoma. To investigate, we started with blood reports which were normal. Preoperative biopsy was done, which was suggestive of sinonasal papilloma, inverted type. CTPNS was underwent and was to see the extent of the lesion and to rule out the involvement of the adjacent structures. Here, the left maxillary sinus was totally occupied by the lesion, and the osteometal complex was widening was seen, letting the lesion into the left nasal cavity, occupying the whole of the left nasal cavity, as seen here. Patient was surgically managed with left medial maxillectomy, lateral rhinostomy approach under general anesthesia, where we gave a Moore's incision on the left side of the nose, and soft tissue dissection was done until the pyriform aperture, exposing the maxillary bone, and the medial wall and the medial aspect of the anterior wall of the maxillary sinus was removed to enter the maxillary sinus. After entering the maxillary sinus, we could resect the lesion in toto from the sinus, nasal cavity, and along with the normal mucosa of the sinus. And the lesion was sent and the mass was sent to histopathology. In histopathology, gray-brown soft mass of size 2 into 2 centimeter was sectioned. Multiple sections were taken, which showed inverted papilloma, inverted pattern of growth with rounded ribbon-like thickened epithelium extending into the stroma. Here, the inverted pattern of the epithelium can be seen in scanner view, and this is the 40x view of the epithelium, which is suggestive of sinonasal papilloma inverted type. To discuss, inverted papilloma has many synonyms like Ringer's tumor, Schneiderian cell papilloma, and basically benign papillomas are morphologically 3 distinct benign papillomas, that is inverted papilloma, oncocytic papilloma, and fungiform papilloma. Usually it arises from the lateral nasal wall, middle meatus, often extending to the ethmoid and maxillary sinuses. The pathogenesis of the lesion remains unclear, although allergy, chronic sinusitis, and viral infections have been suggestive of possible causes. It has a rate of around 10% and a chance of malignant transformation about 3.4 to 9.4%, 9.7%. To conclude, though the inverted papilloma is rare to occur, one can suspect inverted papilloma if it is a male patient in his 5th to 6th decade of life with complaints of unilateral nasal obstruction, epistaxis, sinusitis with nasal discharge. And on examination, if a mass is seen in the nasal cavity arising from the lateral nasal wall and it at least involving one paranasal sinus, endoscopy should be done and a biopsy should be taken. CT scan is CTPN is needed and MRI can be done. To treat the case, small to moderate lesions need endoscopic resection. There are 3 types: type 1, type 2, type 3. And for large lesions, open approaches like lateral rhinostomy or midfacial degloving procedures, which increase the tumor visualization and complete resection, including maxillectomy, which will minimize the recurrence rates, are to be done. These are my references, sir. I thank all the audience for the patience, and I
thank AOI Telangana branch for giving me this opportunity. Thank you, sir.
Did you do MRI?
No, sir. The patient was not affordable, sir. So he was rejecting the gadolinium enhanced MRI, sir.
Okay. What is the classical picture in MRI?
The inverted papilloma, pattern of the epithelium can be seen in the form of lines into the stroma, sir. Just like the way histological picture, the same picture, almost the same picture is seen on the MRI.
Can you identify malignant changes in MRI?
Sir, I didn't get you.
Malignant changes in MRI.
Malignant changes? No, sir.
Some sort of convolutions will be there.
That is one of the disadvantage of MRI, sir.
That is one of the signs in MRI. We think that.
Okay. What are the viruses that are involved in inverted papilloma origin?
Meta-analysis say that human papilloma virus is involved in the causation of the inverted papilloma, sir. But serotypes 16 and 18 are strongly emphasized towards the malignancy in the inverted papilloma case, sir.
Okay.
Dr. Ashwini?
Thank you, sir.
Okay, thank you. Hello, Dr. Ashwini, are you ready?
Who is next?
Yes, sir, I'm there.
Dr. Seema?
Am I audible, sir? Yes, sir. Am I audible?
Yes, yes.
Hello?
Frequency
yes,
change.
Seema, you're audible,
Yes.
Seema. Go ahead.
Okay, sir.
Share your screen.
Good morning, everybody. I'm Dr. Seema, third year postgraduate. I'm here to present a case report on hematohidrosis, a rare phenomena of spontaneous ENT bleeds. So bleeding from ear, nose, and throat can be caused by a variety of factors such as trauma, tumor, bleeding diastasis, and which can be worked up by careful history, clinical examination, screening, laboratory studies, and systemic diagnostic testing. However, in some rare instances, such extensive workup is also inconclusive. Hematohidrosis is one such condition. We report 2 such cases of different age groups, which should raise awareness of hematohidrosis, occurrence, especially among ENT patients. Hello?
Yeah.
Yes,
go ahead.
Okay, sir.
You're audible.
Okay. So coming to our first case report, our first patient was a 3-year-old female patient who was referred from pediatric department, which complains of bleeding from eyes, ear, and nose since 2 days. It so happened that about 18 months of age, our patient first experienced multiple episodes of epistaxis during an episode of upper respiratory tract infection. Later on, at 2 years of age, she had hematemesis, on which she was found to be hypertensive and started on nifedipine. At about 2.5 years of age, she had episodes of epistaxis, hematemesis, vaginal bleeds, and bleeds from eyes and nose. Coming to the present episodes, the bleeding episodes were spontaneous and consisted of diluted blood. It lasted for few seconds to 1 minute, and there were about 4 to 6 episodes per day. It was associated with hypertension. It subsided on its own, and it had no aggravating or relieving factors. The birth and family history were pretty normal, except for the fact that the mother had pregnancy-induced hypertension in her pregnancy. General examination revealed all vitals to be normal, but except for blood pressure, which was greater than 99 percentile for that age and sex, which is 130 by 70 mm of Hg. The ENT examination was completely normal, and there was intact skin, and the tympanic membrane did not reveal any scars or bleeding points. Systemic examination was also normal. To evaluate the cause of bleeding and hypertension, the pediatric department underwent all the tests which could rule out all the differential diagnosis for bleeding and hypertension at such a young age. But yet, none of the tests showed any significant positive findings. Later on, she was referred to pediatric hematologist, where she was diagnosed as hematohidrosis with autonomic disturbances and put on propranolol and clonidine. The frequency of episodes decreased, however, it continued to occur. Our second case was 20-year-old female who presented with complaints of episode of bloody discharge from left ear. It was about 5 ml, watery in consistency, preceded by weakness in hands and legs. It lasted for a few seconds and subsided on its own without any intervention. It aggravated on stress. There was history of similar episode 1 month back. She also had history of epistaxis and hematemesis since 6 months on and off. On further interrogation, she gave history of ongoing mental stress due to personal reasons since 6 months. On examination, she was moderately built female who was slightly apprehensive. Her vitals were stable. General examination, ENT examination were completely normal. A huge variety of investigations were done for her also. Apart from the upper GI endoscopy, which revealed antral gastritis, rest all hematological evaluation, biochemical tests, and radiological workup could not reveal any positive finding. After counseling about the condition, the patient was referred to psychiatrist for psychotherapy and also hematologist. However, she was lost to follow-up. Hematohidrosis is a rare phenomena where blood is excreted with sweat upon exposure to extreme physical or emotional stress. The pathophysiology of the condition is unknown. However, it is thought to occur due to activation of the sympathetic nervous system, which causes blood vessels to rupture into the sweat glands, thus pushing it along with the sweat to the surface and presenting as droplets of blood mixed with sweat. Diagnosis is made by bloody discharge without any obvious cause through intact skin and the presence of blood component on biochemical and microscopic studies of discharge. Treatment, although the condition is very rare, but there are reports in literature of efficacious treatment with beta blockers, atropine sulfate transdermal patches, and psychotherapy and psychoanalysis. In conclusion, I would like to say that hematohidrosis is a relatively unknown condition to the otolaryngologists, and the cases are occurring sporadically, which goes unnoticed. If awareness is created about this clinical condition, which is relatively unknown entity, it will lead to further insight on the evaluation and management of this rare disease. Thank you.
What is the prognosis? It is going to stop by or long-term treatment is needed?
So presently we do not have much data on it. So what all cases I have seen in this literature, prognosis is these episodes decrease in frequency, but they do not stop completely by using beta blockers and propranolol.
Not life-threatening situation, no, because sometimes you may
treat. Yes, sir. Not life-threatening situation.
Not life-threatening.
Yes, sir. Not life-threatening situation.
But it is it's a multi-system, multi-speciality, and then it's a handiwork of nervous system. So quite rare things, but it involves a lot of workup ultimately. Very good selection of 2 cases. Yeah.
Yes, sir. So actually,
okay,
sir,
next.
Thank you, sir.
She's Dr. Ashwini, sir.
Ashwini, okay. Go back.
Ashwini?
Yes, sir.
Ashwini, no?
Okay.
Ashwini, yes, Kemedi.
Yes, sir. Sir, my topic is fibroma of palate, sir.
Share your screen.
Share your screen
okay,
title.
Sir. Okay, sir. I'm connected. Okay, sir. I'm visible, sir?
No, you are visible,
no.
But you're not your presentation.
You are visible. Screen.
Share.
Your presentation has to be visible, not you.
Presentation. Share screen.
First slide.
Yes, sir.
Yeah.
Thank you so much for your patience, sir.
Fibroma of palate. Go ahead.
Sir, my
yes.
Coming to introduction, sir. Fibroma is a hyperplastic fibrous connective tissue, sir. Responds to local irritation of masticated cells. The most common location is along the occlusion line of the buccal mucosa. Also, other locations such as tongue, labial mucosa, gingiva are possible. Coming to case report, a 66-year-old female presented with a swelling over the hardy palate since 6 months. It is insidious in onset, slowly growing, progressive in nature, and painless in nature. Now, the patient complains of difficulty in speech and swallowing. There is no history of trauma or fever. Patient is not addicted to tobacco, chewing, smoking, and alcohol. There is no family history.
On examination, there is a 3 into 3 centimeters sized pink smooth pedunculated mass seen over the left side of the hard palate. The swelling is firm in consistency, non-tender, not bleed on touch. Examination of ear, nose, laryngopharynx, neck was normal. No cervical lymphadenopathy. Lab investigations were normal. Coming to procedure. Patient underwent electrocautery excision of swelling under local anesthesia. The excised mass measured 3 into 2 centimeters, which is firm in consistency, and minimal bleeding was noted intraoperatively. Excised mass was sent for histopathological examination. It is revealed spindle cells arranged in intersecting bundles lined by stratified squamous epithelium with plexiform acanthosis consistent with fibroma. Post-operative picture. It is a post-operative picture of 1 week after electrocautery excision of swelling, and histopathological picture showing collagenous fibers and in between fibroblast cells. Microscopically, collagenous fibroma is hypocellular mixocollagenous tumor with focal desmoid-like areas and composed of haphazardly arranged reactive appearing spindle to stellate-shaped cells. And enlargement of the adjacent muscle and fat is common, but aggressive growth is not a feature of collagenous fibroma. Coming to my discussion, collagenous fibroma is also known as desmoplastic fibroblastoma, recently defined as benign fibroblastic or myofibroblastic tumor. Collagenous fibroma typically occurs in subcutaneous tissue or skeletal muscles in adults. It presents as a painless, prim, well-circumscribed mass of long-standing duration, behave in a benign fashion. There is no evidence of bone involvement except for a rare case of surface erosion. Conservative marginal excision appears to be curative and no recurrence has been reported. Coming to differential diagnosis, consider pleomorphic adenoma, pyogenic granuloma, necrotizing ciliometaplasia, granular cell tumors, desmoid fibromatosis and irritation fibroma, neurofibroma and myxoma, lipomas, and torus palatinus. In general, head and neck is one of the most frequent sites involved, but in intraoral collagenous fibroma is extraordinarily rare. Because of its few sites of presentation, the lesion was initially interpreted as fibromatosis. Occasionally, fibromatosis, also called as desmoid tumor, affected the palatine region. Since fibromatosis shows an aggressive clinical behavior and with high risk of recurrence. Unlike collagenous fibroma, fibromatosis is more infiltrative, usually causing bone destruction, occasionally root resorption, but above. Fibrous hyperplasia, which is fairly common reactive or inflammatory lesion of the oral mucosa, should be added to the differential diagnosis. And in contrast to collagenous fibroma, the fibrous lesion of much smaller, measuring less than 1.5 centimeter in diameter. Lack of preceding history of trauma, non-existing inflammation in our case ruled out such possibility. Coming to conclusion, oral collagenous fibroma is unusual, a distinct benign fibrous tumor that may show slow but persistent growth, reaching a considerable size, and exact etiology of fibroma is unknown. It can occur at any age group with female preponderance. Patient is usually presents with a mass, difficulty in swallowing and speech, which depends on size and location of the mass. And no recurrence is noted after complete excision. It is presented because of their age. And thank you. These are my references.
Is there any irritant factors like pawn chewing or anything in this case? Because she doesn't look to be a smoker because a female patient.
Yes.
Is there any signs of irritant factors like pawn chewing or gutta chewing in this case?
No, sir.
No, right. Okay. What exactly palatine torus? Palatine torus. You have been there. Any idea?
Flat palate, congenital lesion.
Hematoma, right? It is a hematoma, that is a deviation from normal, and at the same time it is not benign or malignant, right?
Yes, sir.
Are you able to hear me?
Yes, sir.
Okay.
Dr. Samrin Fatima?
Yes, sir.
Dr. Samrin Fatima?
Yes, sir.
Yeah, okay.
Share your screen.
Yes, sir. Sharing. 1 second, sir.
Okay. You can start.
Is my screen visible, sir?
Yes, yes, go ahead.
Sir. You can start.
Good morning, sir. I'm Dr. Samrin Fatima. Today I'm going to present a case report on fibroma of tongue. A 27-year-old female presented with the complaints of swelling at the base of the tongue since 2 months. It is insidious in onset, gradually progressive, and in size and attain the present size. It is associated with difficulty in swallowing, more to solids than liquid. It is not associated with any pain, discharge, or bleeding. And there is no complaints of difficulty in breathing or trauma. There is no history of tobacco chewing or smoking. The past history is not significant. The family history is not significant. General physical examination and systemic examination are also normal. On local examination, we see a single well-defined oral swelling measuring 2 into 2.5 centimeters, which is visible on the posterior 1/3 of the tongue on the left side, which extends to the vallecula. The surface is smooth and it is covered with a whitish slough, and the margins are also irregular. On palpation, the swelling is firm in consistency and non-compressible, non-tender, non-fluctuant, and there is no local rise of temperature and does not bleed on touch and does not move, not moving with deglutition or protrusion of the tongue. The movements of the tongue are also normal. Teeth are non-caries and oral hygiene is maintained. The oropharyngeal and neck examination are also normal. There are no nodes palpated and thyroid gland is also normal. Ear and nose examination is normal. Indirect laryngoscopy and video laryngoscopy reveals epiglottis and vocal cords to be normal. So based on the history and the clinical findings, we come to a provisional diagnosis of lingual thyroid or pyogenic granuloma. The general investigation are like the hematological investigations, the viral markers and thyroid hormones are also normal. Ultrasound findings. We see a well-defined solid hypoechoic avascular lesion of 27 into 18 mm deep in the neck and the left side with well-defined margins. The thyroid gland is also normal in size and echotexture. CECT reveals a rounded and taut 17 mm hypodense lesion with a thin periphery enhancing rim. The surgical management shows a solid swelling at the base of the tongue is noted, and it is excised by radiofrequency ablation procedure under general anesthesia. And the specimen is sent for histopathology. The histopathological report, it reveals an ulcerated lesion with a proliferation of the smooth muscle cells with fibrocollagenized stroma and the tissue which is composed of oval to spindle shape with the uniform nuclei. Hence, the diagnosis of irritational fibroma is confirmed. A traumatic or irritational fibroma is a common benign exophytic lesion of the oral cavity that develops secondary to the injury. The fibroma is a result of the chronic repair process that includes granulation tissue scar formation resulting in a fibrous submucosal mass. Recurrences are rare and may be caused by repetitive trauma at the same site. The lesion does not have any risk for malignancy, and the most common traumatic fibroma occurs on the tongue, the buccal mucosa, and the lower labial mucosa. Thank you, sir.
Did you think in terms of lingual tonsil?
Yes, sir. But because it does not extend to the tonsillar fossa, so we did not think in terms of that, sir.
Classical position of lingual tonsillar area. So
Sorry, sir?
Lingual tonsillar.
Yes, sir.
Different diagnosis, right?
Yes, sir. But both the tonsillar fossa were normal and the normal tonsil was present in that.
Usually, without that, lingual tonsillar hypertrophy is also being reported.
Yes, sir. Yes.
One of the three, what you mentioned.
Yes, sir.
Hemogram is normal, no? Not having any sort of...
Yes, thyroid gland is normal on examination and on ultrasound, sir.
No other lymph nodes are there?
No, sir. No lymph nodes are palpated.
Thank you.
Okay, sir. Thank you, sir.
Saida Kausar Fatima.
Dr. Sayeda Kausar Fatima. You can share your screen. Hello? Are you audible?
Hello.
Yeah. You share your screen. Kausar Fatima?
Local yes, sir.
Fatima.
Good Good morning, everybody. I am Dr. Kausar, and today I'll be presenting a case report on squamous cell carcinoma of temporal bone. My patient is Kamla, a 65-year-old female who presented to the hospital with the complaints of discharge from the right ear since 3 months, which was moderate in amount, purulent. Lately, it has been blood-tinged, foul-smelling, progressive, and not relieved with medication. She had a 1-month history of swelling of the right ear, which was insidious in onset, gradually increasing in size, associated with dull, aching type of pain, not relieved with medication. She had difficulty in opening mouth since 20 days, which was progressive, associated with pain, and not aggravated or relieved with anything. She did not have any other significant ear, nose, or throat complaints. She did not have any comorbidities. She is a chronic tobacco chewer since the past 40 years. On clinical examination, we found that the right ear showed an ulceroproliferative mass over the right tragus, which was 1.5 centimeters into 1 centimeter in dimensions, tender, firm to hard in consistency, having irregular margins with rolled out edges and unhealthy granulation tissue at the base. The mass was discharging pus on pressing. The external auditory canal was edematous and the tympanic membrane was not visualized. The left ear was normal. There was grade 3 trismus. Examination of the rest of head and neck was unremarkable. There was no evidence of cervical lymphadenopathy. Routine blood investigations were normal. Otoendoscopy confirmed the clinical findings. However, due to the presence of mass and edematous external auditory canal, distal visualization was limited. So we went on to get a CT of the temporal bones, which showed on the right side there was evidence of soft tissue density mass involving right external auditory canal, middle ear, mastoid, auricle, and extending into the temporomandibular joint and inferomedially. There was destruction of the tympanic and squamous part of the temporal bone and the temporal part of the temporomandibular joint. There was erosion of ear ossicles and scutum. All these were suggestive of malignant mass. Left side of the CT temporal bone was normal. We took a punch biopsy from the ulceroproliferative growth over the right tragus, histopathological examination of which revealed well-differentiated squamous cell carcinoma. As you can see in this histopathological slide, there is hyperplastic squamous keratinizing epithelium with polygonal cells with hyperchromatic nuclei. The intracellular bridges are characteristic feature of well-differentiated squamous cell carcinoma. The tumor was staged as T4 of carcinoma temporal bone according to University of Pittsburgh staging system. On evaluation, it was found to be unresectable due to extensive local invasion. Our patient is currently undergoing palliative chemoradiotherapy. Squamous cell carcinoma of the temporal bone is a rare tumor with an incidence of 1 to 6 cases per million per year. It accounts for less than 0.2% of all tumors of the head and neck, but it is the most common neoplasm in the temporal bone. It is often associated with chronic otitis media and exposure to radiation therapy. Diagnosis is based on histopathological examination of tumor tissue from the ear. Because of the rarity, developing a universally accepted tumor staging system and treatment has been difficult. However, University of Pittsburgh staging system is widely used. Treatment depends on the stage of the tumor, which includes local extension, lymph node metastasis, and facial nerve involvement. Preferred treatment is a combination of en-bloc surgical resection of the primary tumor with tumor-free surgical margins and post-operative chemotherapy and radiotherapy. Often performed surgery is lateral temporal bone resection or a subtotal temporal bone resection. Overall 5-year survival rate ranges between 40 to 70%, but in advanced stage of the disease, it can reach up to 20%. Since this is a rare and aggressive type of tumor, as otolaryngologists, high level of suspicion is necessary in patients with chronic inflammatory disease unresponsive to conventional treatment because it may mimic a ear infection causing late diagnosis. Early detection of the tumor before extensive spread into the middle ear allows for better treatment and better prognosis. These are my references.
Differential diagnosis.
Differential diagnosis, chronic inflammatory process, sir, such as chronic suppurative otitis media.
Did you think of glomus tumor?
No, sir.
Skull-base osteomyelitis?
No, sir.
There are a few things to be kept in mind. Is there history of CSOM in this case?
Patient is only giving history of 3 months of your discharge, sir. No past history of CS.
Limiting factor is your histopathology, right?
Yes, sir.
So put on that palliative treatment. That is your radiation and other things.
Yes, sir.
You have put the patient on radiation and chemotherapy, no?
Yes, post-operatively, sir.
Yeah. Did you do any surgical procedure? No.
We did not do, sir. The tumor was found to be unresectable. It was very extensive. So we put the patient on palliative radiotherapy and chemotherapy.
Okay, next. Okay, fine. Good.
Thank you, sir.
Dr. Aparna?
Yes, sir.
Aparna,
Yes, sir.
share your screen.
Sharing, sir.
Nasopharyngeal lymphoma.
Sir, am I audible, sir?
Yes, go ahead.
Yes, sir.
Yeah, you can start.
Good morning, sir. I'm presenting a case report on nasopharyngeal lymphoma, a rare presentation. Aim is to present a rare case of nasopharyngeal mass and to establish the diagnosis and plan for management. A 12-year-old male child presented to OP with history of left-sided nasal obstruction since 2 months, which was insidious in onset, gradually progressive with no seasonal or postural variation, and not subsiding with medication. There was history of bleeding from the left nostril since past 1 month, which was spontaneous in onset, intermittent 2 to 3 episodes per day, moderate in amount, painless, and not associated with fever or cold. There was history of left earache and left facial pain. No history of nasal discharge, sneezing, itching, disturbances of smell. And there was no history of headache, snoring, or trauma. On examination, on anterior rhinoscopy, a pinkish polypoidal globular mass was seen in the both nasal cavities, occluding the choana, and which bleeds on touch. An S-shaped deviated nasal septum was present. On posterior rhinoscopy, the globular mass was seen occluding the bilateral choana. Ear and the throat examination was unremarkable, and the neck examination, there was no swellings visualized, and there was no organomegaly. This is the mass being seen on the right side and the left side. Preoperative evaluation, all the blood investigations were within the normal limits, and the diagnostic nasal endoscopy was done, which confirmed the mass. This is the contrast enhanced CT of the paranasal sinuses showing mild, enhancing homogeneous soft tissue lesion noted along the superior surface of the nasopharynx extending into the left lateral wall, causing compression on the left pterygoid muscle, anteriorly extending into the left choanal region and the left posterior nasal cavity. Possibility of asymmetrical adenoid hypertrophy or a benign nasopharyngeal mass lesion was done. MR angiogram was done and showed a enhancing lesion on the left nasopharynx, left side of the nasopharynx, and extending into the nasal cavity, and abutting on the extending into the parapharyngeal space. And it was found to attain its blood supply from the hypertrophied ascending pharyngeal artery. Intraoperatively, under general anesthesia, coagulation-assisted excision of the mass was done. Septal correction was done on the left side. Left-sided middle meatal androstomy was done. Posterior wall of the maxilla was found to be bulging anteriorly. The site of the origin of the mass was found to be from the posterior wall of the nasopharynx, including the pterygoid plate. The tumor mass was excised with the help of the coagulator from both the nasal cavities and the nasopharynx up to the level of prevertebral muscles and sent for histopathological examination. There was excessive loss of the blood, and intraoperatively 1 pint PRBC was transfused and hemostasis was secured. Intraoperatively, this was the finding, and coagulator was used to excise the mass. Histopathological report: multiple bits of tumor arranged diffusely, composed of small round cells with scanty cytoplasm and fine chromatin was seen. Brisk mitotic figures noted with interspersed histiocyte. Areas of congestion with overlying ulceration was seen. It was suggestive of poorly differentiated malignancy, Cori lymphoma. Immunohistochemistry was done to confirm the diagnosis, and the impression showed features consistent of high-grade B-cell non-Hodgkin's lymphoma. And the patient was referred to oncologist for chemotherapy. Discussion. Lymphomas are the second most common malignant neoplasms after the squamous cell carcinomas in head and neck region. They can be classified into two types, Hodgkin's and non-Hodgkin's lymphoma. 10 to 18% of the non-Hodgkin's lymphoma were Walde's ring non-Hodgkin's lymphoma. Among Walde's ring NHL, 35 to 37% of the cases were in nasopharyngeal site. Diffuse large B-cell lymphoma and the NK or T-cell lymphoma are the two most common pathological diagnoses. Primary non-Hodgkin's lymphoma were more commonly spread superficially, and the lymphadenopathy is frequent and extensive. Coming to the conclusion, the age group, clinical presentation, intraoperative findings of this case were similar to nasopharyngeal angiofibroma. The neck node involvement, which will be extensive in lymphoma, was found to be absent in this case. Definite diagnosis is biopsy-based pathological analysis. The treatment for stages 1 and 2 are a combination of chemotherapy and radiotherapy. 3 and 4 is chemotherapy. B-cell non-Hodgkin's lymphoma has been found to be more sensitive to anthracycline-based chemotherapy. These are my references, sir. Thank you.
So this is the extranodal lymphoma, you need to say.
Yes, sir. Yes, sir.
Nodal lymphomas.
Yes,
Not
sir.
in lymph node, but it's extra lymph nodal lymphoma, no? Your diagnosis.
Yes, sir.
Prognosis?
Yes, sir.
Prognosis.
Prognosis is bad, sir. Poor, sir.
Not too bad. Because radiation is going to give a
What was the consistency of the tumor which you have excised with the coblator?
Sir, it was firm, sir. Firm in consistency.
A good diagnosis, good prognosis compared to other things, right?
Okay, yes, sir.
And what is plasmacytoma? Any idea?
Plasmacytoma, it is another type of B-cell lymphoma, sir, and it can usually present with it is like multiple myeloma, and it can present with extramedullary site enlargement will be there.
Yes. Thank you.
Dr. Chandana?
Petrous splenomegaly. Thank you, sir.
Chandana.
Sir, I'll share my screen, sir.
Share your screen.
Sir, can I start, sir?
Yes, yes.
No.
Good morning, one
Share
and
your
all.
screen.
First
First slide.
Sir,
First slide.
this is the first slide, sir.
No, you are not able to see.
Your screen has been not shared. Okay. Yeah, enlarge it.
Noted papilloma.
Sir, now it's visible, sir.
Yes.
Yeah.
Yes.
Okay, right. Start.
One and all, today I'm going to present a case of recurrent sinonasal inverted papilloma, a case report. Introduction to the case report. Inverted papilloma is the second most common benign tumor of nose and paranasal sinuses. It is also known as Schinderian papilloma due to its origin from Schinderian membrane, which is an invagination of olfactory ectoderm. Its incidence ranges from 0.6 to 1.5 cases per 1 lakh inhabitants per year. Inverted papilloma is more commonly seen in men, and its prevalence is in between 50 to 6 decades of life. Inverted papilloma frequently originates from the lateral nasal wall in the fontanel area, and maxillary sinus being the second most common site. These lesions are known for recurrence and are associated with squamous cell carcinoma either synchronously or metachronously. Case report: a 51-year-old male came to OPD with chief complaints of left-sided nasal obstruction from 1 year. History of present illness: the nasal obstruction is associated with nasal discharge in the left nasal cavity since 1 year. It is also associated with headache and postnasal drip from last 6 to 7 months, and associated with mouth breathing and snoring since 1 month. There is no history of nasal bleeding, sneezing, or loss of smell. History of similar complaint in the past, for which he underwent endoscopic sinus surgery 10 years back. On clinical evaluation, grayish polypoidal non-transcline masses seen extending from the left nasal vestibule anteriorly to the choana posteriorly, extending to the right choana. On probe test, the mass is insensitive to touch and it's not bleeding, and probe can be passed laterally.
but that is the probe cannot be passed, can be passed medially, inferiorly, and superiorly. CECT of the nose and paranasal sinus is taken. In on the screen we can see the CECT coronal section of the nose and paranasal sinuses, and there is homogeneous opacity occupying the left maxillary sinus, left nasal cavity, and deviation of the septum to the right. The inferior and middle turbinate could not be visualized. Differential diagnosis is sinonasal polyposis, squamous cell papilloma, rhinosporidiosis, schwannoma, and esthesioneuroblastoma. Biopsy was taken in view of the recurrence from the left nasal cavity, which revealed inverted papilloma. Surgery done was medial maxillectomy. In this diagram, we can see the Morse incision and the mass is exposed. On follow-up of the patient for 6 to 18 months, there is no recurrence observed on repeated diagnostic nasal endoscopy. In this diagram, we can see the clear maxillary sinus cavity. Discussion: inverted papilloma represents 0.4 to 4.7% of all surgically removed nasal tumors. Inverted papilloma with malignant transformation mostly is associated with human papilloma virus 16 and 18 serotypes. Inverted papilloma usually presents a soft, fleshy mass with clinical symptoms of nasal obstruction, nasal discharge, headache, and nasal bleeding. Diagnostic nasal endoscopy usually shows pale polypoidal lesion with a papillary appearance protruding from the middle turbinate may easily suggest the diagnosis. The best radiological investigation for inverted papilloma is MRI with gadolinium enhancement. Will help to differentiate the normal inflammatory mucosal changes and from the inverted papilloma, which shows a cerebriform columnar pattern. Histopathology appearance shows hyperplastic ribbon of basement membrane, which are laid parallelly, and endophytical invasion of the epithelium into the stroma, which is shown in the slide. Lateral rhinotomy with medial maxillectomy is considered gold standard because it gives wide exposure of the mass and prevent recurrences. But depending upon the site of the lesion and area of the mucosa involved by the lesion, endoscopic approach can be done. Histopathological examination of the complete specimen is required to check for synchronous squamous cell carcinoma because of its incidence from 9 to 18%. Take home message: any unilateral pinkish to grayish mass, firm to friable in consistency in a middle-aged person with poor response to medication and radiologically a typical appearance of focal hyperosteosis and osteotic changes at the site of origin should arise high index of suspicion for inverted papilloma. Complete excision is a hallmark for successful treatment, and histopathological examination is essential to look for malignant transformation. And long-term follow-up is essential to look for recurrences and metachronous squamous cell carcinoma. In our case, due to incomplete excision, there is recurrence after 10 years, but the first surgery was not done in our institute, and first surgery was an endoscopic approach. So due to the recurrence and extensive involvement of the mass laterally and posteriorly of the maxillary sinus, we have done the external approach so that further recurrences or metachronous squamous cell carcinoma can be prevented. Thank you, sir.
Next, Dr. Rabia Rafi.
So it is answer after endoscopic approach. Radical treatment is open excision, medial maxillectomy.
Yes, sir. For extensive masses,
Answer, right?
yes. For extensive masses, medial maxillectomy will be better, sir, to prevent recurrences.
Commonest complication after medial maxillectomy?
Epiphora and damage to the lacrimal epiphora will be there, sir. Sir?
The
Okay.
other name, otherwise, yes.
Dr. Rabia Rafi.
Any other
Yes, sir. Good morning, everyone, sir. Am I audible, sir?
Yeah.
Yes.
Share the
Yes.
screen.
Yes, sir. So, good morning, everyone. Today, my case is COSM with Petrous apex involvement. So 35-year-old female patient was present into OP with left ear discharge since 2 years and double vision from left eye and pain behind left eye, which was from 2 weeks. History of aesthetic complaints, the patient was apparently normal 2 years back. Then she developed ear discharge, which was gradual in onset, scanty, yellowish discharge, foul smelling, and it was continuous. History of double vision from left eye, which was sudden and persistent. And gradual onset dull aching pain behind the left eye, which is progressive in nature, but no aggravating.
Number serial number 20 వరకు ప్రజెంట్ చేయమని అందులో.
Yes. No aggravating and redeeming factors. In history of past illness, the patient was non-diabetic and non-hypertensive, and there is no surgical history in past. In local examination, the right ear seems to be right ear tympanic membrane is intact and retracted. Left ear, there is atic perforation with scanty discharge, and cholestoma flakes was seen at atic discharge, atic region. And nose, the deviated septum to left side. Eye, there was left lateral recti weakness noted on movements. So the diagnosis is left side active squamous cell chronic suppurative otitis media with petrositis, that is Guadagnino syndrome. Upon investigation, the blood investigation was within normal limits. X-ray mastoid revealed on the left side, it was opacified. And in the CT scan, left side, it was opacification of the mastoid region and Petrous cells. In MRI, on T1, it was hypodense, and in T2, it was hyperdense at Petrous apex, which was suggestive of Petrous epiccitis. The treatment done was left modified radical cortical mastoidectomy with sublabyrinthine approach, and subtotal petrosectomy was done under general anesthesia. In patient in semifloral position, Henry spine and McEwen's was identified. The antrum was entered and extensive granulations were present that were removed. And by sublabyrinthine approach, Petrous apex was reached and entire disease and air cells were removed. And post-operatively, the patient improved after surgery. These are the CT scans image, sir. There was a soft tissue mass seen in the left side in axial and coronal view. And this is the MRI picture, sir. And so the famous otologist of Naples, UCP Guadagnino, describes the triad of symptoms as double vision, retroorbital pain, and oral discharge. So the extension of infection causes pressure over the abducens nerve while traveling in Dorolo's canal underneath the Gruber's petroclinoid ligament, which is reduplication of dura connecting the Petrous apex and posterior clinoid process. So therefore, the diplopia was produced. And also there is the Gesserian ganglion in the Michel's cave. So therefore, the patient will have peri and retroorbital neuralgia. So the diagnosis is easy because of typical triad of symptoms, and also the Stenberg's view and Townie's view are also helpful in X-ray for seeing the decalcification involving the Petrous apex. CT scan is also helpful in ruling on Petrous apex syndrome. There are other things also like meningioma and neuroma trigeminal nerve, which will have a similar picture with associated features and evidence of intracranial space occupying lesion. So the approach along the route, there are various routes for going to the Petrous apex, but the best route is sublabyrinthine infracochlear approach. That is the most practical way when we want to preserve the hearing. So the posterior cell tracts can be traced out without destroying the existing hearing level. After mastoidectomy, any of the following routes can be adopted, like cell tracts between the genicular ganglion and superficial semicellular canal, because since it is along the course of the facial, 1 minute. Yeah, since it's along the course of facial nerve injury can occur. Cell tract about lateral and behind the superior semicellular canal also we can go. It is along the superior petrosal sinus towards the internal auditory meatus and sometimes to the apex, and under the arch of superior semicellular canal. Cell tract between posterior semicellular canal, jugular bulb, and facial nerve, that is described by Dearman and Fario. And also by Eagleton approach, that is middle cranial fossa approach, we can from the arcuate eminence we can go. And that approach is blind, but there is a possibility of dural tear after doing radical mastoidectomy, or through the triangle between the tegment tympanic, carotid artery, and cochlea described by Almore. After removing the tympanic plate of external canal posterior to the base of glenoid fossa, suture line, carotid artery is lifted forward by a gauze sling and Petrous apex is explored, but there is a risk of lacerating the carotid artery and injuring the facial nerve and cavernous sinus and cochlea. The injury is more. And these are the approaches, sir, from where we can go till the Petrous apex. Like anterior approaches are there, like transsphenoidal approach. Endoscopically also we can do, and endoscopic anterior petrosectomy. In anterolateral is open anterior petrosectomy. Lateral approaches are translabyrinthine transcochlear approach, middle cranial fossa approach, and transcanal infracochlear approach. Thank you, sir.
What is the hearing loss?
Hearing loss was mild, sir, like it was 40 decibel. So the patient did have that complaint of hearing loss, but she was like she has hard of hearing, but not that much.
Tinnitus or giddiness.
Yes, sir.
Tinnitus or giddiness or something.
No, tinnitus and giddiness was not there, sir.
Dr. Shahima Shehnaz.
Just Pranit, just wait.
Thank you.
Sir, respected judges.
Okay,
Sir, Venkatamed, sir.
Yes.
Sir, please continue up to serial number 20, sir. 2 more candidates are there.
Okay.
Let the other judges will join. After joining the judges, you will leave, sir.
No problem.
As it is going very well, sir. Very early also. Thank you for your cooperation, sir.
The second day, no, we are tuned and
sir.
We are tuned because of yesterday first day. We realized the problem.
Yeah. That's why, sir.
Okay.
Till the next judge joins, you please continue, sir.
Okay.
Thank you, sir. Thank you so much. Yeah. Pranit, you can continue.
Okay. Dr. Shahima Shehnaz?
Yes, sir.
Shema.
Yeah, you can start.
Respected judges, seniors, and my colleagues, good morning. I am Dr. Shema Shehnaz. I am going to present a case report on keratocystic odontogenic tumor. Introduction. Keratocystic odontogenic tumor, previously known as odontogenic keratocyst, is a developmental cyst that arises from the rest or glands of ceres, where the source of odontogenic epithelial residue is the dental lamina. It is more common in males, around 63%. It is more common in the second to third decade, around 40 to 60%. And the most common site affected is the third molar of the mandible, around 60%. Coming to the case history, a 13-year-old male reported to ENT OPD with complaints of swelling in the left cheek since 1 year, which was gradual in onset, initially of pin size, now increased to current size. There is history of occasional fever and nose blocks. There is history of occasional pus discharge from the swelling since 3 months as a result of stab incision given by a quack. On examination, the left cheek shows a puckered swelling of size 1 cm by 1 cm with a fistulous tract. The swelling is spherical in shape with puckering over it. It is non-tender and there is no local rise of temperature. Supernumerary teeth are present in the upper jaw. The remaining ENT examination is normal. Investigations. Orthopantomogram reveals supernumerary teeth in the maxilla, mixed dentition, unerupted third molars. Left maxillary quadrant shows a unilocular radiolucency surrounding unerupted canine. The CT of the paranasal sinuses shows a cystic expansile lesion, pericoronal lesion seen in the floor of the left maxilla, containing the crown of an impacted canine. There was evidence of bilateral maxillary sinusitis. Histopathological examination on low power showed parakeratosis, inflammatory regions, and dentigerous regions. On high power, it showed parakeratosis with palisading of epithelium and focal ulceration. Rest of the investigations were normal. Differential diagnosis was either a dentigerous cyst or amyloblastoma. Coming to the treatment, excision of the cyst with extraoral approach was done. Complete excision was done as recurrence is common. Post-op recovery was good. The discussion. Odontogenic keratocysts have been renamed as keratocystic odontogenic tumor by WHO due to its potential aggressive infiltration behavior. More maxillary cysts are more likely to get infected at an early stage, leading to an early diagnosis. Mandibular cysts may spread to infratemporal fossa and result in recurrent cysts in the temporalis muscle. Maxillary cysts may spread to the orbit, resulting in proptosis, to the infratemporal fossa, and to the skull base. The cystic content may be creamy white or thick yellow colored. It may be mistaken for pus, but it won't be foul smelling. The immunohistochemistry reveals overexpression of mutated P53 gene, mutated PAD gene, tenascin protein, and lost normal copy of tumor suppressor gene PTCH1. Recurrence. The recurrence rate of keratocystic odontogenic tumor depends on the original treatment given. Local resection and enucleation with peripheral osteotomy and Carnot's solution, the recurrence rate is just 18%. With the enucleation with peripheral osteotomy, it is 26%. With enucleation alone, the recurrence rate is 40%. And with marsupialization and enucleation with Carnot's solution, the recurrence rate is 50%. Coming to the malignant potential,
It may lead to squamous cell carcinoma seen in about 0.12% of the cases. Syndromic association. It is associated with Gorlin and Golf syndrome, also known as nevoid basal cell carcinoma syndrome. It is an autosomal dominant disorder characterized by multiple odontogenic cysts, which may either be simultaneous or sequential, basal cell carcinoma, palmar or plantar pits, and ectopic calcification of falx cerebri. These are my references. Thank you.
What approach you have proceeded?
Sir, with the help of an oral maxillofacial surgeon, we approached by a cadval loop incision, sir. The cyst wall was broken and the cyst contents were taken off piece by piece.
What is the Conroy solution you are talking about?
Sir?
Conroy solution or something? What is that?
That contains absolute alcohol, chloroform, and absolute alcohol, chloroform, and acetic acid and ferric chloride, sir. It penetrates bone more than the surrounding tissues. That is why it is used, sir.
Okay.
Thank you, sir.
Next.
Dr. Vinay. You are not audible.
You may disconnect your headphones.
From laptop.
Disconnect your headphones from the laptop.
You can.
Share your screen. Share.
Yeah, you can start. Hello, Vinay. Hello.
Vinay, share your screen and talk. Unmute.
Vinay, check your mic settings. In the corner of your screen, the arrow button next to the mute button. Please adjust your laptop settings. Sir, we can go for next speaker. Meanwhile, we fix this.
Sir.
Vinay, are you ready?
Once.
Left to bottom, you can see
Audio. Your audio is not there.
Okay. What is the problem?
Speakers on.
Okay, we are not audible, Vinay. Check your once.
What is the problem?
No, we are not audible.
is second Sana.
Okay. Sana Khan.
Your audio is.
Sana is the next person, Dr.
Are you ready?
Serial number 21, Sana.
Ramesh, this is Sana, no?
Sana, serial number 21, sir.
Then her audio is not audible, sir.
Vinay, you are keeping.
He is also having same problem.
Hello.
Yeah.
Yeah.
Go ahead.
Sana, go ahead.
My name is Dr. Sana Shaista Khan, and today is
mandibular swellings as TB lymphadenitis in an asymptomatic patient. The patient here is by name Vidyavati, 71-year-old female patient, housewife by occupation, came with chief complaints of 2 swellings under the chin since 8 months. This is the patient, sir. She came with bilateral submandibular swellings. On the right side, more large swelling than compared to the left. And the history of present illness, patient was apparently asymptomatic 8 months back when she noticed a small painless peanut-sized swelling in the right submandibular region, which gradually increased to the present size, and concurrently another small swelling developed in the left submandibular region. It was not associated with any pain, and there was no history of fever, night sweats, or weight loss. And there were no aggravating or relieving factors. No history of ear, nose, and throat complaints were found. Past history, no similar complaints of in the past. Known case of hypertension since 3 years and is on medication. And there is no history of diabetes, bronchial asthma, tuberculosis, no history of previous surgeries or blood transfusions. And present history was normal. Family history, there was a history of tuberculosis in grandson 2 years back, and they were living under the same roof. On general examination, the patient was conscious, coherent, and cooperative, moderately built and well nourished. No pallor and no icterus, no cyanosis. Vitals were also stable. Systemic examination was normal. On local examination, bilateral swellings in the submandibular region were seen. The right submandibular swelling was of size approximately 6 into 4 centimeters with well-defined borders extending from the angle of mandible to the lateral border of the sternocleidomastoid. The left submandibular swelling of size approximately 4 into 2 centimeters below the lower border of the mandible with well-defined margins. Skin over the swelling is normal and surrounding surface was also normal. On palpation, all the inspectory findings were consistent with palpation, and both swellings were firm in consistency, non-tender, non-fluctuant, and non-compressible, and mobile. Intraoral examination, there was no abnormality detected, no dental caries or so. Neck examination, the trachea was in midline. There was no thyromegaly or no other lymph nodes were palpable. ENT examination was normal. Investigations were normal except for the ESR, which was raised. Ultrasound of the neck revealed evidence of collection noted in the submandibular region in the right side of the neck, likely abscess. Thyroid lobes, both lobes were normal in size, contour, and ecotexture. Great vessels of the neck are normal. Other soft tissue structures of the neck are normal. And they had advised FNAC. In FNAC, it revealed eosinophilic necrotic background, and the possibilities to be considered were contents of an abscess with Cox type of necrosis, but the excision biopsy for confirmation. So excision of the right mandibular lymph node was done under general anesthesia. The excised right submandibular lymph node was sent for histopathology. And the histopathology report confirmed the diagnosis suggestive of tuberculous lymphadenitis. Under final diagnosis, that is tubercular lymphadenitis of submandibular lymph nodes. The patient was put on anti-tuberculous treatment. After appropriate treatment, the swelling has subsided and the patient remained asymptomatic at 6 months follow-up. No further complications were noted. Under differential diagnosis, it was reactive hyperplasia, lipoma, lymphoma, Ludwig's angina, and the metastatic carcinoma of the skin or oral cavity were also considered. Discussion. Extrapulmonary TB is defined as TB of organs other than lungs, such as lymph nodes, pleura, genitourinary tract, skin, joints, bones, etc. TB of superficial lymph nodes, also called scrofula, is very common in India, with cervical lymph nodes most commonly involved. Clinical picture is often non-descriptive in extrapulmonary TB. Symptoms such as fever, weight loss, and failure to thrive are usually associated. In our case, patient had swelling in submandibular region with no other symptoms. Tuberculosis needs to be suspected in every case of asymptomatic neck swelling in India due to high prevalence of TB in India, especially in rural settings. The tubercle bacilli enter the body through inhalation, which results in involvement of tonsils and adenoids, leading to further entry of bacteria into the lymphatics. The gold standard for diagnosis of extrapulmonary TB is the direct demonstration of acid-fast bacilli in the biopsy. It is difficult to see AFB in such cases due to low bacterial load. FNAC showing features of granulomatous lymphadenitis is valid for diagnosis for tubercular lymphadenitis. 4-drug regimen of rifampicin, isoniazid, ethambutol, and pyrazinamide in the intensive phase, followed by 2 drugs, rifampicin and isoniazid, in continuation phase of recommended treatment regimen. It is important to be aware of such cases of extrapulmonary TB. and it often poses a diagnostic delay due to non-descriptive clinical picture and low burden of organisms. The increased awareness of uncommon manifestations of lymph node tuberculosis at atypical sites may help in diagnosing the condition early. So these are my references.
Sir, any questions? Okay.
So good
Dr.
diagnosis
Mohammed,
is part of the patient. The patient has got a good prognosis, right?
Yes.
What is Recurrent syndrome?
Sir?
Recurrent syndrome. Recurrent disease.
Which syndrome, sir?
Recurrent disease.
Miculits.
Affecting okay.
Not able to hear you.
Okay.
Next is there, Ramesh. Other
Mohammed,
judges joined.
Ayub?
Yes, sir.
Mohammed Ayub.
Other judges have come.
The two judges are available, sir. One more judge we are waiting.
Okay. We'll continue with another case.
Yes, sir. Thank you, sir.
What about Vinay?
Vinay, are you there?
Vinay
No,
is
sir. No.
Yes, sir. Hello, can you hear me?
Yeah, you can present Vinay now.
Okay,
Ayub, just wait.
Okay, sir. Okay, sir.
Vinay, you continue.
Yes, sir. Yes, sir.
We'll go back to Vinay.
Display.
Not Ayub.
Yeah, you continue.
Yes, sir. Yes, sir. Hello, sir. Am I audible?
Yes.
Yeah.
Go ahead.
Yes, sir.
You can start.
Respected teachers, today I like to present a case report of spindle cell schwannoma of parapharyngeal space, a rare head and neck tumor. The aim is to present the rare case of parapharyngeal tumor as spindle cell schwannoma. A 53-year-old female patient from Nalgonda came to our OPD with complaints of pain in throat since 2 months, which was insidious in onset, gradually progressive, continuous, pricking in nature, not relieved by medications. There was no history of fever, difficulty in swallowing, difficulty in breathing, or any other swellings over the neck. On clinical examination, what we could see was a single unilateral swelling seen posterior to the left tonsillar pillar, smooth surfaced, non-pulsatile, pushing the left tonsil medially, non-tender, firm in consistency, partially obscuring the view of posterior pharyngeal wall, as you can see in the diagram below. When we investigated, all routine blood investigations were normal. USG-guided FNAC reported as hemorrhagic aspirates, and CT neck plain and contrast reported as heterogeneously enhancing hypodense lesion, which was 46 into 35 into 33 millimeter in left carotid space at the level of C1 and C2 vertebrae, causing extensive narrowing of the oropharynx, likely to be a nerve sheath tumor. Query schwannoma. CT neck angiography reported lesion with speck of calcification having supply from branches of left external carotid artery. The diagram in the top right, bottom right corner depicts the mass, the CT scan. And consequently, excision of tumor was done by transcervical approach under general anesthesia, and mass was sent for histopathological evaluation. The HPE report came as spindle cell lesion of neural origin, suggestive of schwannoma, Antony type A pattern, that is the pattern of elongated spindle cells forming a palisade of nuclei around a central mass of cytoplasm known as Verrucke body, as you can see in the slide. The immunohistochemistry showed S100 strong positivity, which is typical for Antony type A pattern of schwannoma. Postoperative is uneventful, and patient was healthy, and follow-up continues without any new complaints 9th month postoperatively. The parapharyngeal tumor represents only 0.5% of all head and neck tumors, and 80% are benign in nature, and among them neoplasia of neurogenic origin is only found in 1/10 of parapharyngeal tumors. They commonly originate from the sympathetic chain or vagus and are rarely malignant, and almost all are in the post-styloid compartment. Owing to the deep location, parapharyngeal space tumors do not present until they are large enough, making early diagnosis difficult. Common symptoms are neck swelling, oropharyngeal swelling, lower cranial nerve palsy, pain, and dysphagia. FNAC, MRI, and CT are necessary for diagnosis. Surgery is necessary to obtain histological diagnosis and should be excisional in nature. Various approaches are transparotid, transcervical, extended transmandibular. Common parapharyngeal tumors present with neck swelling, whereas in this case, only presenting complaint was pain in the throat. Main problem with surgery is one of access, followed by problems related to adjacent important vital structures. Initial assessment should consist of thorough clinical examination that documents all cranial nerve deficits, followed by scans and FNAC. The 5-year survival rate of benign tumor, even with late diagnosis, is greater than 90%. These are my references, sir. Thank you.
There are no nerve paralysis. There are no morbid changes in this patient. Eh?
No, sir. No, there was no involvement of the cranial nerves in this patient, sir. Only presenting complaint was pain in the throat.
What is the upper extension of the tumor? Near the skull base?
Yeah, till the skull base, sir, but not involving any jugular fossa or any foramens, but till the skull base.
Ramesh, you can relieve us.
Sir. Pandit, just wait.
Sir. Okay, sir. Okay.
The session will end. Thank you so much, respected judges, Dr. M. Venkateshwar Rao, sir, Dr. Venkatramreddy, sir, S. Ramakrishna, sir, for your cooperation and support, sir. You will have a small break, sir, 2 minutes break. The presenter, Ayub, just wait.
Thank you for the honor to be a so-called judges. Good morning, Dr. Satish.
Sir, good morning, sir. Good morning.
Thanks for your so-called keeping still in your memory.
Thank you so much, sir.
Very nice session we had.
All the best.
Yeah. Everything is going on well, sir.
Very well.
So far, so good.
Beyond expectation.
Good show.
For the next session, I welcome Dr. S. Ramesh Kumar, sir, Dr. Mohan Reddy, sir, and Dr. Jivesh Rao, sir.
Okay, bye.
Sir, Ramesh, sir. Ayub, just wait.
Okay.
Mohan Reddy, sir. Harsha, sir, wala mute.
Hi, Ramesh. Good morning.
Sir. Good morning,
Good
sir.
morning, everybody.
Welcome, Mohan Reddy, sir.
Good morning, Ramesh.
Good morning.
Hi, Satish.
Good morning. Welcome, sir.
Great to see you again. Finally, after a long time, Satish.
Yeah.
It's a virtual meeting. It's made it possible to see you and see your nice laughing face. Wonderful.
Yeah, we are not leaving any opportunity.
Yeah, that's really good.
To serve the AOI.
Yeah, I know.
with your cooperation and your support.
You are a dedicated person for the association.
It is your cooperation which is making the thing success.
Good work.
All members of AOI, they are cooperating.
Yeah, Ramesh is doing
that
wonderful
is the reason
work.
why we are going ahead.
Yeah, I know. Ramesh is doing good job. Good job.
Yeah, yeah.
Really appreciate.
Yes.
Hello. Just wait. Sir, the mic setting problem, the Ramesh sir.
Otu.
సతీష్ సార్ రమేష్ సార్ ది మైక్ సెట్టింగ్ సెట్ చేసుకుంటున్నారు
ఓకే
సార్ మాట్లాడాక
రైట్ జీవీఎస్ సార్ వచ్చాడా
సార్ అది ఇప్పుడు ప్రెసెంట్ గానే యూట్యూబ్ లో చూస్తున్నారు వాళ్ళ కొంచెం టైం పడుతుంది అన్నారు
యూట్యూబ్ చూస్తున్నారు కదా జూమ్ కు షిఫ్ట్ అయితే అయిపోతుంది
అదే కొంచెం ఏదో టెక్నికల్ గా సార్ కి తెలియదు అంటే వాళ్ళ అసిస్టెంట్ హెల్ప్ చేస్తారు
ఓకే ఓకే
am I audible now?
Yes, sir. Yes,
sir.
Yeah. Good morning, everyone.
Hi, Ramesh.
Good morning, sir.
Good morning, sir.
Hello,
Good morning
Ramesh.
and welcome.
Hello, Ramesh.
Yeah, good morning. I'm ready.
We miss your dance.
Yesterday I posted one virtual dance.
Yes.
Yeah.
I enjoyed it.
That's good. Yeah, we enjoy. We will see. We'd like to see that. Yeah. The link పంపిస్తావా?
Yeah, already it is there in the group.
దాంట్లో పెట్టాడు ఆల్రెడీ ఉంది
గ్రూప్ లో
వచ్చేసింది.
There in the WhatsApp group.
నిన్న సాయంత్రమే డాన్స్ చేసేసాం అందరం.
That's really good. Yeah. Very nice.
రమేష్ రమణాచారి సార్ వచ్చిండా?
చారి is there.
రమణాచారి కనిపించాడు.
Sir, good morning, sir. Good morning.
Sir, good morning, sir. Good morning.
Ramnachari, just had a glance up. Yeah.
Sir.
Yeah.
Morning, sir. Good morning.
Good morning, Ramnachari.
Sir. Since morning, I am there, sir. Since morning.
Wow. That's really good. Hi, Sudarshan.
Anna, namaste, Sudarshan. Namaste.
So nice. Nice to see.
அன்மியூட்ல சவுண்ட் கேக்குதான்னு சொல்றேன்.
Hello.
Good morning, everyone, sir.
Yeah.
Am I audible?
Yeah, you are audible.
Yes, sir. Thank you, sir. So I'm going to present a case of unusual presentation tuberculosis in oral cavity. My name is Dr. Muhammad Ayub.
Share your presentation.
Share your presentation.
Share your presentation.
You have to share your screen.
Sir, is it okay?
Yeah, right.
Enlarge.
Full screen. Full screen, please. Go to slideshow. Oh, it's gone. Share your screen and keep it in full screen view. Yes. Full screen, please. Go to the slideshow. No, lower down at the bottom.
Click F5 in your keyboard. Click F5.
Yes, sir. Okay, thank you, sir.
All right.
Okay.
Go ahead.
Okay, sir.
Yes, you can start.
I'm going to present a case of unusual presentation of tuberculosis in oral cavity, sir. A 40-year-old male resident of Shamshabad, driver by profession, came to the hospital with chief complaints of whitish lesion on the inner side of left cheek since 4 months, fever and cough since 2 months, shortness of breath since 1 month. Here is the lesion, sir, which is extending from left retromolar trigone, buccal mucosa to left side of angle of mouth, sir. Patient noticed whitish lesion on the inner side of cheek 4 months back, which is insidious in onset, slowly progressive in size, which is painless, not associated with bleeding on touch. Fever and cough since 2 months, fever low grade in nature, intermittent, with evening rise of temperature, not associated with chills and rigor. Cough since 2 months, saturation, whitish, which is not relieved by medication, and shortness of breath since 1 month, which is aggravated by exertion and not relieved by the rest. There is a history of weight loss and generalized weakness. There is no history of trauma, skin lesions, difficulty in swallowing, difficulty in opening mouth, or any other neck swellings. Comes to past history, it is not a known case of hypertension, diabetes mellitus, tuberculosis, asthma, or epilepsy. It is not a known case of renal disease, cardiovascular, coronary artery disease, cerebrovascular accident, or thyroid disease. There is no history of previous surgeries, and there is a history of contact with tuberculosis in childhood with his father. Personal history: patient is a cigarette smoker since 15 years. Is used to smoke 6 cigarettes per day. Patient is a chronic gutka chewer for 2 years and used to consume alcohol occasionally. On general examination, findings were no abnormality was detected except a respiratory system examination where bilateral coarse crepitations were had. On local examination on inspection, ulcerative lesion over left retromolar trigone and buccal mucosa extending up to angle of mouth on left side, which is whitish in color, with smooth surface with irregular margins with no erythematous areas, no visible growth over neck or submandibular region, and no associated neck swellings were there. And palpation, inspectory findings were confirmed, and no tenderness, ulcer is non-indurated and not bleeding on touch and cannot be wiped off, and no cervical lymphadenopathy. VLS and DNA findings were normal. Video laryngoscopy and diagnostic nasal endoscopy findings were normal, sir. On routine blood investigation, all were normal except elevated erythrocyte sedimentation rate, which was 40 millimeter in first hour, and biopsy was taken from left buccal mucosa, which is suggestive of no evidence of malignancy, and it shows granulomatous lesion with caseous necrosis, which is suggestive of Cox etiology, and it was negative for fungal staining. And chest X-ray PAV was taken, which is suggestive of multiple diffuse opacities in bilateral lung fields of size 1 to 3 mm in size, which are not uniform in size. Sputum for AFB was done. Acid fast bacilli was done, which showed acid fast bacilli, and Mantoux test. It is also positive with 15 millimeter induration over right arm, sir. Right forearm. This is the X-ray which is showing multiple opacities, diffuse opacities in bilateral, and this is the biopsy which is showing caseous necrosis with granuloma, the Langhans giant cells, epithelioid macrophages, and lymphocytes. Discussion: cause of ulcers in oral cavity as infections, viral and bacterial. Viral infections like Herpangina, and bacterial infection like TB, syphilis. And there are immune causes like aphthous ulcers. Trauma, which are physical, maybe chemical like silver nitrate, phenol, aspirin. And neoplasms like squamous cell carcinoma, carcinoma of minor salivary glands, and non-Hodgkin's lymphoma. like blood disorders and skin disorders. Drug allergy also can cause present as mouth ulcers. Miscellaneous causes like radiation mucositis, chemotherapy, diabetes, uremia, and fungal candidiasis. Conclusion, sir. Commonest sites of presentation of tuberculosis are tonsil and soft palate in and posterior pharyngeal wall. But in the present case, it is presented with the ulcer in the left retromalar trigone and left buccal mucosa, which is unusual. Actually, oral tubercular lesions are rare, difficult to diagnose, and pose a potential infectious hazard to ENT surgeons engaged in treatment. An oral ulcer mimicking squamous cell carcinoma of buccal mucosa must be considered for being tubercular if biopsy of the lesion does not show a definitive evidence of malignancy. Thank you, sir.
Next, Dr. Shruti.
Yeah, Dr. Ayub.
Sir.
Yeah, what are the various differential diagnostic conditions for such ulcer? Common ones. Common.
Sir, it may be fungal causes, sir. Candidiasis.
Talk about common things. Common things. Yeah, candidiasis. Okay, agreed. In which patients you suspect candidiasis?
Squamous cell carcinoma. Sir,
No,
immunocompromised patients.
Yes. Okay.
Yes.
Any other common practical situation? Can you think of oral candidiasis? Apart from immunocompromised condition, common practical condition will be there, which is iatrogenic. Iatrogenic. I am giving you a clue. Iatrogenic. Candidiasis, which is iatrogenic, found in asthmatics. Found in asthmatics. Another clue I am giving, try to catch it. What do they prescribe in for asthmatic patients? Just physicians, what do they prescribe?
The steroids.
Yeah, steroids. Steroid inhalers. Okay. So prolonged steroid inhalation also can produce oral candidiasis, right?
Yes, sir.
So what are the other common oral ulcerations?
Ulcer, sir.
Yes.
And there are viral and bacterial causes are there, sir. Viral hemangioma.
Yes. Agreed.
Bacterial causes, tuberculosis, syphilis.
Yes.
There are causes like
what type of ulceration you get in syphilis? What type of ulceration? What type of ulceration you get in secondary syphilis? What type of ulceration you get in tertiary syphilis?
Hello. కొంచెం పిలిచే మీద వెయిట్ చేయి.
Are you? Heard of snail track ulcers?
Yes, sir. Yes, sir.
Now that is seen in which type of syphilis? Secondary or tertiary snail track ulcers? Gamma? Yeah, secondary. So in tertiary syphilis? In tertiary syphilis? In tertiary syphilis, what type of ulceration you get? Gummatous ulceration. So how does the margin look like in tuberculous ulceration? How does the margin look like in malignant ulceration? How does the margin look like in gummatous ulceration? Ayub?
Sir, it is. Yeah. Sir, there are irregular margins will be there in tuberculosis ulcer, sir.
No. Heard of undermined ulceration?
Yes, sir, undermined edges.
Yes. and undermined edges. And in gummatous ulcers, in malignancy,
In malignancy, the lesion will be indurated, sir. And edges will we will find that irregular growth, irregular ulceroproliferative growth.
Margins
will be irregular, sir.
Yeah, call it as averted. Okay. So did you follow up this patient with anti-tubercular treatment?
Hi, sir. Sir,
How
we
was the
sent
response?
to a patient. Patient recovered well, sir, on anti-tubercular treatment, and there is sir, am I audible, sir?
Yes, you are audible. Please.
Hi, sir. Patient recovered well, sir, and the lesion it subsided, sir.
Okay.
With relieving of that all symptoms which he had.
Okay. Okay, right.
Yes,
Thank you, Ayub. Next,
thank you.
Shruti.
Sir, small announcement, sir.
Yeah.
GVS Rao sir join time person, sir. Venkateshwar Rao sir already acting as a standby till GVS Rao sir joins, sir.
Okay.
Yes,
Okay, sir.
That's a small note, sir. That's it. Thank you, Venkateshwar sir. Yes, Pranit, we continue, sir.
Sir. Okay. Dr. Shruti, are you ready? Okay.
Yes, sir.
Share your screen, Dr. Shruti.
Yes.
Yes, start.
Morning, sir.
Go ahead.
Sir, I'm going to present a case report on Eagle syndrome. A 45-year-old female patient came to OPD with complaints of pain in the left side of the throat since 3 years. Patient was apparently asymptomatic 3 years back, and then she developed pain in the left side of the throat, which was insidious in onset, gradually progressive, sharp pricking type of pain, constant throughout the day, not relieved with any medication, aggravating on neck rotation. There was history of painful swallowings. There was history of foreign body sensation in the throat and history of left-sided neck pain. There was no history of any foreign body sensation, no history of any trauma, no history of fever, sore throat or cough or any upper respiratory tract infections, no history of change in the voice. She underwent tonsillectomy 2 years back, but patient was not relieved of symptoms. All the routine investigations were done and they were within normal limits. On bimanual palpation, symptoms worsened on palpation of styloid process through the tonsillar bed. Infiltration of lignocaine into the left tonsillar bed relieved pain. This is the pain X-ray soft tissues neck lateral view showing elongated styloid process. This is the CT scan neck showing elongated styloid process. We have done transoral excision of elongated styloid process, which was about 1.5 centimeters extra. As tonsillectomy was done outside 2 years back, now superior constrictor muscle was dissected. The styloid process, extra length of the styloid process is grasped, mobilized, and removed with curved artery forceps. This is the intraoperative picture. Discussion. Eagle syndrome or styalgia was first described by W. Watt Eagle as a pain syndrome which occurs due to elongation and ossification of styloid process or stylohyoid ligament impinging on local neurovascular structures. Incidence of elongated styloid process is about 4%, out of which 4 to 10% of this group is actually symptomatic. Commonest symptom being chronic throat pain. There are two types of syndrome complexes, classic variety or stylohyoid syndrome, which constitutes throat pain, neuralgia, and foreign body sensation. The other thing is carotid artery type or stylocarotid syndrome, which has carotidina, headache, facial pain, and dizziness. Carotidina is on application of pressure on at the bifurcation of carotid artery, patient feel there will be tenderness. Conclusion: all can be diagnosed by detailed history, physical examination, and radiological investigations. Resection of this elongated styloid process is the treatment of choice. It can be done either by transoral route or transcervical route. Awareness of pain syndrome related to the styloid process is important to all health practitioners involved in the diagnosis and treatment of head and neck pain to rationalize the line of management. These are my references, sir. Thank you.
Is it unilateral or bilateral, Shruti?
Unilateral, sir.
Unilateral.
Only left side, sir.
So, okay. So how does this styloid gets elongated?
Either by reactive hyperplasia due to trauma or abnormal ossification, or there may be remnant of second arch cartilage, that is research cartilage.
Abnormal ossification along?
Styloid process or stylohyoid ligament.
Ligament.
Abnormal calcification of stylohyoid
ligament. Okay. Good.
What is the normal length?
2.5 centimeters, sir.
What is the length in this case?
Extra 1.5, sir. 2.4 centimeters, sir.
Got good relief? Patient got
yes, sir.
relief?
She's completely relieved of symptoms, sir. It's been 3 weeks, sir. She has completely relieved of symptoms.
Can you assure total relief of pain for such patients?
Yes, sir.
Counseling, pre-op counseling?
Yes, sir. Yes,
no.
sir.
No, never do that. Never do. You are not sure of your results. See, sometimes
okay,
that neuralgic pain will be there even after excision of styloid process. Okay?
Okay, sir. Okay, sir.
Dr. Ashita? Dr. Ashita is Kabir.
Yes, sir.
Share your screen.
Shall I start, sir?
Yeah, start.
Yeah, okay, start.
4 centuries ago, a British French butcher surgeon, Ambrose Paré, was called to the sickbed of young King Charles II of France, who was suffering from high fever, discharging ear, and delirium. Paré proposed an operation of the skull to drain away the pus, but the Queen Mother forbade the operation, and Charles II, at the young age of 16, was succumbed to the first ever recorded complication of chronic otitis media. Even 4 centuries later, we are not free from the clutches of this notorious disease. So here, good morning, everyone. I'm presenting a case report on post-auricular cutaneous mastoid fistula, a very rare complication of chronic otitis media in the antibiotic era. Post-auricular cutaneous mastoid fistula is a rare complication of chronic otitis media with only 6 reported cases in the modern literature. While most of the simple mastoid fistula tend to heal spontaneously, these cutaneous mastoid fistula tend to heal slowly. This is because of the ingrowth of the epithelium, followed by necrotization and epithelialization of the margins of the fistula. Various techniques are recommended to reconstruct mastoid cutaneous fistulas, including simple closure, bone or cartilage graft, and mastoid flap coverage. This is a case report of Yadaya, a 23-year-old male from Nalgonda, came with complaints of discharge from the post-oral wound since 1 year. There was discharge which was mucopurulent in nature, not blood-stained, but foul-smelling, and he complained of undergoing an incision and drainage for an abscess, following which the wound failed to heal and started discharging chronically. There is history of hearing loss in the left ear with no history of ear discharge, no history of intracranial or intratemporal complications of the disease. There is no history of previous surgeries or
tuberculosis in the past. Routine blood investigations was done, which was normal. Pure tone audiometry suggested 70 decibels of hearing loss with moderate mixed hearing loss. In examination under microscopy showed intact tympanic membrane with the retraction pockets in the posterior superior quadrant with the pus in the middle ear, which was seen through the intact tympanic membrane. This is the picture of the postoral fistula, which showed discharge in the otomastoidectomy cavity with the epithelialization of the margins. HRCT of the temporal bone was done, which showed otomastoidectomy cavity, which was connecting to the skin with the soft tissues, which was present, in the attic, antrum, and adytus with intact facial canal as well as semicircular canals, but with erosion of the middle ear ossicles. He was managed with canal wall up mastoidectomy surgery with a postoral William Wildes incision, which was done including the postoral fistula, and an otomastoidectomy cavity was seen on opening up the mastoid, which was filled with granulation tissues within the mastoid as well as within the middle ear. The excision of the fistulous tract was done after erosion of the margins, with the fistula tract was around 4 centimeters in length. The granulation tissue was removed from the attic, antrum, and middle ear. Type 3 cartilage tympanoplasty was done, and a temporalis musculofibrous periosteal advancement flap was done to close the fistula. In discussion, chronic otitis media implies a permanent abnormality of the pars tensa and pars flaccida, which may be lasting for more than 2 to 6 weeks. Complication can be intracranial or intratemporal, with the oral mastoid fistula being a rare complication. Resorption of bone is a feature of both active mucosal as well as squamous disease, which is mainly because of the resorptive osteitis because of the granulations in this case. The differential diagnosis for postoral mastoid cutaneous fistula are polysteatoma, tuberculous otitis media, post-surgical mastoidectomy fistula. Primary closure with excision of the fistulous tract with temporalis fibromuscular flap, epicranial flap, rotation flap, or advancements at plasty has to be employed, because the simple closure will not be able to close the fistula because of the necrosis that is present at the edges. So even in this era of advanced antibiotics, postoral mastoid cutaneous fistulas are present. Early detection of chronic otitis media and its complication and appropriate antibiotics can save the patient from accumulation from such a chronic discharging fistula. Thank you, sir.
So, okay, this is secondary to subperiosteal abscess, isn't it?
Yes, sir. Yes, sir.
What are the various mastoid abscesses, you know?
Cicalis abscess, lux abscess, Bezold's abscess.
Okay, what do you mean by Bezold's?
Bezold's abscess is along the posterior digastric muscle, sir.
Okay. In the digastric?
Sternocleidomastoid, sir. Cicalis is along the posterior digastric muscle.
Mm-hmm.
Lux is along the posterior wall of the external auditory canal, sir.
Yes. Okay. So how was the follow-up?
The patient has come for suture removal, sir. The wound is healthy. There is no discharge from the EAC, sir. This is his 14 days, post of 14 days, sir.
Mm-hmm.
What was the hearing loss, Priya, you said?
70 decibels of hearing loss, sir, mixed.
70.
Yes,
Other side was...
no, sir, there was 50 decibels of hearing loss, sir.
So a child having SN component.
23.
How do you
Yes,
explain the other side also having a SN component on this side?
He complained of discharge in the right ear also, sir, since the childhood. So we managed this year first.
So the chronic otitis might have caused the sensory component, right?
Yes, sir. Yes. The granulation tissues around the oval window and round window might be the reason for his sensory neural hearing loss, sir.
Have you taken post-op audiogram?
Not yet, sir. We have to do it yet.
Okay. So,
what was the tuning fork test you mentioned?
Yes, sir. Tuning fork test was done, sir. There was bone conduction was better. Air conduction was better than bone conduction in both the ears, sir, with peppers lateralized to the more diseased ear, which is left ear in this case, sir.
air conduction was better.
Yes, sir.
Mm-hmm.
What is my, sir?
No. You mean to say it is positive. Renisis?
Yes, sir. Positive, sir.
Weber's?
Weber's was lateralized to this ear, sir. Left ear. Yes, sir.
Are you sure?
Yes, sir, we have
With the
done
70 decibel, with the 70
Yes, sir.
decibel loss and the 50 decibel bone conduction loss, Weber and
both are.
Renis test. Do you expect Renis to be positive? I mean, do you expect Renis negative and Renis positive? And how can you explain that Weber's lateralization? It must be the worst bone conduction actually on the left side.
Yes, sir. So it was lateralized to the left side, sir. Airborne conduction gap was more in the left side, sir, than the right side. So it was lateralized to the more deceased side, sir.
నాకు వచ్చిన చార్ట్ వచ్చింది ఇదేంటి 23rd స్టార్ట్ అయిందా అయితే మండే స్టార్ట్ అయిపోయినా 18th నుంచి స్టార్ట్ అయిపోయినా
Thank you, sir.
What was the purpose of this canal wall up mastectomy in this?
Since the disease, since it was only a chronic mucosal disease with granulation, sir, it was not an extensive disease. And once this granulations was removed, the middle mucosa was normal. So there was no purpose of canal wall up surgery. And the patient is undergoing surgery. He has to undergo surgery for the other ear as well. So hearing can be better with this canal wall up surgery, sir.
And your hearing aid fitting maybe.
Yes, sir. Beneficial.
This, no? Yeah.
Yes, sir.
How can you call it a mucosal disease when he has already presented to you with mastoid abscess? Can you call it a mucosal disease?
Because cholesteatoma flakes and cholesteatoma sac was not present on the when we opened it, sir.
Likely. Okay.
Okay. Thank you, sir.
Thank you. Welcome to Dr. GVS Rao, sir.
Yeah, welcome GVS Rao, sir. Good morning, GVS Rao, sir.
Good morning.
Good morning, everybody.
Good morning.
Good morning, sir.
Sir, Sadish sir, good morning.
Good morning, sir.
వందనాలు
మీకు కూడా మా తరఫున AOI తరఫున
థ్యాంక్ యూ సార్
మీ అందరికీ వందనాలు శుభోదయాలు
థ్యాంక్ యూ సార్
Welcome, Dr. GVS sir.
Thank you, sir.
Yeah, who's next?
Dr. Joshi and
Joshi.
Good morning, everyone.
Good morning.
Good morning.
Share your screen.
Yes, sir. Good morning, everyone. Can I start?
Okay, you can start.
Yeah.
I'm here to present a case report of chondrosarcoma of nasopharynx with oral polyp as presentation. Introduction. Cartilaginous tumor of nasopharynx are rare. The incidence is less than 5% in head and neck region. Chondrosarcomas are malignant cartilaginous neoplasms with diverse morphological and clinical behavior depending on the anatomical location. It is a locally aggressive group of cartilaginous matrix-producing neoplasm with relatively high local recurrence rate. The surgery, as wide excision of the lesion, is known as the most effective treatment modality for chondrosarcoma. My case is a 35-year-old female patient, resident of Sheikpet, presented with progressive right hard of hearing of 1 year duration, right ear discharge, which was mucoid, non-foul smelling, not blood stain, aggravated on upper respiratory tract infection, relieved on taking medications, which is a 1 year duration, not associated with right ear pain, itching sensation, fever, headache, vomiting, facial asymmetry, giddiness, ringing sensation, trauma. No history of nose and throat complaints, no significant past and family history. Coming to the examination part, examination of right ear, pinna, periauricular area, post-auricular area are normal. A single pale polypoidal mass is seen filling the entire external auditory canal, which was firm in consistency. On probing, it could be passed all around. It's insensitive to pain and not bleeding on touch. Examination of the left ear, the pinna, periauricular, post-auricular region normal, tympanic membrane intact. Nose examination on anterior rhinoscopy, anterior deviated nasal septum was seen towards the right. Posterior rhinoscopy, pinkish mass was seen on the right lateral wall of nasopharynx. Oral cavity, pharynx, laryngeal examination was normal. Neck examination was normal. Cranial nerves examination was also normal. The systemic examination, cardiovascular, respiratory system, GIT were normal. Coming to the blood investigations, were within normal limit. Here under microscope showed a single pale polypoidal mass in the right extern-aortic canal, completely filling the canal. So the scope could not be negotiated further. Tympanic membrane was not visualized. Diagnostic endoscopy was also done, which showed pinkish irregular mass seen arising from the right lateral wall of nasopharynx. So due to which we advised the patient CT scan with and without IV contrast, which showed approximately 45 by 35 by 51 mm non-enhancing hyperdense lesion noted involving the right lateral and posterior wall of nasopharynx, bilateral lateral and posterior wall of oropharynx, bilateral tonsils with multiple coarse calcifications. Evidence of 12 by 3 mm non-enhancing hyperdense lesion was also noted in the right external aortic canal. So the patient was subjected to biopsy from the nasopharyngeal mass, which showed acellular eosinophilic material admixed with foci of calcification and osteochondral tissue, suggestive of chondrosarcoma, followed which biopsy was also taken from the external aortic canal mass, which suggestive of focus of extension from the primary lesion. This is the CT scan of the nose and the paranasal sinus. This is the DNA findings. The CT scan showed lesion involving the nasopharyngeal area with calcification. This is the irregular mass seen. It's a microscopic feature of the mass. This is a ear under microscopic picture and the CT temporal bone. It's seen involving the internal EAC. The material structures are all not visible, seen even extending into the master also. Coming to the discussion part, chondrosarcoma is a slow-growing malignant tumor of skeletal and extraskeletal origin, which comprises less than 5% of head and neck tumors. These neoplasms probably arose from the remnants of embryonic cartilaginous skeleton, which had escaped resorption from the endochondral ossification. Chondrosarcomas have several histological variants. They're divided into conventional chondrosarcomas and non-conventional. Non-conventional, which in turn is divided into clear cell, mesenchymal, and dedifferentiated chondrosarcomas. They're graded as low, intermediate, and high grades. The radiographic features are very often characteristic, which shows calcified areas, which means that they suggest of pre-existing enchondromas. In respiratory tract, they have very considerable in degrees of differentiation, and despite their bizarre microscopic appearance and tendencies to involve locally, these tumors rarely metastasize. They're comparatively radio-resistant, and prognosis depends following the adequate excision is much better than the other forms. It depends upon the local extent of the tumor and the adequacy of surgical therapy and the degree of differentiation of the tumor. These are my references. That's it, sir.
So what treatment you suggested for this patient?
So we advise patient for en bloc resection, sir, but the patient didn't give consent for surgery and we lost her on follow-up, sir.
Dr. GVS, would you like to ask anything?
No, this is better you only.
You are the right person.
No, sir.
She has presented with some autological manifestation also.
Yes, sir.
So what would be appropriate treatment for this, Dr. Joshi?
As a chondrosomas are resistant to radiotherapy, preferably the surgery is a initial treatment modality, sir. And depending on that, post-operative chemotherapy can be given. But as much response is not seen for chemotherapy. So surgery is the main treatment advised.
Have you taken audiogram for this patient?
Yes, sir. We have taken.
How much was the hearing loss?
So on the right side is 66.6 decibel hearing level, and on left ear is 35 decibel hearing level, sir. It's mixed conductive hearing loss on the right side, sir.
Okay. Thank you.
Yes, sir.
Next, Dr. K. Vinod.
Good morning, sir.
Morning.
Sir, is it visible?
Yeah, visible.
Yeah.
I'm going to talk about an unusual choristroma in the parotid gland. 16-year-old adolescent male came to ENT OPD with complaints of swelling below and behind the left ear since 3 years. The history of presenting in this patient was apparently asymptomatic 3 years back. Then he developed swelling below and behind the left ear, which is insidious in onset, gradually progressive in nature, and attained the present size. It is not associated with pain and discharge, no aggravating and relieving factors. No history of trauma, no history of difficulty in opening the mouth and difficulty in swallowing or fever. No history of loss of weight or loss of appetite. Past history, no history of similar complaints in the past, no history of any other surgeries. Personal and family history are not significant. General examination, patient is conscious, coherent, cooperative, and moderately built and nourished and afebrile. No pallor, no electric, no sinuses, no clubbing, no lymphadenitis, no edema. Vitals are stable, and the systemic examinations are normal. On inspection, a solitary swelling of size 4 to 3 cm in the region below and behind the left ear, which is smooth surface, well-defined margin, and no visible pulsation, no scars, sinuses, and no dilated veins over the swelling. No, and the surrounding areas around the swelling are normal. On palpation, all the inspector findings are confirmed. It is not warm, not tender, mobile, firm in consistency, not fluctuant, and not tonsil. Neck examination, no other swellings in the neck. Rest of the ENT examination are normal. In examination of the oral cavity and oropharynx and all, no deep lobe enlargement, no pushing of the tonsil or soft palate towards the opposite side anteromedially, and bilateral facial function is normal, intact. And my provisional diagnosis is benign tumor of the parotid gland. Investigations, normal routine investigation, routine blood investigations are normal. And the USC suggestive of left pleomorphic adenoma, and FNAC also suggestive of left pleomorphic adenoma. And we have planned for superficial parotidectomy, marking of the incision, modified Blair incision, and incision is given, and it is deepened, skin, subcutaneous tissue up to the parotid fascia, and the anterior and posterior flaps are elevated, and the swelling is exposed. The swelling was attached to that of the tragal cartilage. The swelling was excised along with the tragal cartilage, and this was the excised specimen. And the histopathology report came out as a choristroma of the left parotid gland. The histopathology picture shows the normal parotid acini and the bony trabeculae and the cartilaginous and myxoid stoma. Postoperatively, patient was on antibiotic and suture removal was done after 7 days on 7th day. Postoperative wound site healthy. Postoperatively, facial function intact. Discussion. Choristroma are masses of normal tissues found in the abnormal excisions. Choristroma are classically occurring to the type of the tissue. They are relatively rare. They are commonly seen on the skin and relatively rare in the head and neck, and sometimes most commonly in the head and neck it is present in the oral cavity. Several different heteropias are as osseous choristroma, cartilaginous choristroma, gastric mucosal choristroma, glial choristroma, lingual thyroid choristroma has been described in the oral and maxillofacial region. Purpose of this presenting this case report is rarity. So far, according to the entrance-based data, only few cases of osseous choristroma in the salivary glands has been reported. Absence of any neoplastic characteristics obviates the need for further management and follow-up in choristromas. Thank you, sir.
Sir, Ramesh, sir, you only have to ask the questions.
Yeah, in differential diagnosis, what other possibilities you suspected, Dr. Vinod?
It is a painless swelling, so benign tumors of the parotid gland. If it is pain, then it is chronic silenitis, pain during mastication. Painless swelling, so it is a pleomorphic adenoma, Warthin tumors, oxophilic adenoma, oncocytoma, and any other cyst over the parotid cyst, and vascular malformations, hemangioma, but no bruit over here over the swelling, and any granulomatous diseases, tuberculosis, sarcoidosis. If usually sarcoidosis, if it is bilateral, it is in this case it is unilateral, so it is not there. And tuberculosis and actinomycosis also.
What is the commonest malignancy in the parotid?
Most benign tumor is pleomorphic. Malignant tumor is mucoepidermoid carcinomas.
Yes. How do you grade that?
Low grade, intermediate grade, and high grade. And The low grade is clear. Intermediate.
Okay, okay. So during parotid surgery, how do you locate facial now?
Tragal pointer, sir. The 1 centimeter deep and inferior to the tragal pointer facial nerve is located, and also from the posterior belly of digastric and facial nerve location, and from the posterior belly of digastric up to the tympanic plate, and also from the peripheral branches of the facial nerve can be traced retrogradely to the main trunk of the facial nerve. And branch of the stylomastoid artery. It is a branch of the posterior auricular artery. No lies medial to it, and mastoid process.
Okay. Okay, good.
Thank you, sir.
Okay, you can leave.
Yes. Dr. N. Shweta. Dr. N. Shweta, are you there?
Pranit is coming on the screen. Ramesh or Mohan Reddy sir, moderator.
Sir, Pranit sir, moderator.
Manish.
Okay.
Sir.
Shweta or Pranit?
Pranit is moderating, sir.
Moderator.
Okay.
Yeah.
Dr. Shweta, are you ready?
Sir, Shweta has not responded, sir.
Okay.
Yeah, next candidate.
Manju.
Dr. M. Manju. Dr. M. Manju.
Are you there?
Yes, sir.
Yeah.
You continue, ma.
Please share your screen.
Good morning, sir.
Good morning.
Share your screen first.
Good morning, Manju. Good luck. I think a lot of tension is there, Manju.
Be relaxed.
No. Sir, video got stuck up. Poor net connection, it seems.
Thank you, sir.
I think Ramesh, can you try for the other candidate?
Topic of cavernous hemangioma, 45 year.
No.
No, you are not audible. Your net connection is poor.
Presented to the ENT.
Manju?
We are not seeing your PowerPoint, Amma.
Sir, let me try one, sir. Sir?
Yeah, try once.
Okay, sir. I'll once again. Yes, sir. Yes, sir.
Request all the candidates, please ensure good net connection. Yeah. Full screen. F5.
Sir, are you able to see my
audio is poor.
screen, sir? Yes, sir.
Check your audio.
Yes, sir. It's full screen, sir.
No, we are not seeing.
We are not getting that.
Can I start, sir?
No.
Yes.
No. Okay.
Okay.
We are seeing full screen. Okay. You can start.
Sir, is it okay now?
Right.
Sir, is it okay now?
Okay, let us try.
Yes. Go on.
Sir, one minute, sir. Sir, 1 minute, sir. Okay, sir. Okay. My rare entity.
Okay,
a 45-year-old female
start.
presented to ENT OPD with chief complaints of swelling below the lower jaw on the right side since 2 years. History of presenting illness. Patient was apparently asymptomatic 2 years back, after which she developed swelling below the lower jaw on right side. It was insidious in onset, gradually progressive, started as a small marble-sized swelling, increased to attain the present size. It is not associated with pain, fever, and discharge. No aggravating and relieving factors were noted. No history of loss of appetite and loss of weight. Past history, she is a known case of hypothyroidism since 3 years and she was on tablet Thyronorm 50 microgram OD. No other comorbidities was present. Personal history and family history are nil significant. On general examination, patient is conscious, coherent, cooperative, and there is no pallor, icterus, cyanosis, clubbing, koilonychia, generalized lymphadenopathy, and no edema. And the vitals are stable, and the systemic examination are normal. On inspection, a solitary smooth globular swelling that is approximately 4 × 4 centimeter size noted in the right submandibular area, extending from the angle of the mouth to the hyoid bone in the midline. And the margins are well defined, and the skin over the swelling is normal, and the surrounding area is normal. No other visible scars, sinuses, pulsations over the swelling. On palpation, all inspectory findings are confirmed, and the swelling is non-tender. It is mobile, soft in consistency, non-fluctuant, and non-transilluminant. And the skin over the swelling is pinchable. There is no local rise of temperature over the swelling. On auscultation, no breathe was heard over the swelling, and no other swellings in the neck was noted. Rest of the ENT examination is normal. My provisional diagnosis was benign tumor of the right submandibular gland. On further workup, routine hematological investigations profile turned out to be normal. On ultrasound examination of the neck, the right of size 3 × 3.8 into 2 with heterogeneous echo texture, and it is extending to the right sternocleidomastoid detected on the ultrasound. Left submandibular suggestive of vascular lesion and soft tissue density mass lesion in the sublingual region that is closely abutting the submandibular gland, showing mild enhancement post-contrast. Calcific foci noted within the lesion, likely pleomorphic. On MRI neck, showed a slow flow vascular malformation of likely hemangioma. This is a CCT neck showing the phleboliths in the submandibular gland post-contrast. And this is the MRI of T2 wave and still images showing the high intensity, high signal intensity in T2 wave images and the still images. Then it is planned for excision of right submandibular salivary gland. The swelling and the incision was marked below 2 centimeters of the inferior margin of the mandible, and the incision was given, and subplatysmal flaps were elevated with carefully preserving the marginal mandibular nerve, and the facial artery was ligated and cut, and submandibular gland duct was identified and ligated and cut, and the gland was excised in toto with the hemangioma, and it was sent for histopathology. On histopathology, it suggests to a vascular malformation, that is the cavernous hemangioma of submandibular salivary gland. And the post-op care, patient was on antibiotics and drain was removed on the 3rd day, and the removal done on 7th, suture removal done on 7th day, and the post-op wound was healthy. Hemangiomas involving the major salivary glands are uncommon in adults. Those that do occur are more common in the parotid gland of about 87.5% than in the submandibular gland of about 12%. Hemangiomas are classified as either capillary or cavernous. Cavernous type is characterized by the dilated thin-walled vascular spaces that are filled with blood and lined by markedly flattened endothelial cells. The vessels may be arranged in a roughly lobular arrangement or a diffuse episode pattern. 90% of hemangiomas are presenting only in their first 3 decades of life, but in our case, it has presented in an old age group, that is adult. Hemangiomas in the submandibular gland are twice as common in the females than in the males. The treatment of choice in this case is surgical excision without angiography and the need for embolization. Thus, the rare presentation of hemangioma in adults should be kept in mind in the differential diagnosis of submandibular swellings. Thank you.
So, intraoperatively, did you come across any bleeding?
No, sir, there was no so much of bleeding, sir. There was moderate amount of bleeding.
Okay. Have you reserved any blood for this patient? Anticipating bleeding?
No, actually, yes, sir. We have reserved blood, but since there was no intraoperative bleeding, there was no so much bleeding. So we haven't transfused.
No, have you reserved or not?
Yes, sir. We have reserved, sir.
Okay. Okay. Post-operatively, how was the post-operative period? Were there any complications?
No, sir. Post-operatively, the patient doesn't have any complications. She was on antibiotics and she was doing fine, sir.
Not even marginal mandibular weakness.
No, sir.
Mhm. Okay. What other nerves can get injured during excision of submandibular salivary gland?
Hypoglossal nerve and lingual nerve can be injured during the submandibular gland excision, sir.
Mhm. So what will happen if the hypoglossal nerve gets injured?
Deviation of the tongue, sir.
To
Deviation of the tongue to the hello. Deviation
yeah,
of the tongue, sir.
to which side?
Deviation of tongue to the same side.
Okay, good. Lingual nerve injury produces what?
It produces general sensation in the anterior 2/3 of the tongue. So sensation will be lost, sir, in the anterior 2/3, sir.
Okay. Thank you.
Thank you, sir.
Dr. Bhuvaneshwari.
She will present last.
Bhuvaneshwari, sir.
Yeah. Next to Navina.
No. Sweta is not done, no?
Sweta not done. Bhuvaneshwari not done. Probably they will present in last session, sir.
Okay.
Next is Navina.
Number
Next,
30
Navina,
is
30
presenting.
Yeah,
30.
30. Number 30, T Navina.
Okay.
Share your screen.
Yeah, sharing, sir.
Navina, are you ready?
Yes, sir. Yes, sir.
Okay. Good morning.
Good morning. Good morning, everyone.
Full
My
screen, full
topic.
screen. Okay, start.
Yeah.
Good morning,
Okay,
everyone.
go
My
on.
topic is low-grade B-cell lymphoma of uvula. Introduction. Uvula is a conical pendulous projection hanging from middle lower part of soft palate. Uvular enlargement may occur by trauma, infection, and allergies. Malignant neoplasms of uvula are rare. Here we are reporting a case of low-grade B-cell lymphoma of uvula in a 55-year-old man. Case history: a 55-year-old male resident of Zahirabad, carpenter by profession, came to ENT department with complaints of dysphagia, progressive throat swelling since 1 month, and fever since 1 week. Patient was apparently fine 1 month back. He woke up in the morning with some oral discomfort, which he neglected it, and by evening he experienced mild pain during swallowing. He noticed uvular enlargement, after which he took some local medications given by the pharmacy. Pain got reduced for a few days, but oral discomfort and swelling continued. 1 week back, he again experienced mild dysphagia and fever, which he came to ENT department for treatment. He had no history of cough, cold, sneezing episodes, allergies, asthma. Past history: he had no tuberculosis, leprosy, epilepsy, no history of trauma, allergies, infections, and viral diseases. He had peritonsillar abscess that has been trained 30 years prior. No history of diabetes and hypertension. Family history is not significant. Personal history: mixed diet, sleep sufficient, and no history of tobacco and alcohol consumption. General physical examination: moderately built, well nourished, well oriented to time, place, and surroundings. He had a noticeable hot potato voice but no stridor. Vitals are normal. Temperature is 99.4 Fahrenheit. No pallor, icterus, lymphadenopathy, clubbing, and pedal edema. Systemic examination was normal. On local examination, lips, teeth, gums, buccal mucosa, anterior 2/3 of the tongue, floor of the mouth, hard palate was normal. And soft palate showed mild inflammation noted at the base of the uvula. Uvula is enlarged, reddened, approximately 2 centimeters in length. Anterior pillar, tonsil, posterior pillar, posterior pharyngeal was normal. The picture showing uvular enlargement, and on palpation, uvula revealed enlarged uvular mass, elastic hard in consistency. Rest all ENT examination was normal. And routine blood investigations were normal, but WBC differential count showed an increase in the lymphocytes about 55%. Urine analysis was normal. HIV, HBsAg was non-reactive, and chest X-ray was normal. MRI showed significant uvular enlargement. extending up to tip of the epiglottis. This is the MRI showing uvular enlargement. And we have done surgery. Uvular mass is excised by electric knife and coagulated with a safety margin of 2 mm. Operative assessment revealed uvular hypertrophy of 10 to 15 times the normal size. This is post-operative picture, and post-operative period was uneventful. And on sending to histopathology, it revealed a low-grade B-cell lymphoproliferative disorder, and molecular studies demonstrated B-cell clonality, and pathological diagnosis favored extranodal marginal zone lymphoma. There was no recurrence during 1 year period follow-up. Discussion. Initial management of a patient with uvular enlargement necessitates evaluation of upper airway. Recent surgical procedures may indicate traumatic intubation or lymphatic disruption in the case of tonsillectomy. A thorough alcohol and tuberculous tobacco use history must be taken because these substances are risk factors for squamous cell carcinoma. Rare neoplastic process must be ruled out, particularly when the presentation is of more chronic and progressive disorder. We should suspect malignancy. Low-grade lymphomas of head and neck almost typically present with obstructive symptoms and undergo an indolent course, rarely requiring treatment except in case of blastic transformation or autoimmune complications. Now, indication for treatment are symptomatic relief and plastic transformation. Interventions include surgery and chemotherapy or both. Uvulectomy was recommended in our patient for symptomatic relief and to provide a definitive diagnosis. Steroids were prescribed preoperatively to reduce uvular enlargement. For our patient, frequent follow-up with an oncology specialist was recommended to monitor the progression of disease, but chemotherapy was not immediately started because PET scan was stable and absence of clinical symptoms. Although uvular enlargement often presents acutely, the unique presentation in this case and a more progressive presentation may indicate an underlying neoplastic process. Thank you, sir.
Okay. Dr. Mohan Reddy, adutara?
Yeah, it's some kind of a rare case.
Yes, sir.
Uvular swelling. What is the differential diagnosis? You can you enumerate any differential diagnosis on this?
Yes, sir. Uvular enlargement is commonly caused by trauma, infections like Epstein-Barr virus, flu, and streptococcal sore throat, and allergies, and very rarely angioedema of uvula.
Yeah.
Any tumors? Any other tumors you can?
Squamous cell carcinoma, sir, of uvula.
Yes.
Yeah.
Rarely even schwannomas. Can you think of schwannomas? They are seen relatively common in oropharynx.
Yes, sir.
Just not aware of.
Literature you mentioned about this kind of a presentation. Anything? Incidents?
Sir, it is very rare, sir. Usually, this marginal B-cell lymphoma usually it occurs in gastrointestinal tract, sir. But uvula only 1 to 2 cases are reported, sir.
So it's isolated location and isolated to the uvula itself. Nothing else. Any other possibility of looking towards other sites?
Yes, sir. We need to look stomach, sir, gastrointestinal tract, spleen, skin, eye, sir, and thyroid.
Was any
Sites.
was any ultrasound abdomen done for this patient?
Sir?
Was
PET.
any ultrasound abdomen? Oh, PET
Yeah,
was
sir.
PET scan.
No,
Oh,
PET scan we have done, sir.
Okay.
Okay.
Thank you, sir.
Dr. Salman Raj.
Sir, good morning all, sir.
Right. Morning, Salman.
Good morning, sir.
Morning.
Ramesh, sir, good morning, sir.
Morning.
Sir.
Go ahead, Salman. Share your screen.
Sir.
Yeah, full screen.
Sir, is my screen full, sir, right now?
Yeah, it's
Yeah,
full.
yeah. You can start.
Sir, good morning, all, sir. Today I am presenting a rare case of ancient schwannoma. Ancient schwannoma are rare encapsulated tumors of long duration and are benign in nature. The tumor is solitary and may grow to a large size before detection of notable degenerative changes have happened. The term ancient schwannoma is used to describe a tumor that has undergone changes characterized by relative loss of Antony type A tissues, perivascular hyalinization, calcification, cystic necrosis, hemorrhage, and the presence of degenerative nuclei that may be misinterpreted as sarcomatous pleomorphism. Ancient schwannoma is an uncommon schwannoma variant with a course typical of a slow-glowing neoplasm. The term ancient was proposed to describe a group of neural tumors having degenerative changes and diffuse hypocellular areas. These lesions are often erroneously diagnosed as malignant tumors because they present with atypical features. A 52-year-old female patient came to her OPD with complaints of nasal blocks in 6 years, intermittent headache, inability to open the right eye, swelling around the right eye, deviation of the right eyeball. Patient was apparently asymptomatic 6 years back when she noticed a small swelling in the right middle canthus, medial canthus, which grew to the present size of the size of a ping pong ball. On diagnostic nasal endoscopy, mass was seen in the middle meatus, which is smooth in consistency, which is covered by mucosa, pushing the middle terminate medially towards the septum. On probing, the growth was smooth, which is not painful and not bleeding untouched, and the probe can be passed inferiorly and medially, but not superiorly and laterally. A differential diagnosis was frontal mucosal, polyp, inverted papilloma, granulomatous infection, meningioma, carcinoma of maxillary sinus, schwannoma, neurofibroma, perineuroma, malignant peripheral nerve sheath tumor. Routine-based investigations were done, which were normal. Ultrasound guided FNAC showed acute suppurative inflammation. CT-PNS was done, which showed enhancing soft tissue density in the frontal sinus, which was more on the right side, causing expansion and erosion of the frontal sinus with erosion of the cribriform plate. Suspicion of intracranial extension was seen. Opacities in both the maxillary sinuses was seen. MRI suggested frontoethmoid mass with intracranial extension. We carried out an endoscopic biopsy of the right intranasal mass on 27 December 2019. Routine histopathological examination along with immunohistochemistry suggested of ancient schwannoma. With standby from the neurosurgery team, transnasal endoscopic removal of the sinonasal mass was done on 7 January 2020. A soft, easily suckable tumor noted in the right frontoethmoidal and orbital cavity with doubtful origin from the anterior ethmoidal nerve branches. Intraoperatively, pulsatile CSF leak was noted near crista galli, which was repaired using middle turbinate mucosa. This is the intraoperative picture and immediately after the excision of the growth. This is a histopathological picture and immunohistochemistry, which showed S100 strong positive. Pathology showed ancient schwannoma. Post-operatively, patient was put on IV antibiotic, analgesics, antihistamines. No CSF leak was seen in post-operatively. Post-op MRI suggested post-op changes in frontal and ethmoidal sinuses with mucosal thickening noted bilaterally, maxillary and ethmoidal sinuses. Post-operatively, patient improved symptomatically and hence was discharged with medication on post-op day 7. Discussion. Schwannoma originate from myelinated Schwann cells of the nerve sheath and are recognized by the presence of spindle cells with Antony A and Antony B regions. These are designated as ancient when either cystic or degenerative fatty degeneration is seen, or focal accumulation of hyaline material, thick capsule, infiltration of histiocytes, siderophages, and hyperchromatism are encountered. These histopathological features are attributed to the long duration of schwannoma. Misdiagnosis of these lesions as sarcomas might arise due to the presence of hypercellularity and atypia. Tumors such as hemangiopericytoma, leiomyoma, leiomyosarcoma, and malignant melanomas often resemble schwannoma. Moreover, the key feature of differentiating a benign ancient schwannoma from malignant schwannoma is the absence of any mitotic activity. Further, the presence of the capsule thick-walled and areas representing degenerative changes also would suggest the benign nature. Malignant changes in a benign schwannoma are rarely encountered. The diagnosis of malignant change of a benign schwannoma is based on areas of increased cellularity, numerous mitosis, anaplastic cells, and invasiveness, along with the absence of clinical evidence of neurofibromatosis. The treatment of choice for schwannoma is surgical excision with preservation of the function and integrity of the involved nerve. Grafting of defective nerve segments is done in cases where preservation of the nerve is not possible. The nerves being small in size are rarely encountered during surgical resection of the schwannomas. These are my references, sir. Thank you, sir.
Next, Salman.
Okay, very good case.
Thank you, sir.
Very good case.
Thank you, sir.
So, no. Was it addressed externally by
No, sir. It was endoscopic nasal excision was done, sir.
Totally, even the frontal lesion is also.
Yes, sir. Even the frontal is done endoscopically, sir. Modified RAP
neurosurgeon,
procedure.
he was just there standby.
Yes, sir. Neurosurgery standby was there, sir.
So everything is done by ENT surgeon itself.
Yes, sir. It was done by ENT surgeon.
Good.
Sir.
What about CSF leak?
CSF leak was repaired on the table, sir. It was there from Crista galli. That medial turbinate from mucosa from the inferior turbinate was taken and it was repaired, sir. It was a mild leak, sir. Pulsatile. Middle turbinate was taken. Middle turbinate, sir. Mucosa from the middle turbinate was taken and was. Sir.
So post-operatively, there was no CSF leak.
No, sir. Post-operatively, diagnostic and nasal endoscopy was done, which did not reveal any active CSF leak, sir.
Okay.
How much defect noticed, Salman?
Sir?
How much defect do you notice the pulsatile CSF leak?
Sir, it was very small, sir. It was like almost less than a centimeter was there, sir.
Centimeter or millimeter?
Less than a centimeter, I'm sorry, sir. It was 5 mm or 6 mm.
No, that is, so you tucked the mucosa of the middle turbinate, or how you your people managed?
Sir, we tucked the middle mucosa, meatus mucosa, sir.
So any side you want to prefer, lateral side or medial side of mucosa?
Sir?
Any important?
Lateral side of the middle.
Lateral side, outside or inside?
I didn't get it.
Okay.
No. Mucosal inner surface.
Inner surface, outer surface. Okay, don't worry. Thank you.
Yes, sir. Like we have to invert it, sir, because there should not be any mucosal growth into the thing. So we have to outer surface is placed up and inner surface is placed down.
Okay, nice.
Sir. Yes.
Mohan Reddy, sir, anything? Mohan Reddy, sir.
What was the diagnosis kept in mind before? What was the diagnosis kept in mind before taking up for surgery?
Actually, we thought of any frontal mucosal.
Hello?
Sir, we thought of frontal mucosal, sir. Can you hear me, sir?
Yes.
Mucosal.
Yes, sir.
Yeah, you can.
Schwannoma, sir.
What was the what made you to?
Hello, sir.
There was no smooth bulging swelling like that, no, in this image. In the image, mucosal looks, with a very well-defined smooth margins.
Sir,
Here,
sir. There was frontal swelling present.
Margin, and there was erosion of the bone also more. Yeah.
Sir, looking at the diagnostic endoscopy, it was more of a smooth.
Okay, a smooth bulge.
Sorry, sir.
Okay. Any other any other kind of imageology will help in this kind of a situation? How it can be differentiated with MRI, or
it can be differentiated with.
Did you consult with the radiologist, your people?
Yes, sir. MRI was done for this patient, sir.
What will be the radiological differentiating findings with MRI? What was the opinion by the radiologist? How can this be differentiated from inverted papilloma, mucosal, and all?
Radiologically.
Have you had any discussions with the radiologist?
Yes, sir.
It's okay. Okay.
Good morning, everyone. Am I audible, sir?
Yeah, you are audible. Share your screen.
Yes, sir. Good morning, everyone. Today I'm Dr. Zeba Kausar. Today I'm presenting a rare case of pig bronchial anomaly.
Okay.
Full screen.
Okay,
We
go
report
ahead.
to you a case of 14-month-old female child who presented to the OPD with complaint of accidental inhalation of foreign body 2 hours earlier. There were no complaints of dyspnea or stridor or respiratory distress and no history of choking episodes. On examination, the patient was conscious and coherent, no pallor, no icterus cyanosis or generalized lymphadenopathy. On examination of respiratory system, bilateral air entry was present and no adventitious sounds were heard. Other system examination was normal and vitals was stable. Investigations on X-ray chest in the lateral view, there was a small radio-opaque foreign body seen in the left upper lobe. Bronchoscopic removal of the foreign body under general anesthesia was planned and performed. During the bronchoscopy, it was incidentally noted that the child had additional third bronchus arising directly from the trachea above the level of carina on the right side. The foreign body was extracted and patient revived. Later, CECT was performed to confirm the bronchoscopic finding of the tracheal bronchus, and 3D reconstruction of images was done. This is the bronchoscopic image showing an additional third bronchus here on the right side. And this is the CECT image with reconstruction, 3D reconstruction, showing a additional bronchus here on the right side. Coming to introduction of tracheal bronchus, the tracheal bronchus is an aberrant accessory or ectopic bronchial branching which originates from the right lateral wall of trachea. It occurs as a result of an additional tracheal outgrowth early in embryonic life with an incidence of 0.1 to 2%. The most common ones of the abnormal tracheal origins is that of right upper lobe bronchus, usually less than 2 cm above the carina, also referred to as bronchus suis or pig bronchus, which is a normal finding in cattle and pigs. This anomaly usually is diagnosed incidentally during bronchoscopy or bronchography performed for various respiratory problems. The tracheal bronchus is mostly asymptomatic, but it may be associated with recurrent pneumonia, chronic bronchitis, bronchiectasis, and focal emphysematous change. It is pathologically classified into two types, supernumerary and displaced. In the supernumerary type, usual bronchial supply to the affected lung segment is concurrently present. It occurs early in the development at 29 to 30 days as the lobar bronchi start to differentiate. In the displaced type, the usual bronchial supply to affected segment is absent. It is relatively more common than the supernumerary type. This type more likely to occur after 32 days of embryonic life as the bronchi elongate and branch further. According to the anatomical origin in relation to carina, it is classified as type 1, 2, and 3. In type 1, it is located more than 2 cm above the level of carina with narrowing of distal trachea. In type 2, it is located more than 2 cm above the level of carina with normal the diameter of the distal trachea. In type 3, the tracheal bronchus is located less than 2 cm above the level of carina. This tracheal bronchus can also be associated with other congenital anomalies such as Down syndrome, laryngeal web, ribbon vertebral anomalies, tracheal stenosis, congenital heart disease, azygous lobe, partial anomalous pulmonary venous return, and displaced segmental arteries. Coming to discussion, the normal tracheobronchial development is initiated 24 to 26 days as a medial bulge of ventral wall of pharynx that develops as caudal end of laryngotracheal groove. At 26 to 28 days, this bulge gives rise to right and left lung buds. As the lung buds elongate, trachea is separated from esophagus by lateral ingrowth of mesoderm, forming the tracheoesophageal septum. At 28 to 30 days, the lung buds elongate into primary bronchi. At 30 to 32 days, 5 lobar bronchi appear as monopodial outgrowth of primary bronchi. All segmental bronchi are formed by 36 days. 3 main hypotheses have been formulated for the formation of anomalous bronchi: reduction, migration, and selection theories. Because of the embryonic abnormality, the main bronchial abnormalities include accessory cardiac bronchus and the tracheal bronchus. So, in every pediatric patient presenting with non-resolving respiratory symptoms, it should be investigated to exclude other congenital anomalies of the tracheobronchial tree. If a tracheobronchial bronchus is detected, it is important to exclude other cardiovascular and pulmonary abnormalities.
Next candidate.
Hello.
Yeah.
Next.
Hello. Hello.
Hello.
Next, sir.
Hello.
Sir, if they finish within 4.5 minutes only, you can ask questions, sir. After crossing 5 minutes, next candidate will present, sir.
Okay.
Hello.
Okay. No, she has done within
After
5 minutes.
5 minutes, 5 minutes over, sir.
5 minutes crossed. She has crossed 5 minutes.
Yeah.
Okay.
Yeah, yes, sir. Yes, sir. That's why I will ring, sir.
Okay.
Before 1 minute, I will give a bell, sir. Warning bell.
Yeah.
After finishing, I will give the final ring, sir.
Okay.
Very nice.
If you have any leftover time, you can ask, sir.
Yeah, yeah, understood. 4.5 minutes presentation, half-minute question and answers. Okay.
Yeah, yes, sir. Yes, sir. Yeah,
Thank you, Ramesh.
Sir, thank you, sir. Next candidate.
Hello.
Which
Am
one?
I audible?
Yeah.
Taba.
Good morning. Good morning, everyone.
Good morning. Go ahead.
Good morning. This is Dr. Uzma Mushtaba, MS ENT postgraduate. Today I'm going to present a rare case of lingual thyroid. A 19-year-old female patient presented to the Department of ENT with the chief complaint of foreign body sensation in the throat and dysphagia progressing since a year. History of present illness: she was apparently asymptomatic 1 year back. Initially, she noticed foreign body sensation in the throat and later on developed dysphagia. On examining the throat in the mirror, she could see a lump in the throat which was progressively increasing in size. Not associated with pain, there was no history of dysphonia, upper airway obstruction, or hemorrhage. There was no history of obstructive sleep apnea. There was history of weight gain. Past history: no history of similar complaints in the past. Family history was not significant. Personal history: diet, vegetarian, appetite decreased, sleep normal, bowel and bladder movements normal, no addictions. On general examination, patient was conscious, coherent, cooperative, moderately built, well nourished, vitals was stable. On systemic examination, all the systems were normal, all the cranial nerves intact. On ENT examination, ear, nose were normal. On throat examination, oral cavity was normal. In the oropharynx, tonsils and pillars, soft palate and posterior pharyngeal wall normal. Valleculae were normal. Base of the tongue, which is best seen by indirect laryngoscopy, showed a submucosal, smooth, pink, firm mass at the base of the tongue. Rest was normal. On neck examination, trachea was in the midline, bilateral carotid pulsations present, laryngeal crepitus present, no neck nodes were palpated, no thyroid gland was palpated on its normal pretracheal position. Provisional diagnosis was lingual thyroid.
అది పోస్టర్ పైన అట్లా అంటే అది లింక్ ఓపెన్ కాదు సెపరేట్ గా లింక్ పెట్టు
On investigations, the blood tests were normal.
సెపరేట్ గా అందుకే ప్రైవేట్ గా పెట్టాను
Chest X-ray normal.
Thorax, sir, please mute your
And the ECG normal.
audio.
The thyroid function test, TSH levels were raised, T4, T3 were within the normal
Thorax,
limits.
sir, please mute your audio.
Showing hypothyroid state. This is the contrast enhanced CT scan of the neck, showing a hyperdense lesion of the size 23 by 23 mm in the posterior part of the tongue, suggestive of lingual thyroid. The thyroid fossa was empty. The rest was normal. This is the technetium pertectinate thyroid scan, showing no significant tracer uptake in the normal pretracheal location of the thyroid, as well as in the region of the base of tongue, possibly due to drug interference. The contrast used during the CT scan, because of that, there was an error in the technetium thyroid scan report. Otherwise, there would have been uptake in the region of base of tongue. Management: initially, as the patient was in hypothyroid state, the hormonal treatment was given with tablet Thyronorm for a period of 3 months, after which she came into euthyroid state, which was followed by surgery. Excision was done through transcervical approach under general anesthesia. The lump was removed with the help of cautery and sent for histopathological examination. Postoperatively, the patient was hemodynamically stable and was put on lifelong thyroxine therapy and advised to get thyroid profile done every 3 months. These are some intraoperative procedure pictures. Histopathological report showed a capsulated lesion enclosing the thyroid tissue with aggregates of large follicles filled with abundant colloid lined by benign epithelium. There was no evidence of cytological atypia. Features were consistent with clinical diagnosis of lingual thyroid. Discussion: lingual thyroid is a developmental disorder due to failure of thyroid gland to migrate from its analge, foramen cecum, to its prelaryngeal site. The most common location is in the lingual zone. Lingual thyroid is the most common clinical detected thyroid ectopia, more common in females. Mostly symptoms are dysphagia, dysphonia, upper airway obstruction, hemorrhage. Over half of the patients are hypothyroid. Most of the patients have no other thyroid tissue in the neck. This is the conclusion. These are the differential diagnosis of midline base of tongue lesions: lingual tonsillitis, thyroglossal duct cyst, dermoid, lingual abscess, squamous cell carcinoma of base of tongue, lymphatic malformations, and hemangioma. These are my references. Thank you.
What was the indication for surgery in this case?
She was having dysphagia, sir. Dysphagia and feeling of lump in the throat.
That feeling you said, but you said there is no dysphagia, no.
There was dysphagia, sir.
Dysphagia was there.
Yes, it was there, sir. It was progressing. Yes.
So what are the other methods of management of lingual thyroid?
CO2 laser can be used, or radio ablation of the gland can be done. And there are other approaches like transoral approach. And
Can you think of coablator?
yes, coblation can be done. Coblation.
Okay.
Thank you.
Thank you.
Is it Siddhartha ready? Are you ready?
Yes, sir. I'm ready.
Good morning. Good morning,
Good
Siddhartha.
good morning, sir. Yes, good morning, sir. I'm starting screen share. Good morning, sir. I'm Dr. N. Siddhartha. I'm presenting a case of chronic suppurative otitis media with complicated with cerebellar abscess. Sir, shall I continue?
Yeah, please.
Oh, yes, sir. Introduction. Chronic suppurative otitis media is most troublesome problem with most of the which gives rise to intracranial complications and extracranial complications. Most common intracranial complications are meningitis followed by otogenic brain abscess. Most of the times, it is temporal lobe abscess. Cerebellar abscess is not as common as temporal lobe abscess. Management mainly comprised of drainage of abscess followed by mastectomy. So coming to our case details, a 42-year-old male patient came to ENT OPD with presenting complaints of giddiness associated with vomiting since 15 days. There is history of left ear discharge since childhood, which is greenish yellow, scanty and false smelling. Decreased hearing since 1 year, insidious in onset, slowly progressive. No history of ringing sensation or mouth deviation, headache, visual abnormalities, seizures, neck rigidity and any other comorbidities. So on examination, general examination is normal, vitals are stable. Local examination, in left EAC, there is greenish yellow discharge. On left ear microscopy, after suction clearance done, we noticed a grade 3 pastensor retraction and there are aortic cholesteatoma flakes. On neurological examination, there are intentional tremors, dysdiadochokinesia, dysmetria, nystagmus, horizontal fast components towards left side. So we ordered radiology and CT scan temporal bone suggestive of left chronic suppurative otitis media with cholesteatoma and aortic adenomatous mastoid antrum with erosion of sinus plate and subdural empyema with hydrocephalus. Then MRI suggestive of multilobar crescentic lesion in the cerebellar hemispheres, more on left side, mildly hypointense on T1 and hyperintense on T2. Contrast study shown peripheral enhancements of the lesion. So we referred the patient to our neurosurgical team. Our neurosurgery team performed medial suboccipital craniotomy with drainage of abscess under general anesthesia and first sent for culture sensitivity, which came out to be of Klebsiella species. There was no residual signs of intracranial complications after the surgery. Patient was comfortable on IV antibiotics and with frequent dressings. Patient referred back to ENT department once patient got stabilized after craniotomy. Mastectomy. Approximately 1 month after craniotomy, mastoid exploration planned. Canal wall down mastectomy performed to ensure the complete removal of disease to reduce the chances of recurrence. Patient got postoperative giddiness, which subsided on treatment. Patient was comfortable while discharged and is on regular follow-ups. Postoral craniotomy site and postoral site are healthy. Mastectomy cavity also healthy at 3rd month follow-up. So So coming to discussion part, patients with chronic suppurative otitis media and cholecystioma are usually strongly associated with intracranial abscess. And since most of the patients were treated with antibiotics prior to the development of the intracranial complications, they may not present with typical symptoms and signs. Most of the patients will present with malodorous otorrhea or an headache, or patient presented with vomiting and giddiness. Several literatures have reported that brain abscess more commonly located in the temporal lobe than in the cerebellum. Recent trends show increased incidence of cerebellar abscess. Spread of the middle ear infection to the cerebellum usually occurs through Trotman's triangle, retrograde venous thrombophlebitis, and periarterial space of Virchow Robbins. And there are controversies regarding timing of neurosurgical and otological surgery. Immediate mastectomy within 2 days along with neurosurgical drainage of the abscess was recommended by some authors to reduce mortality and enhancements of the treatments of the antibiotic. Another study suggested that there is no difference in outcomes between immediate otological and delayed otological surgery. In our case, we delayed otological surgery to stabilize the patient after craniotomy. Conclusions: even though it is not common, CSOM can be complicated by cerebellar abscess and number of cases are increased in recent times. Classical symptoms of intracranial complications may not be there and patient may present with vague symptoms like vomitings and giddiness. Despite of controversies, mastectomy can be planned at later date, preferring drainage of abscess as an immediate intervention. Thank you, sir.
Siddhartha?
Yes, sir.
What is the Trotman's triangle?
It is a triangle between posteriorly lined by sigmoid sinus and superiorly superior petrosal sinus, anteriorly by the solid angle or semicircular canals, which gives way to intracranial complications.
Nice. I think your time is over.
Yes, sir.
Nice presentation, Siddhartha.
Thank you, sir.
Okay, thank you.
Dr. Susmita.
Am I audible, sir?
Yes.
Good morning, sir. I'm going to present a case report of olfactory neuroblastoma. It is olfactory neuroblastoma is an uncommon malignant neoplasm of the nasal arising from the olfactory neuroepithelium. It was Berger and Love first described the tumor as neuroepithelium. According to WHO, olfactory neuroblastoma is defined as malignant neuroectodermal tumor.
Fan is there? Fan is there with you?
Olfactory receptors present high in the nasal cavity. Most common site being the frontale and superior nasal concha and anterior scapula. This here is a case report of a 68 years old male patient, resident of Hyderabad, is a carpenter by occupation, came to the OPD with a complaint of bleeding from the nose since 4 months and right side nasal obstruction since 3 months. Coming to the presenting illness, the patient was apparently asymptomatic 4 months back, then developed bleeding from the nose, which was inside, provocative in nature, and it was more while blowing the nose, and the bleeding was moderate in amount and relieved spontaneously. And there were about 8 to 10 episodes in 4 months of duration. And the other complaint was a right-sided nasal obstruction since 3 months, which was insidious onset, progressive, no aggravating or relieving factors. And there were no diurnal variations or positional changes. And there was a history of loss of sense of smell on the right side, and no history of visual loss or headache. On anterior rhinoscopy, a single fleshy mass was seen in the right nasal cavity. On probing, the mass was soft in consistency and probe could be passed all around and insensitive to touch and was non-bleeding. And in diagnostic nasal endoscopy, there was a single fleshy mass in the right nasal cavity. The CT-PNS showed a homogeneous opacity in the right nasal cavity, anterior and posterior at the mouth, and there were no bony erosions of the plate. And then patient was posted for excisional biopsy, and the general anesthesia and endoscopic guided excision was done and sent for HO. And procedure was analyzed. And on the histopathological report, it showed well differentiated homogeneous small cells with uniform round to oval nuclei with flexmo-intestinal rosets and fibrillar material and mitotic features. And immunohistochemistry showed positive for S100 protein and neuron-specific endotype. It was graded as Kaddish stage B and Hines grade 3 stage, and the patient was sent to Cancer Institute for further radiotherapy. It is coming to the discussion. Olfactory neuroblastoma accounts for 2 to 3% of all sinonasal malignancy. Incidence is 0.4% in million population. The site of origin is from the Jacobson nasal organ, fever, palatine ganglion, ectodermal olfactory plateau, autonomic ganglion, and the nasal mucosa olfactory. It's a bimodal in age. It's most common in the 2nd decade and the 6th decade, and it's more common in female. And most common symptoms are nasal obstruction, epistaxis, headache. In advanced stages, there are orbital symptoms like visual loss. The aggressiveness of this tumor is determined by cavitization. In stage A, the tumor is confined to the nasal cavity alone. In stage B, the tumor involves nasal cavity and the paranasal sinuses. In stage C, the tumor is extended beyond the sinonasal cavities into the water. And histopathologically, it's graded as Heinz grading. It's grade 1. It's a well differentiated. In grade 1, it is well differentiated small round cells. In grade 2, it's pleomorphism and less fibrillary stroma is seen. In grade 3, flexular intestine rosettes are seen. In grade 4, it's anaplastic. The treatment is mainly the surgery and then followed by radiotherapy. Differential diagnosis is nasal and paranasal sinuses, squamous cell carcinoma, sinonasal polyposis, and neuroendocrine tumor, malignant melanoma, and non-Hodgkin. Conclusion. Olfactory neuroblastoma is a rare malignant tumor with varied clinical behavior. A proper diagnosis should be made clinically, radiologically, and histopathologically. Surgical resection and radiotherapy is the main treatment and should be followed up carefully as their recurrences are more common. These are my differences. Thank you.
Sorry, some drilling is going on in someone's house. Please mute your audio.
Yes.
I think the presenter's house only.
Yeah.
Oh, sir, it's outside.
Not presenter's house. So faculties.
Sorry,
It's
sir,
okay.
for the disturbance.
We'll go for the next because we can avoid the disturbance. Anyway.
Next candidate.
Pratibha. Yeah.
Good afternoon, everyone.
Yeah.
Let's start.
Good afternoon, everyone. Today I'll be presenting a rare case of invasive fungal sinusitis by Candida species causing blindness. Invasive fungal sinusitis is common in immunocompromised patients. The common offenders are Aspergillus and Mucor. Candida is a yeast-like fungus which is a commensal in the oral cavity and skin. Invasive fungal sinusitis due to Candida is rare. Central retinal artery occlusion is an ocular emergency where the patient presents with acute painless loss of vision, which can be either unilateral.
Full screen, please.
Unilateral or bilateral. CRAO is an ocular emergency. The risk factors are hypertension, diabetes, and smoking. It can also occur due to infiltration of the central retinal artery by fungi from the orbit. Cavernous sinus thrombosis is a serious condition where the patient presents with headache, swelling of eyeball, ptosis, restricted ocular movements, visual loss, fever, and altered sensorium. Here is a 41-year-old gentleman who is HbSAg positive, diabetic, non-smoker, non-alcoholic, presented with complaints of history of headache, fever, right facial swelling, nasal obstruction, running nose since 10 days. As he developed ptosis, chemosis, and swelling of the right eyeball, in spite of a course of IV antibiotics, he is referred to us for further management. On examination, there is right facial swelling with difficulty in opening of mouth. The right eye findings are eyelid drooping, underlying congested eyeball, restricted eye movements, vision is decreased, counting fingers are absent, perception of light is present, pupils are fixed and dilated. The left eye is normal. There is DNS to left with bilateral ITH. A preliminary suspicion of invasive fungal sinusitis with cavernous sinus thrombosis was made, and the patient was in sepsis at the time of admission, which is evident with the high blood counts. Patient was started on IV antibiotics. A CT-PNS was done, which showed haziness in the left maxillary sinus, but the complaints were on the right side. MRI brain revealed left invasive fungal sinusitis along with cavernous sinus thrombosis. Within 24 hours of his admission in our hospital, patient rapidly progressed to develop proptosis, chemosis in both eyes. visual loss in both eyes with restricted ocular movements. Urgent FES under local anesthesia was done, which revealed devitalized tissue in the maxillary sinus, which when sent for frozen amount showed negative for fungus. Fungal and gram stains were negative, culture sensitivity was negative, and cryptococcal antigen was negative. But in spite of strong suspicion of fungal etiology was made and patient was initiated on IV antifungal therapy. In spite of the treatment, he rapidly lost his vision on both sides. On fundoscopy, a pale optic disc were found, which is suggestive of bilateral central retinal artery occlusion. The next day, patient developed right hemiparesis due to left middle cerebral artery infarction. A repeat CTPNS was done, which showed haziness in bilateral maxillary sinuses. A revision FES was planned the next day for debulking of the necrotic debris from the sinuses, which on frozen section revealed no fungal elements, gram stain was negative, and histopathological examination revealed dense colonization by candida with many yeast forms. Patient was started on liposomal amphotericin B under close monitoring of the renal functions and is advised to continue the treatment for a minimum of 6 months. Coming to discussion, chronic rhinosinusitis with cavernous sinus thrombosis associated with stroke or any vascular occlusion is highly suggestive of fungal etiology, particularly aspergillus and mucor. In spite of non-identification of the organisms in the first biopsy sample, first biopsy sample, we started the patient on empirical antibiotic treatment. To our surprise, repeat biopsy revealed candida in the histopathological examination, which was confirmed by candida on culture. Candida is an uncommon cause of invasive fungal sinusitis, which accounts for only 1 to 2% of the isolates. It is very important to identify the type of fungus so as to start the most appropriate treatment and to stop the direct perineural and hematogenous spread of the fungus. Any patient not responding to conventional antibiotic treatment should raise the suspicion of fungal etiology. Diagnostic nasal endoscopy, CT scan, and repeat FES procedures are necessary to arrive at a diagnosis. The presumptive cause of tissue invasion and intracranial extension in our case is the immunocompromised state of the patient being HBsAg positive, diabetic, and in sepsis. Prolonged and indiscriminate use of antibiotics, steroid sprays, and antihistaminics in chronic rhinosinusitis patients might have contributed to fungal infections of the paranasal sinuses by suppression of the normal bacterial flora. Conclusion: any long-standing case of chronic rhinosinusitis can have superadded fulminant chronic rhinosinusitis along with cavernous sinus thrombosis.
Time cross.
Urgent and sometimes repeat biopsy is necessary for correct diagnosis.
Must stop there. Next candidate. Dr. Anirudh Kumar.
A very good afternoon, sir. I'm Dr. R. Anirudh Kumar. I'm presenting a rare case on Branchio-otorenal syndrome. Introduction. Branchio-otorenal syndrome is a condition that disrupts the development of tissues in the neck and causes malformations of the ears and kidneys. It is an autosomal dominant genetic condition that can vary greatly from one person to another, even in members of the same family. Mutations in 3 genes, those are EYA1, SIX1, and SIX5, have been reported in the people with Branchio-otorenal syndrome. About 40% of the people with this condition have mutations in EYA1 gene. SIX1 gene and SIX5 mutations are much less common cause of the disorder. Branchio-otorenal syndrome is characterized by pits or ear tags in front of the outer ear. Those are preauricular pits, abnormal passages from the throat to the outside surface of the neck, branchial fistulas, branchial cysts, malformations of the outer, middle, and inner ear hearing losses, and kidney renal abnormalities. Case history. A 6-year-old female child came to the ENT OPD complaining of discharge from the retroauricular area. Child was born with right ear atresia and was apparently all right up to 3 months of age. Then she developed CS discharge from the right retroauricular region associated with pain and tenderness. On examination, right ear atresia and sinus discharge pus from the retroauricular area was observed, whereas left ear was on normal. This is the patient. Investigations. Blood investigations were done. where CBP hemoglobin was noted as 9 gram percentage and PCV was 26%. Rest were all in normal limits. The urine culture sensitivity suggested of amikacin sensitive E. coli. Ultrasound abdomen was done where right renal calculus of 10 millimeter was observed. A sinogram was done, a linear tract measuring of 40 millimeter approx is noted extending anteriorly with pooling of contrast in the mastoid region. This was the report of ultrasound, and this is a sinogram showing us the tract. Treatment. Patient was given antibiotics for 10 days preoperatively to control UTI. A combination of iron, folic acid, and vitamin B12 was also given for 30 days prior to the surgery to correct the anemia. Sinus tract was traced and excised under general anesthesia. Post-surgically, she was given again antibiotics, anti-inflammatory for 7 days, and antibiotics was given when needed. We followed the patient up to 6 months with no recurrence of discharge. This is the pic of post-operative after 7 months. Discussion. Branchio-otorenal syndrome is also known as Melnick-Fraser syndrome. It is characterized by an association of brachial fistulas or cysts, ear malformations, which can include inner, middle, and outer ear abnormalities, renal malformations, which can range in severity from renal hyperplasia to agenesis. Inherited in an autosomal dominant fashion, each child of a parent with Branchio-otorenal syndrome has a 50% chance of presenting with the disease. It is thought that 90% of the Branchio-otorenal syndrome cases are due to its inheritance, while the remaining 10% of the cases are due to acquired mutations. Branchio-otorenal syndrome displays variable expressivity, accounting for the difference in severity of symptoms among the family members. In 1864, Heisenberg was the first scientist to recognize the association between brachial clefts, fistulas, preauricular pits, and hearing impairment. In 1975, Melnick et al. And Fraser et al. Described Branchio-otorenal syndrome as a specific entity with an autosomal dominant inheritance pattern. Branchio-otorenal syndrome affects about 1 in 40,000 people. A family history positive bronchial, otologic, and renal malformation is suggestive of Bow syndrome. There are 6 major criteria and 6 minor criteria. These are the major criteria: pinna malformation, hearing loss, preauricular pits, renal anomalies, second branchial arch anomalies, external auditory canal stenosis. And the 6 minor criteria includes preauricular tags, lacrimal duct aplasia, middle ear anomalies, inner ear anomalies, palate malformation or facial asymmetry, and euthyroid goiter. Thank you.
Are there any questions?
Okay, next.
No, next.
Thank you, sir.
Ivani, are you ready? Share the screen.
Your voice is not audible, Shivani.
Shivani, disconnect your headphones.
Disconnect from the laptop and speak directly.
Yes, sir. Are you able to hear me now, sir?
Yeah.
Yes, sir. Today I am discussing a case of unexpected case report on highway to mediastinum. Introduction. Mediastinal infections caused due to descending cervical infections are underreported and may arise from odontogenic, cervicofacial infections, esophageal perforations, or maxillofacial or neck trauma. Its mortality rate is approximately 40%. Even
Full screen.
Even in, sir?
Full screen.
Okay, sir. Even in post-antibiotic era, mediastinitis from odontogenic source accounts for 58% of mediastinal infections. Other causes include retropharyngeal abscess, peritonsillar abscess, cervical lymphadenopathy, parotitis, thyroiditis, neck trauma, traumatic endotracheal intubation, central venous catheter, and iatrogenic cause. Multiple facial compartments, numerous portals of entry, and proximity to vital structures make entry into mediastinum an easier challenge for the infection from the source. It is thus important to have a high index of suspicious and use all possible modalities to rule out complications like mediastinitis and institute prompt therapeutic measures. The 65-year, coming to case report, 65-year-old male truck driver came with swelling and fever from swelling in front of neck and fever from 8 days. Swelling was insidious onset, gradually progressive, and started in the right submandibular area and progressed to the present size. And the fever was continuous, high grade, with chills and rigors, with no evening rise of temperature. And there was no difficulty in swallowing or difficulty in breathing. And patient was a chronic smoker and alcoholic from 20 years. On examination, his temperature was raised and he was having tachycardia. And neck examination showed diffuse swelling in front of neck, which was 10 into 15 centimeters, involving submental and submandibular region with obliteration of angle of mandible on right side. And it was extending 2 centimeters proximal to suprasternal notch. And there was a black necrotic area of 5 into 4 centimeters present in the midline, 6 centimeters distal to mentum. And on palpation, there was tenderness present, local rise of temperature present, and it was soft to firm consistency. And skin was not pinchable. And oral cavity examination revealed an opening present on the buccal side of lower right premolar tooth with caries and discharge coming out on local pressure. And provisional diagnosis was made, deep neck abscess, which was odontogenic origin. So pre-op investigations ordered were USG neck, which showed multi-compartment neck space inflammation with edema of subcutaneous tissue with multiple pockets of collection in the neck space. Largest is in the right side between right lobe of thyroid and strap muscles. OPG was normal. Pus for culture sensitivity was sterile. And WBC and neutrophils are raised. Rest are all normal. So incision and drainage under general anesthesia with extraction of right lower premolar tooth along with extraction of necrotic bone pieces and of alveolar was done. Preoperatively, patient was put on antibiotics, analgesics, and anti-inflammatory, and regular dressings were done. In spite of all the dressings, there was gradual spread of necrotic area seen in spite of adequate treatment. Due to poor 1 unit packed RBC was transfused. Patient developed dry cough from 4th post-operative day, which was not responding to treatment. And on 9th post-operative day, chest X-ray was done, which showed a well-lobulated radio-opaque lesion in the region of right hilum. So CT was advised, and which showed peripherally enhanced multiloculated intercommunicating hypodense lesion involving mediastinum, and it is anterior to pericardium with mild pericardial effusion and exterior and extending superiorly along retroclavicular region into neck between right and carotid sheet is not involved here. The management was USD guided aspiration of mediastinal abscess, which was sterile and was done, and the patient recovered completely thereafter with secondary healing of neck wound. Discussion. This is a case of elderly non-diabetic male with delayed healing with necrosis of neck skin with subcutaneous spread of mediastinum. So mediastinum must be evaluated for prevention of mediastinal collection from becoming mediastinitis, which was associated with high mortality rate. Prompt investigation with clinical suspicions led to an early diagnosis of this potentially catastrophic complication, which without intervention could have resulted in severe morbidity. So conclusion, mediastinum is an hidden area and has to be evaluated in all cases of multi-compartmental neck that are not responding to treatment adequately. Although financial constraints pose a possible limitations. Thank you.
Next candidate. Respected judges, this is the last candidate for this session, sir.
Okay, thank you.
Yes, sir.
Okay.
39. The last candidate.
See your screen.
Yeah.
Okay, thank you.
Hira Reddy.
Sir, is the screen visible, sir?
Yes.
Sir, am I audible, sir?
Yes.
Go ahead.
Good morning, respected faculty. I'm Hira. Today I'm here to do a case report on a rare case of schwannoma and dorsal. Introduction: schwannomas are benign, slow-growing tumors that arise from the Schwann cells of the peripheral nerve sheath. These are also called as perineural fibroblastoma, neuralema or neuralomas. 25 to 45% of schwannomas occur in head and neck region. However, fewer than 4% of head and neck schwannomas occur in nasal cavity and paranasal sinuses. Malignant transformation is rare. Coming to the case history, a 15-year-old male patient presented with swelling on the left lateral side of the neck since 2 years. History of present illness: patient was apparently asymptomatic 2 years back when he developed a swelling over dorsum of nose, which was initially pea-sized, gradually progressed to the small lemon size. There was no history of nasal obstruction, pain, discharge, no history of trauma, allergies, no history of epistaxis, headache, no history of past surgeries. Past history: no history of similar complaints in the past. Family history not significant. Personal history takes mixed diet, appetite normal, sleep normal, bowel and bladder habits are regular with no addictions. General condition is good and with stable vitals. Coming to the ENT examination, nose examination, a single oval swelling of approximately 2 by 1 centimeter seen at left lateral side of dorsum of nose, which is firm in consistency, non-tender, freely mobile, non-pulsatile, not reducible, with well-defined margins without any discoloration. In nose, the swelling is normal. Anterior rhinoscopy, mild DNS to the left. Posterior rhinoscopy was normal. On nasal endoscopic examination, DNS to the left with right inferior turbinate hypertrophy. Paranasal sinus were normal. Throat and examination normal. And systemic examination was normal. And all the routine baseline investigations were done, which were normal. Coming to the radiological investigations, ultrasound of the swelling showed well-defined solid region measuring 2 by 1 centimeter at lateral wall of the nose. Contrast enhanced CT of PMS showed a well-delineated lobulated swelling of 2 by 2 centimeters with well-defined margins extending from anterior left lateral aspect of nasal bone to the midline. And there were no evidence of bony defect or intracranial extension. And these features suggested of space-occupying region in the subcutaneous plane of the nose. FNAC suggested of infected keratinous cyst. After all baseline investigations, the patient underwent excision of swelling under local anesthesia, and the findings were firm white-colored lobulated mass of approximately 2 by 2 centimeters was identified, dissected, and excised from the surrounding tissue, and the excised mass was sent for histopathology. And the histopathology of the schwannoma divided into two types. They show Antony A and Antony B areas. This is the hypercellular Antony A, and this is the hypercellularity Antony B areas. In Antony A, there are bland spindle-shaped with buccal nuclei. These cells often align to produce nuclear palacemin, resulting in alternating bands of nuclear and anuclear cells called Verroque bodies, and specific of Antony A. And the Antony B is typified by loose myxoid stroma with spindle cells. Coming to the differential diagnosis, there could be an dermal, sebaceous cyst, keratinous cyst, fibroma, or chondroma, or maybe a traumatic due to traumatic deformities, congenital masses, or maybe malignant neoplasms. Discussion: nasal schwannomas are variant in neoplasm. They have been postulated to arise from the ophthalmic or maxillary divisions of trigeminal nerve, the sympathetic fibers from the carotid plexus, or the parasympathetic fibers from the sphenoparietal genital. These are the most infrequent benign tumors of the nose and paranasal sinuses. These are slow-growing tumors but can become very large, expanding and eroding bone by pressure. Benign schwannomas usually consist of solitary encapsulated masses that are attached to the adjacent nerve, from which the lesion presumably arose. Microscopy shows elongated or spindle-shaped cells with oval or flattened nucleus with a palisading effect. It is, however, unusual to identify the particular nerve of origin. MRI and CT are invaluable diagnostic tools to demonstrate and assess the tumors of nose and nasopharynx. Biopsy can confirm the diagnosis. In gross, the tumor shows resemblance to a fibroma, which is frequent in nasal cavity. The tumor was therefore removed without being suspected as a special case. And so the solitary nasal masses have a wide area of differential diagnosis, and schwannomas may lie towards the lower end. However, they should be always kept in mind as they may occur in any age group and any location. These are my answers. Thank you.
Sir, you can ask questions.
Okay. Dr. Monry.
Okay, sir.
So, okay. What was the approach for surgery taken? External rhinoplasty or what was the surgical approach? I could not follow. It was external incision or
external incision, sir.
Externally,
external incision. Yes, sir.
Not the rhinoplasty, external rhinoplasty approach.
No, sir.
I think it was a possibility there. No, it could have been done that way to save that scar, because it's a schwannoma under the skin. It was not attached to the skin, isn't it? The mass was not attached to the skin.
It is in the subcutaneous.
It was attached subcutaneous. So that
Yes,
would have been the best approach, external rhinoplasty approach, cosmetically.
Thank you, sir. Thank you, respected judges. Yes, Ramesh Kumar, sir, Mohan Reddy, sir, GVS Rao, sir, accepting as the judges. Thank you once again. And this session ends now, sir.
Yeah. Thank you and congratulations to all of you. Almost we
Thank you,
accomplished.
Ramesh. Thank you, Ramesh. Thank you, Satish.
Thank you, boss. Thank you for your valuable time and energy.
Yeah, it's a privilege. I always believe that it's a privilege for an associate and a joint association.
Thank you.
Thank you
so
like
much.
this. And
Thank
when
you,
you
sir.
gave me the privilege. Thank you so much.
Yes,
Thank you, everybody, sir.
Almost we have come to the end of the conference.
Yeah, almost.
Yes, sir.
So
Last
far,
session.
so good, sir.
And it's a
so
good
Ramesh, sir.
opportunity.
Congratulations
Yeah,
on
good
the successful
opportunity
conduction.
to meet.
Let us use this experience in future.
Good opportunity, wonderful time.
Yes, sir. Yes.
Good opportunity for
Ramesh?
meeting,
Yes, sir.
seeing all the people, these days we are missing you, seeing each and each one. It's a good opportunity.
Is it Ramesh first time in India?
I don't know, sir.
Hopefully.
First time in India?
Yes.
Yeah, congratulations. Of course, I am also a member. Congratulations
You
to all
are
of you.
you are part and parcel of the AOI organizing committee.
Thank you. So my duty over. Our duty over. Okay.
Sir, yes, sir.
Thank you. Have a good day, all of you.
Thank
you. Bye.
Bye. Thank you.
See you.
Yeah, move on to the next session, sir. Final session. 15 more candidates are there. I request Dr. D. Satyanarayana, sir, from Warangal, Dr. T.B. Ramakrishna, sir, and Dr. S. Srinivas Kishore, sir, act as judges for this session, sir. Please welcome, sir.
Hello, everyone. Can you?
Yes, sir. Good afternoon, sir.
Good afternoon. Good to see everybody.
Yes. Sir, there are 40 serial number onwards.
Yeah, so it's
52,
40.
Two backlogs also there. Total 15.
All right. Sure.
Shall I call, sir?
Yes, please go ahead. And there are actually 4 columns here. 1, 2, 3, 4, 5 columns.
5 columns. For each column, there are 10 marks.
Correct. So there are no changes in terms of that. Yeah, sure. Yeah.
Thank you, sir.
Thank you.
Hello. Good afternoon, everybody.
Yeah, good afternoon, sir.
Srinivas Kishore, sir, President, General Secretary. Good afternoon.
Yes. Sir, thank you, our President-elect, sir. Now, Dr. Hasina. Are you ready?
Yes, sir. Good afternoon, respected teachers and my dear colleagues.
Screen. Yes.
Sir, am I audible, sir?
Yes, you are audible.
Yes, sir.
You share the screen.
Yes, sir. I'm going to present a case report on unusual presentation of juvenile nasopharyngeal angiofibroma.
Hasina, full screen.
Yes, sir.
F5. Yeah, go on.
Aim of my presentation is to evaluate nasal mass in adolescent male in taking into consideration juvenile angiofibroma for early diagnosis and management. Introduction. Juvenile angiofibroma is a unique tumor presenting almost exclusively in adolescent males. It accounts for 0.5% of all head and neck tumors. A higher incidence is noted in Southern Europe and even more in South Asia. Hippocrates first described this tumor in 5th century. In 1940, Friedberg called it juvenile angiofibroma, and it is most commonly seen in age group of 14 to 25 years. And prevalence in males can be explained due to high androgen receptor expression, suggesting that JNA is androgen dependent. The origin and development of JNA are not fully understood, and many theories have have been proposed. Most commonly accepted theory is hormonal theory, and recent theory that are being popular are vascular theories. Juvenile angiofibroma is a benign, locally aggressive tumor seen predominantly in adolescent males with bony erosions due to... Sir? Sir, am I audible, sir?
Yes, yes.
Yes, sir. Juvenile angiofibroma is a benign, locally aggressive tumor seen predominantly in adolescent males with bony erosions due to pressure resorption. The lesion may extend into pterygopalatine fossa, intraorbital or intracranial extension, and there is extension rarely into the oral cavity as seen in the present case. This aggressiveness and extensiveness can lead to high recurrence rates of 0 to 57%. This is a case report of 13-year-old child studying 9th standard from Nizamabad district, complaints of left nasal obstruction, which is insidious in onset, painless, gradually progressive, not associated with any allergic symptoms since 3 months, and there is difficulty of swallowing to solids since 1 month, associated with an episode of blood-stained saliva, about 5 ml, one episode 2 days back after admission in our hospital. History of bleeding from nose, single episode about 2 ml that stopped spontaneously about 3 months ago. There is no significant past or familial history. On examination, we can see a single pale, soft, fleshy, well-defined mass with smooth surface in left nasal cavity, extending into oropharynx, limit above the base of tongue, not bleeding on touch. Mass pushing the septum onto the right side. Spatula test and cotton wool whisk test confirm left nasal obstruction, and sense of smell is normal. PNS, eye, ear, and neck examination and systemic examination are normal, and all cranial nerves are intact. On DNA, we can see a single soft, pale, fleshy mass with irregular surface anteriorly in the left nasal cavity, mass extending to posterior nares and hanging into the oropharynx, lower limit above the base of the tongue. On probe test, it can be passed in all directions of the mass. The mass is not bleeding on touch, and cuff impulse is negative. On plain CT scan, we can see a large heterogeneously hyperdense soft tissue mass of size 6.4 into 4.3 into 4 centimeters of extensions anteriorly into the 1/3 of left nasal cavity, posteriorly till posterior pharyngeal wall, superiorly till floor of the sphenoid sinus, left laterally till medial pterygoid plate, antero-inferiorly till soft palate, uvula, anterior 1/3 of hard palate. There is no widening of sphenopalatine foramen, no Holman-Miller sign. So we have taken a biopsy of the mass. It features suggestive of capillary hemangioma and juvenile angiofibroma. On further investigation by MR angiography, we can see left ill-defined soft tissue density lesion in nasopharynx extending into the oropharynx of size 6 into 4 into 4 centimeters. There is no widening of left sphenopalatine foramen, and no extension into the intracranial or infratemporal region. Mild erosions are present. Multiple feeding vessels with prominent one being left internal maxillary artery is seen. Features suggestive of juvenile nasopharyngeal angiofibroma of stage 2A according to Fish classification. On surgical management, transendoscopic guided removal of left nasal mass by coablation, debridement, and delivery of mass from oral cavity in rose position. On follow-up, there is no residual mass and patient recovered uneventfully. On histopathological specimen, we can see gross specimen of a slightly pinkish non-capsulated mass. Query arising from a left sphenopalatine foramen, and on HP, hyalinized connective tissue with irregular vascular pattern is seen and confirms it to be juvenile angiofibroma. Discussion: the main clinical presentation of JNA is unilateral nasal obstruction with or without epistaxis, and differential diagnosis like antrachoanal polyp, inflammatory polyp, angiomatous polyps, nasopharyngeal cysts, carcinomas, soft tissue neoplasms, and esthesioneuroblastoma and granulomatous conditions can be taken. The present case is of 13-year-old with complaints of left nasal obstruction and difficulty in swallowing. On radiological examination, there is no widening of sphenopalatine foramen with mild erosions. On histopathological examination, it is confirmed to be left juvenile angiofibroma stage 2A. Conclusion: juvenile angiofibroma is a benign, highly vascular tumor, and nasal mass in adolescent males. JA should always be ruled out, and diagnosis should be made by.
That's it.
Already over.
Okay.
Sir, I request the judges small thing. The presenter has to finish by 5 minutes, sir.
Yeah.
If they finish half minute earlier, you can ask question. If they cross 5 minutes, no need of questions, sir. Within 5 minutes, you can ask questions.
Okay.
Sure.
Okay.
Before 1 minute, I will give a ring, sir, warning ring.
Yeah.
After final, I will give 2 rings.
All right.
Good afternoon, sir. Am I audible, sir?
Yeah,
yes.
you can.
Yes.
So good afternoon, sir. This is Dr. J. Munimahesh Babu, second year ENT postgraduate. Today I am going to present a case report of a role of nasolabial flap in reconstruction in carcinoma of buccal mucosa. The introduction to the topic is, so carcinoma of buccal mucosa is the most common oral cavity cancer in Indian subcontinent. Several methods are described for reconstruction of oral defects by using the pedicle flap or free flaps. So the nasolabial flap is ideal for reconstruction of intraoral defects because it is a being simple flap and the procedure is very fast. The advantage is providing a vascularized flap with matching of texture and the color of the skin. So I'm going to present a case report. A 69 years male patient came to our ENT OPD with growth of right buccal mucosa since 1 year and swelling of right upper cheek since 1 month. The growth was insidious in onset. The size is gradually progressive in nature. The growth is not associated with any bleeding, pain, and difficulty in opening of mouth and difficulty in swallowing. And patient gives personal history of patient usually consumes a moderate amount of alcohol since 20 to 25 years, not regular basis, occasionally. And patient here still denied taking of tobacco chewing. On examination of the oral cavity, usually there is no trismus here. And on examination of buccal mucosa, a 4 into 4 centimeter growth, which is presenting 0.5 centimeters from the anterior commissure to 3 centimeters from the retromolar trigone posteriorly. The superiorly, the swelling was extending 2 centimeters below the upper alveolar ridge and 1 centimeter above the lower alveolar ridge. And the surface was irregular, ulcerated, and the margins are everted. And the base is indurated, and the surrounding area was normal. On examination of neck, there is a single solitary hard lymph node of 3 into 2 centimeters was palpable on right side, that is at level 1B, which is level 1B. So we did investigations. The FNAC of ultrasound of neck is showing that a sclerotic lymph node in level 1 submandibular lymph nodes. FNAC was done, which was negative for the cancer, and the biopsy of the primary lesion was done, which revealed a well-differentiated squamous cell carcinoma, and the staging was T2, N1, and M0. We did a surgery, radical neck dissection, and wide local excision of the primary lesion, and we did nasolabial reconstruction of the intraoral defect. Here in these diagrams, the schematic diagrams are showing that neck dissection, the final one is the neck dissection sample. In this schematic diagrams, we are going to showing that wide local excision of the intraoral buccal carcinoma growth with nasolabial flap reconstruction. The final diagram is showing that closure of everything. Discussion. So the versatility and usefulness of nasolabial flap is well known. Usually the flap withstands a radiotherapy, which signifies its excellent vascularity. The blood supply of the nasolabial flap is from angular artery, which is a branch of facial artery, and also from infraorbital artery and transverse facial artery. Because of this rich vascular anastomosis, which makes the nasolabial flap is an ideal and also versatile flap for reconstruction. So the buccal mucosal reconstruction with nasolabial flap is one stage. It is possible in single stage. It is done even in both dentulous and edentulous patients. So the flap can be used either unilaterally or bilaterally. Usually for less than 3 centimeter defects, we can take unilateral flap, whereas for more than 4 centimeter defect, we can take bilateral flap. And flap can be taken either superiorly or inferiorly or centrally based pedicle flap. So the flap is commonly designed lateral to the nasolabial fold with medial limit of 2 to 3 mm lateral to the fold. The flap can be transformed in 3 directions, either into advancement flap, rotational flap, and transpositional flap. The most common, the donor site is closed with direct closure. The most common possible complications are hypertrophic scar, wound adhesions are the more possible complications when we are doing under tension. The disadvantage of this flap is there is a chances of buccal tunnel. If it is created, that should be closed. Other problems such as cheek biting. So the possible outcomes are necrosis due to hematoma, infection, tension, and the suture line. So that flap survival depends upon the early recognition of the compromise such as ischemia and necrosis. Conclusion, so the nasolabial flap is a versatile for reconstruction of medium-sized oral defects. It has a robust best supply, helps to ensure the flap viability to prevent the flap breakdown even in adverse conditions of excess tension. So the nasolabial flap has proven to be useful and reliable alternative without causing much morbidity to the donor sites when compared to other flaps. Thank you, sir.
Thank you.
Next candidate, Shreya. Dr. Shreya.
Good
Are
afternoon.
you there?
Yes, sir.
Yeah, share your screen.
Is my screen visible, sir?
Yes. Yes, it is. Go ahead.
Very good afternoon to one and all present here. I am presenting a case on myoepithelium of the tongue. Aim is to introduce a rare case for discussion and reporting, which is rare in its anatomical presentation and histology. Presenting to you a case of a 34-year-old female with a history of swelling over the right lateral aspect on the dorsum of the tongue. 34-year-old female with a history of swelling over the right lateral aspect on the dorsum of the tongue for 7 years, which was insidious in onset, initially progressive, later remained consistent for a greater amount of time. It was initially a painless swelling, measuring 25 into 26 millimeters, non-tender, soft firm in consistency, negative on transillumination, without any dysphagia or difficulty in speech or difficulty in movements of the tongue. There were no significant complaints, and the rest of the examination was normal. So with these findings in mind, I had a differential diagnosis of hemangioma, which is the most common DD, lymphadenitis, lipoma, papilloma, minor salivary gland tumors, schwannoma, neurofibroma, neuralgia, granular cell tumor, rhabdomyosarcoma, because I was thinking in terms of benign lesions. So on final aspiration cytology, it revealed a cluster of spindle cells which were arranged in fascicles and sheets with a myxoid background, which is acellular. So our pathologist gave a differential diagnosis of 3 possibilities, which were pleomorphic adenoma, benign nerve sheath tumor, and a spindle cell myoepithelioma. A high-resolution ultrasonography of the tongue was done, which revealed a well-defined hypoechoic lesion, which had ill-defined hypoechoic areas without any increased flow on color Doppler, and the underlying muscle planes were well delineated. So our preoperative workup was done, which was thoroughly evaluated locally and systemically, and all investigations were within normal limits, and the patient was surgically fit. So we had performed an excision biopsy with cold sent for histopathological examination. Intraoperatively, the lesion was yellowish brown in color with very thin capsule, measuring about 3.5 into 2.5 centimeters, and had a multilobulated appearance. Histopathology revealed a tumor tissue which is composed of spindle cells arranged in trabeculae with an acellular background, which had skeletal muscle bundles. Myopitheliomas are extremely uncommon benign salivary gland tumors, which constitute only 1.5% of the all salivary gland tumors. To date, only 4 lesions have been reported in the tongue, and there are of 3 variants: plasmacytoid, clear cell, reticular variant, well circumscribed, encapsulated, and there are 2 theories of tumorigenesis: multicellular theory and bicellular reserve theory. On gross appearance, they are well encapsulated and very rarely, and usually found on parotid, very rarely found in minor salivary glands of palate, buccal mucosa, lips, nasopharynx, and tongue. This is a preoperative image and postoperative image where we find a scar. Thank you.
Excellent presentation, I think, Dr. Shreya. Ramesh, can we ask some questions?
Yeah,
at
you
this
can
point?
ask, sir. You have time, sir.
We have time. So,
Yeah, 1 minute, 10 seconds.
when you did the Doppler, did you do any kind of Doppler study of the lesion in the tongue, Dr. Shreya?
No, sir. Actually, high resolution ultrasonography was done. And
Correct.
simultaneously, they have checked for any underlying vasculature, whether it was
Correct.
coming from.
Correct, because that's very important, right? You need to know the proximity of this lesion to the lingual vessels, isn't it?
Blood vessels.
Yes. So without that, you would be, blinded by. You don't want to have any kind of surprises. Did you do it endoscopically or just an open approach?
Open approach, sir.
Okay,
It was an
excellent.
open approach.
Yeah, excellent. Thank you very much, Shay.
Thank you, sir.
Thank you. Next, Revati. Dr. Revati, are you there?
Yes, sir.
Yeah.
Good afternoon, everyone. I'm going to present a case of papillary carcinoma of thyroid in a thyroglossal duct cyst. The aim of my presentation is to report a rare case of papillary carcinoma of thyroglossal duct cyst, and presentation in an adult male is a rare entity. So thyroglossal duct cyst is the most common midline neck mass in children that occurs due to failure of obliteration during their development. And incidence of thyroglossal duct cyst carcinoma is 1% of the cases of duct cyst, with the papillary carcinoma being more common, and most rare is the squamous cell carcinoma. Less than 250 cases of thyroglossal cyst carcinomas are documented. With rarity of this type of carcinoma, no protocol exists about the proper treatment approach and the particular radical extent of the oncological therapy.
One second. I request non-passengers, please mute.
My case is of a 35-year-old male presenting with a swelling in front of the neck since childhood, with increase in the size of the swelling since 6 months, which was painless and gradually progressive without any history of dyspnea or hoarseness of voice. There was history of weight loss. On examination, there was a single smooth ovoid swelling approximately 3 into 2 centimeters below the level of the hyoid bone, moving with deglutition and protrusion of the tongue. It was on palpation. It was non-tender without any local rise of temperature. It was firm to hard in consistency. The skin over the swelling was pinchable. It was mobile even in the horizontal plane, and there was no other palpable swellings. Ultrasonography of the neck showed a well-defined avascular rounded thick-walled cystic lesion with internal echoes and comeltate artifacts suggesting of thyroglossal cyst with a measurement of 2 centimeters, and right lobe of thyroid gland with hyperechoic nodule, few areas of degeneration and peripheral vascularity. Left lobe is normal with hypoechoic nodules, and few subcentimetric level 2-3 cervical lymph nodes were noted. So an impression of multinodular goiter and a thyroglossal duct cyst was seen. So video laryngoscopy was normal, and fine needle aspiration cytology suggesting of benign cystic lesion, possibly thyroglossal duct cyst with a thyroid's grade 2, and the patient was euthyroid state. The patient was managed surgically with thyroglossal duct cyst excision. As the cyst was well defined and localized, and there was no visualization of the tract, only the thyroglossal duct cyst excision was done, and it was sent for histopathological examination, which showed the cyst lining with flattened cells, and there was it was filled with thick colloid tissue. There was numerous branching papillae lined with thick tall columnar cells, and they were the cellular morphology showing round to oval pleomorphic nucleus. That is the classical orphanani eye appearance, and there were intranuclear inclusions, that is a coffee bean appearance. All the features suggesting of thyroglossal duct cyst with the papillary carcinoma of thyroid. And the patient was referred to surgical oncology department for further management, and he was evaluated with the ultrasonography, postoperative ultrasonography and MRI neck. Ultrasonography showed a well-defined lesion in the right lobe of thyroid gland with peripheral vascularity and halo seen peripherally, and left lobe is normal with hypoechoic nodules, and few subcentimetric cervical lymph nodes were seen. So evidence, impression of multiple nodules in the thyroid gland was seen, and similar impression in the MRI neck was also observed. And patient was planned for total thyroidectomy, but due to COVID situation, the patient did not follow, but he's on follow-up, and he's managed further for thyroidectomy. So thyroid carcinomas constitute for less than 1% of thyroglossal duct cysts with a mean age of 35 to 40 years, and more common in females is 2.9 2.9 ratio. More common is papillary carcinoma. So any change in presentation of dysphagia, dysphonia, rapid increase in size or fixity to the surrounding, you should have a changes in the magnet change. So low risk patients, cyst trunk is enough. High risk patients, you have to go for total thyroidectomy and iodine ablation therapy. Overall survival is better with 95% survival rate. These are the differences, sir.
Okay, one question.
Yes, sir.
Did you remove body of the head bone?
No, sir. There was
Why?
we are not able to visualize any tract, and the surrounding tissue was normal, no evidence of any tract. So we just excised that cyst.
Okay. Okay.
Thank you, sir.
Reshma?
Yes, sir.
Yeah. Share your screen.
Yes, sir. Sir, is it visible, sir?
Yeah. Full screen. Start.
They ride tricycles in the hallway, not in the park. They know the names of their chemo instead of their classmates. Nurses and doctors are their new family. Their laughter will make a heart melt. Their strength will make a grown person cry. If you've ever seen a kid fight cancer, it will change your life forever. The month of September is declared as Childhood Cancer Awareness Month. I would like to take this platform to discuss a rare presentation of pediatric rhabdomyosarcoma of the nasopharynx. Coming to the case details. 6-year-old male with history of nasal obstruction for 2 months, bleeding from the nose on and off episodes for 2 months, history of snoring and mouth breathing for 1 month, fullness in both ears for 1 month, headache for 1 month. There was no history of any nasal discharge, loss of smell, vision abnormalities, ear discharge, ear pain, or frequent upper respiratory tract infections. On examination, anterior rhinoscopy revealed pale polypoidal glistening masses in the left nasal cavity, not bleeding on touch, extending into the choana and the oropharynx. Posterior rhinoscopy revealed huge polypoidal grape-like mass arising from the nasopharynx, hanging into the oropharynx, pushing the soft palate downwards and forward. The palatal movements were normal and there was no neurological involvement. This is the mass in the left nasal cavity. On radiological examination with CT PNS and contrast MRI, a 4.2 by 4.6 by 4.6 centimeter mass in the left posterior nasal cavity, left maxilla, anterior and posterior ethmoids, extending into the sphenopalatine foramen, pterygopalatine fossa, masticator space, with intracranial extension involving the Vidian canal, inferior orbital fissure, foramen rotundum, and medial aspect of the temporal lobe was seen. It was involving the sphenoid sinus and the nasopharynx. Biopsy was taken and sent for histopathological examination, which revealed small to intermediate round cells with numerous capillaries and spindle cells with pleomorphic hypochromatic nuclei and rhabdoid morphology, indicative of round cell tumor. For further confirmation, immunohistochemistry was done, which suggested it to be having desmin positive and myogenin positive, which is highly specific for rhabdomyosarcoma, NSC patchy positive, and lymphocyte antigen negative. This was diagnostic of embryonal rhabdomyosarcoma, and we had staged it to be AJCC T2B N0M0 stage 3. Surgical debulking had been done for symptomatic relief, and the patient had been referred to the onco department for chemotherapy with vincristine, adriamycin, and cyclophosphamide. This is a post-op pic of the patient on chemotherapy. Coming to the discussion, rhabdomyosarcoma is a highly invasive malignant tumor arising from the mesenchymal tissue. The tumor can arise in different sites, typically involving the soft tissues of the head and neck, extremities, and the genitourinary tract. It is the most common soft tissue tumor in children, accounting for 8% of all the childhood solid tumors. But the presentation in the nasopharynx is very rare, with an average incidence of 17% of head and neck tumors. So 4 main types histologically: embryonal, alveolar, spindle cell, and pleomorphic. In the development of metastasis, rhabdomyosarcoma differs from other sarcomas in its way to have dissemination by means of lymphatic pathways. Management in all the patients is multimodal, using a combination of chemotherapy, radiotherapy, as well as surgery. External beam radiotherapy is an integral component of treatment for nasopharyngeal rhabdomyosarcomas. Although rhabdomyosarcoma of head and neck regions are not very common, any child with a fleshy mass which does not bleed on touch, the possibility should be thought of. Rhabdomyosarcoma of the nasal cavity often being present
जाएगा 6 o'clock ला?
it may easily be mistaken for nasal polyps. For this reason, it is important that polypoid growths in the nasal cavity occurring in childhood be biopsied. Encouraging progress in the diagnosis, management, and salvage therapy has been made. In particular, the importance of multimodality chemoradiotherapy has been highlighted, and recent improvements in imaging and conformal techniques have the potential to reduce the morbidity associated with this. Though the terrifying reality of a cancer diagnosis can change a child's life, but as technology and treatments improve, many more children could be able to call themselves as survivors. Thank you.
Sir, you can ask question.
Thank you. Dr. Reshma, nice presentation. Can I ask you as to what was the approach and for the surgical intervention?
Sir, we had actually transnasally birth, sir, but the tumor was delivered through the oral cavity, sir.
All right, it was a complete endoscopic approach. Is that what you're saying to say?
Endoscopic approach, but finally we had put in rose position and we had delivered the tumor intraorally, sir.
Fine, fair enough. Thank you.
Thank you, sir.
Yes. Next. Thank you, Reshma. Next, Chandana. Chandana, are you there?
Yes, sir.
Yeah.
Sir. Can you see my screen, sir?
No.
No, I think Dr. Reshma has to stop screening, stop sharing her screen.
Yeah. Reshma, you exit.
Yeah.
I stopped, sir. I stopped.
Sir, can you see my screen now?
Yes.
Yes. Good. Full fit.
Good afternoon, everyone. Today I am going to present a case on glomus tympanicum, which has presented as an oral polyp with discharge. A 60-year-old female presented to the ENT OPD with chief complaints of purulent discharge from the right ear for past 9 months. There was also a complaint of mass protruding per ear and bloodstained discharge for 7 months. And there was a history of constant earache and progressive hearing loss for 7 months. She had no history of any ringing sensation in the ear. On physical examination, the patient was hemodynamically stable. A pinkish fleshy mass filling the right external auditory canal projecting from the meatus was seen. The facial nerve at the time of presentation was intact. Other lower cranial nerves were also intact. Coming to investigations, the biochemistry revealed no abnormalities. Photon audiometry, there was 56 decibels of conductive hearing loss. Preoperatively, a biopsy was done, which revealed it to be a capillary hemangioma. On computed tomography, there was opacification of all the mastoid air cells on the right side with opacification of the external auditory canal and mass extending into the anteriorly into the eustachian tubal orifice. There was erosion of the anterior wall of the external auditory canal on the right side. The patient was admitted and taken up for mastoid exploration under general anesthesia. A transmastoid approach was employed, and on opening the mastoid antrum, there was a pulsating tumor which occupied the entire mastoid antrum, editus attic, and the tympanic cavity proper, extending anteriorly into the eustachian tubal orifice. The tumor was elevated from all its attachment. The feeding vessels were identified, cauterized, and the tumor excised in toto. This is the intraoperative picture just before the closure. The cavity was obliterated with temporalis fascia flap and Muir's flap. A primary reconstruction of hearing was not done initially. Post-operatively, the facial nerve function was intact and the tumor was staged as glomus tympanicum fish type B. On histopathological examination, the specimen showed clusters of chief cells in Zerbollen pattern surrounded by blood vessels and focal hemorrhages, which was consistent with that of a glomus tumor. Coming to discussion, glomus tympanicum is a rare benign locally invasive tumor and which is slow growing and usually occupies the middle ear. It is the most common primary neoplasm of the middle ear and second most common tumor of the temporal bone. Glomus tumors arise from the paraganglions, which are the chief cells of neural crust origin, found in close association with sympathetic ganglions along the aorta and its main branches. Therefore, they are also known as paragangliomas or chemodactomas. Glomus tympanicum tumor originates from the paragangliomas along the tympanic segment of the Jacobson's nerve or the Arnold's nerve in the middle ear. They have a tendency to multicentricity with incidence of 25 to 50% in familial cases and 10% in non-familial cases. As these tumors are derived from non-chromaffin paraganglia, they usually do not have any functional properties. They are generally benign and have local invasion, and the malignant degeneration is exhibited in a percentage of 2 to 4%. These tumors spread through the tracts of least resistance, such as through the air cells of the temporal bone, or the vascular lamina, or the neurovascular foramina, and into the eustachian tube. The presenting features usually are pulsatile tinnitus, deafness, otalgia, dizziness, recurrent ear bleed, and facial and lower cranial nerve palsies in late stages. Though most temporal bone paragangliomas are diagnosed clinically and radiologically, they are confirmed histopathologically by the presence of monomorphic cell nests, vascularized stroma, and sustenacular cells. On CT scan, we can see a normal jugular fossa with intact jugular bulb and normal carotid canal, which is essential for its differentiation from its counterpart, the jugular variety. CT scan shows a soft tissue mass lateral to the cochlear promontory, which may fill the middle ear cavity and usually spares the ossicles. Biopsy is contradicted as it may lead to profuse bleeding and damage to the structures around. Surgical excision is the main choice of treatment in glomus tympanicum, and open cavity treatment usually prevents recurrence. Coming to conclusion, a differential diagnosis of glomus tympanicum should always be considered in a case of oral polyp with purulent ear discharge. Tinnitus, which is a prominent symptom in a case of glomus tumor, might not always be present. Always consider for contrast-enhanced computed tomography or MRI before attempting a biopsy on a mass projecting from ear. High clinical suspicion on basis of the age and presenting symptoms might direct us towards the best possible diagnosis and ideal course of investigations in such cases. These are my references. Thank you.
Abhisarika.
Sir, good afternoon, sir. Am I audible, sir?
Yeah. Share your screen.
Good afternoon, everyone. Today, I'm presenting a case report on a case of laryngeal papillomatosis for which the administration of intralesional bevacizumab was given. A 24-year-old female patient presented to the hospital with chief complaints of hoarseness of voice for 3 months, which was progressively worsened, complaints of difficulty in breathing for 3 days, and complaints of noisy breathing for 1 day. On examination, patient was in stridor with saturations of 88% at room air, which was not maintaining even after oxygen supplement, for which the patient had to undergo an emergency tracheostomy under local anesthesia. On indirect laryngeal examination, there was a papillomatous growth visualized over bilateral false cords and bilateral true vocal cords. The growth was obscuring the further view. The findings were confirmed on video laryngoscopy. And routine investigations and surgical profile were done where everything was in normal limits, and the patient was taken for direct laryngeal examination where biopsy was taken and sent for histopathological study. Histopathology revealed respiratory epithelium, multi-layered finger-like projections, and acanthosis, coilocytes, which are features of viral infection. There was severe dysplasia. CT neck showed enhancing soft tissue nodular thickening involving bilateral false cords, anterior 2/3 of cords, and anterior commissure, causing significant glottis narrowing with FS paraglottic fat planes. The patient underwent microlaryngeal debridement under general anesthesia. The papillomatous growth visualized was debrided with a micro debrider. After the complete debridement of the lesion, 0.5 ml of bevacizumab was injected over the papilloma affected areas with a microlaryngeal needle. These are the post-op pictures, which are immediate post-op, and after the 6 months, we could not see any recurrence, and the voice was also improved. Discussion. Laryngeal papillomatosis is a benign neoplasm which is characterized by exophytic proliferative lesions of connective tissue covered with epithelium. It usually starts in the commissure and anterior 2/3.
Hello? We've
Hello,
lost
there
your
is-
voice. We've lost your voice.
Abhisarika, are you there?
There is no audio.
Abhisarika, unmute. There is
Abhisarika, unmute. Abhisarika, unmute.
Hello.
Yes.
Yeah.
Are you back?
Yeah.
Hello.
Yes, go ahead.
It consists of two forms. One is juvenile onset form and adult onset form. The etiology is by HPV virus 6 and 11. The most common presenting symptom is hoarseness of voice. Affected individuals may develop noisy breathing due to the obstruction of airway. Some might also present with difficulty in speaking or completely lose their voice. Additional symptoms include chronic difficulty in swallowing, shortness or difficulty in breathing, sensation of a foreign body in throat, and choking episodes. Surgery is the primary method for removing tumors from the larynx or airway. Because the traditional method caused problems due to scarring of the larynx tissue, many surgeons now use laser surgery. Carbon dioxide or potassium titanyl phosphate lasers are frequently used for this purpose. Surgeons are commonly use a device called microdebrider, which uses suction to hold the tumor in place while the internal rotatory blade removes the growth. Several newer forms of adjuvant therapy have shown promising results in improving the control of laryngeal papillomatosis, but none seem able to eradicate the HPV genome from the laryngeal mucosal tissue. These include interferons and antiviral drugs such as acyclovir, ribavirin, cidofovir, indole 3-carbinol, isotretinoin, and photodynamic therapy.
Tiskunta kakunki
Conclusion. Bevacizumab is a human monoclonal antibody that binds to and neutralizes the biological vascular enemy.
Next candidate.
It neutralizes the... Sir?
Time up.
Thank you, sir.
Dr. Roshini?
Yes, sir. Am I audible, sir?
Yes.
Yeah.
Good afternoon, respected faculty. Today I'm going to present on a case presentation on schwannoma at the level of C2, C3 cervical roots. Schwannomas are also known as neurilemomas or neuromas, the benign nerve sheath tumors deriving from Schwann cells that are occurring in the head and neck region in 25 to 45% of cases. About 10% of schwannoma that occur in the head and neck region generally originate from vagus or sympathetic nervous system. Those arising from C2 nerve root are extremely rare. Preoperative imaging studies such as MRI and CT are used to distinguish its location and origin. The treatment of schwannoma is primarily surgical resection, while several surgical modalities have been introduced to preserve the neurological function. Coming to the case report, a 22-year-old male student, resident of Vikarabad, came with the chief complaints of swelling on the left side of the neck since 1 year. Patient was apparently asymptomatic a year ago. Later, he developed a gradually progressive left-sided neck swelling, which was initially painless, but a week ago, he developed pain which was intermittent and not radiating and associated with headache. There is no history of trauma, hoarseness of voice, dysphagia, nasal regurgitation, drooping of shoulders, and any other neurological deficit. And there is no history of weight loss, loss of appetite, cough, fever, vomiting, melena, and not a known case of hypertension, asthma, and tuberculosis. There's no significant past history, family history, personal history was good, and the general examination, the general condition was fair, and vitals are stable, and all the systems appears to be normal. On local examination, swelling was oval So, a single oval swelling measuring 6 into 4 centimeters over the left level 2 region of the neck. Visible pulsations are present. Skin over the swelling is intact without any pigmentation, ulceration, excoriation, with no visible sinuses and fistula. It was soft to firm in consistency with well-defined margins, freely mobile, non-tender, showed no signs of inflammation and not reducible. There's no enlargement of other cervical group of lymph nodes and no other swelling. Facial nerve examination is normal and laryngeal crepitus present. ENT examination normal. Neurological examination revealed no local or focal neurological deficit. On flexible laryngoscopy, bilateral vocal cords are mobile. On USG, neck well-defined oval homogeneous iso to hypoechoic lesion noted in the left side of the neck in the region of carotid, measuring 5.6 by 2.9 by 4.3 centimeters, showing moderate vascularity. This lesion displayed common carotid and its vessels IC and EC anteriorly, and posteriorly it is in relation with scalene muscles, and superiorly the lesion extended up to the level of thyroid. Into subcentric jugular nodes, level 2, 3 are noted on the F side. And the MRI neck show well-defined heterogeneous lesion noted in the left carotid space with diffusion, restriction, and very few phlovoids. CT neck angio shows well-defined heterogeneous enhancing soft tissue density mass lesion on the left carotid space extending from level of C1 to C4, and no luminal narrowing is seen. A lateral neck incision was given on the lateral aspect of the neck over the swelling, and the mass was separated from the surrounding structures and the carotid sheath and its contents, and the mass was excised and removed by blunt dissection, and specimen was sent to HPE. Intraoperatively, we found that the left side well-capsulated oval lesion measuring about 6 by 5 into 5 centimeters arising from left cervical plexus present, extending from carotid bifurcation to skull base, no infiltration to surrounding structures, and no cervical lymphadenopathy. HPE report shows hypercellular Antony A and hypocellular Antony B with varicose body formation, mild pleomorphism, ATP is not seen, and no evidence of malignancy. Thus, the features are these two of schwannoma. Post-operatively, it are healed well, and there is no neurological deficits. Schwannomas, about 25 to 45% cases are occurring in the head and neck region, about 10% from the vagus and sympathetic nerve system. Vagal schwannomas typically characterized by dysphagia and hoarseness. Voice and sympathetic schwannomas are characterized by Horner syndrome. Most of the cases, however, there are no symptoms, thus it is difficult to identify the neurological origin based on the physical examination. Imaging modalities like CT and MRI help in identifying the tumor and its correlation with the surrounding vascular structures, muscles, and nerves. Previously, to prevent the recurrence of tumors, radical dissection, including the neuroprogenitor cells, are performed, and recovery was achieved by nerve transplantation or primary anastomosis. And most of the neuroprogenitor fibers do not run to schwannoma, and they pass over the tumor capsule. And microscopically, schwannomas are encapsulated, and they are composed of two zones, that is Antony A and Antony B, with palisading nuclei, varicose bodies. And cases where partial removal of tumor was performed, the recurrence rate has been reported to rise. These are my references, and thank you, sir.
Thank you.
Sir, you can ask any question. Otherwise, next I will call next.
Yeah, go ahead. Call the next one, sir.
Yeah.
Okay.
Next.
Go ahead, present Pratik.
Hello, sir.
We don't see your screen. You have to share your screen.
Yes, sir. Can you see my screen, sir?
Yeah, now yes. Please go to slideshow.
Good afternoon, esteemed judges and faculty. My name is Dr. Pratik. I'm here to present an unusual presentation of nasopharyngeal carcinoma in a child. Nasopharyngeal carcinoma is a malignant neoplasm arising from the epithelial cells of lining of the nasopharynx. It is a rare tumor in children younger than 10 years of age, and the incidence rises gradually with the age of patient. Early tumor has non-specific clinical presentation, such as nasal congestion, lymphadenopathy, and ear symptoms. The diagnosis is delayed as the clinician might be inclined towards an infective or benign pathology. Gold standard treatment is chemoradiotherapy, and as the tumor is both chemosensitive and radiosensitive, early diagnosis will avoid the unnecessary extent of radiation and associated comorbidities of the treatment, especially in pediatric cases. Case report: 11-year-old girl presented to ENT OPD with chief complaints of painful neck swelling in the upper part of the right neck and high-grade fever since 20 days. The neck swelling was preceded by severe pain, and it was restricting right-sided neck movements. Fever was high-grade and intermittent. Child had a single episode of mild unprovoked epistaxis 5 days back, which resolved spontaneously. She had a history of sore throat and no history of trauma to neck or no other symptoms of ear, nose, or throat. The child showed minimal improvement with NSAIDs and antibiotics. On examination, child was febrile, vitals were normal. There was a, on examination of the neck, as you can see that there is a mild torticollis to the right. We could see a 2 into 2 centimeter diffuse smooth swelling present at the right level 2 of the neck. It was firm in consistency and tender on palpation. It was non-compressible. No local rise of temperature was seen. It was mobile in all directions. Skin over the swelling was normal. On examination of nose, anterior anoscopy was normal, sir. And on posterior anoscopy, we could see an irregular mass in the nasopharynx extending anteriorly, occluding the choanae, more on the right. Rest of the ENT examination was normal, sir. On diagnostic nasal endoscopy, on the first pass, this is a diagnostic nasal endoscopy of the right nasal cavity. We could see a single irregular soft pinkish mass in the nasopharynx, which was extending onto the choana anteriorly. And this is a flexible laryngoscopic picture of the left nasal cavity. You can see that there are small, tiny bleeding points. The mass was bleeding on touch. We planned for an FNSC of the neck swelling, CECT MR of the neck and nasopharynx. FNSC of the neck showed features of inflammatory adenopathy. This is an axial section of the CECT of the nasopharynx. As you can see that there is a heterodense mass in the nasopharynx, which is abutting onto the posterior choanae, both on the right side and left side. Posteriorly, a fat space of the between the retropharyngeal space was maintained, and no other extension was seen superiorly or laterally. There are multiple lymph nodes in the right level 2 and level 5, sir. MRI neck also confirmed the CT findings, and submucosal lesion, which was hyper-intense on T2, was seen. Clinically, we staged this as stage 2A of nasopharyngeal carcinoma. Chest X-ray was normal, sir. Ultrasound abdomen was normal. We have undertaken a endoscopic assisted biopsy under general anesthesia from the nasopharyngeal mass, and it was sent for histopathology. The report showed features suggestive of undifferentiated subtype of non-keratinizing nasopharyngeal carcinoma, sir. The patient was sent for concurrent chemoradiotherapy with adjuvant chemotherapy. 4 cycles have been completed as of now. The patient has taken the treatment very well, and she was hemodynamically and symptomatically stable, sir. And endoscopic follow-up showed remission of the disease. The child is being planned for a contrast-enhanced whole body PET CT scan, sir. Discussion: nasopharyngeal carcinoma, also called cavum carcinoma, is a squamous cell carcinoma from the lining of nasopharynx. It has a bimodal age distribution and male preponderance. However, our child is a pediatric girl, and the annual incidence is around 0.5 out of million children. The commonest presentation is the presence of a painless mass in the neck. However, our patient presented with a torticollis with severe painful neck swelling, and non-specific nasal and otological symptoms may be seen, and advanced cases show neurological symptoms as well, sir. This is an unusual presentation of nasopharyngeal carcinoma. The clinical symptoms are mimicking acute infectious or inflammatory pathologies of nasopharynx. So pan endoscopy of upper air digestive tract, cross-sectional CT-MR imaging can aid in early diagnosis, sir, improving the outcome of the therapy. The endoscopic examination will show mucosal involvement, gross tumor extent, and will allow direct guided biopsy under direct vision. The standard treatment modality is chemoradiation, sir. Here you can see that we have given IMRT for this patient, sir. The primary lesion is given the standard dose, sir, and adjacent tissues are given lower dose. Follow-up endoscopy at 6 to 8 weeks and imaging at 10 to 12 weeks should be done to document tumor responses. After complete remission, the child should still follow up for about 5 years for posterior anoscopy, endoscopy to detect recurrent lesions, and a whole body PET CT scan is more sensitive in cases of recurrent lesions, sir. In conclusion, the diagnosis of nasopharyngeal carcinoma hinges on clinical suspicion, sir, and pernasal endoscopy and CT-MRI scanning aid for this. And symptoms related to early nasopharyngeal carcinoma are non-specific and trivial and frequently escape the notice of clinician. So patients usually present with advanced locoregional disease. High clinical suspicion about non-specific presentation should be held, and such cases should be evolved by an ENT surgeon. Early diagnosis will lead to better outcome of therapy. Okay. These are my references, sir. Thank you, sir.
Okay. Okay.
Thank you, Pratik.
Dr. Vaibhav?
Is the time up, sir, for him?
Yes, sir. Time up, sir. He's late by 30 seconds.
Okay. All right.
Okay. You want to ask some questions, sir?
No. If the time is up, I think probably we can ask a little later.
Okay. Dr. Vaibhav. Okay. Full screen. Your voice is not audible. Vaibhav? Vaibhav, no audio.
Vaibhav, disconnect your headphones and directly speak. Disconnect from your laptop.
Okay. Vaibhav, are you there?
Things seems to be having some technical issues.
Sure. Vaibhav, unmute.
Vaibhav, you have to take out your headphones, disconnect it from your laptop and directly speak. Disconnect your headphones. Take out from the laptop. Detach it.
No, we are not able to hear you, Vaibhav.
Vaibhav? Shall we move to the next one, sir?
Yeah, I think looks like he's having some technical issues. We can probably get him back if time permits.
Okay. Shruti? Dr. Shruti. Hello, Dr. Shruti.
Hello, sir. Am I audible, sir?
Yes,
Yeah,
go
you're
ahead.
Yes,
Go
sir.
ahead.
Share your screen.
Okay, sir.
Okay, full screen.
Good morning, sir. Today I'm presenting Glanzmann's thrombasthenia in a rare case of which is a rare case in a case of epistaxis. My aim is to highlight this bleeding disorder in the Glanzmann's thrombasthenia in a case of epistaxis. Glanzmann's thrombasthenia is a rare congenital autosomal recessive bleeding disorder. The instance is about 1 in 1 million with the equal sex predilection. It was first documented by Edward Glanzmann, who described it as functional abnormality of the platelets with defective clot retraction, in which there is normal platelet count with a prolonged bleeding time. There is absence of platelet aggregation. Glanzmann's thrombasthenia is associated with mutations in the genes encoding for glycoprotein 2B and 3A, resulting in platelet dysfunction. It manifests as bleeding disorder characterized by mucocutaneous bleeding. In my case, a 13-year-old male boy came with the chief complaints of spontaneous heavy bleeding episodes with intermittent heavy bleedings which lasted for 2 days. Immediately, they went to local practitioner where his nasal packing was done and the bleeding was controlled temporarily. Then they referred here for further management. On history, there is a prolonged bleeding for minor injuries, easy bruising since the age of 1 year. It was regressed spontaneously on their own until the age of 10 years. There is no history of nasal obstruction, no history of usage of any medication. On examination, there is no active or postnasal bleeding. The child was conscious, coherent, cooperative, well-oriented. The pallor was noted in his eyes and nail beds. On intraoral examination, there is no bleeding gums and no on general examination, there are no ecchymatic patches papyri, and the examination of the liver and spleen showed no abnormality. In family history, is born out of non-consanguineous marriage. He had a male sibling with no bleeding disorder, and there are no similar complaints in the family. On investigation, hematological investigations, his blood group is A negative, and all the hematological parameters show normal except the prothrombin time, which is 14.7, which is prolonged, and EV's bleeding time for more than 20 minutes, which is also prolonged. We consider being the EV's time prolonged and with normal PT, APTT, we consider it as a platelet dysfunction. After 1 day, it again started heavy bleeding. We did diagnostic nasal endoscopy. On diagnostic nasal endoscopy, it showed heavy diffuse mucosal bleeding, and there are no growth or mass visualized, which required 2 units of whole blood transfusion and 6 units of fresh frozen plasma. We also given vitamin K and tranexamic acid. After 2 days, we removed pack under general anesthesia. On further investigation, we did factor assays. It showed normal clotting factor with factor 8, 9, 11 and factor 1, and ristocytin cofactor assay also normal. On platelet aggregometry, it showed absent response for adenosine diphosphate, epinephrine, collagen and arachidonic acid. And flow cytometry, it showed absent expression for CD41. Diagnosis based on hematological investigation, it showed normal platelet count with prolonged bleeding time. It also showed absent response for the ADP, collagen, epinephrine, which is consistent with the Glanzmann's thrombasthenia here, and it also showed absent response for CD41, which is also consistent with the Glanzmann's thrombasthenia, and it also showed abnormal global hemostatic test, which is also seen in Glanzmann's thrombasthenia. The differential diagnosis for this is the congenital fibrinogemia and van Willebrand disease, in which the normal coagulation parameters are seen, and there are normal coagulation parameter with decreased factors for factor 1 and 8, and with prolonged APTT that can also affect platelet function. In Bernard-Soulier syndrome, it is which is also a disorder of platelets. In Bernard-Soulier, we can see the decreased platelet count and decreased clotting factor 8 with normal ristocytin. In inherited thrombocytopenia, there is decreased platelet count, and acquired thrombasthenia, there will be family history of bleeding disorder. Discussion in this case, we suspected this Glanzmann's thrombasthenia due to typical history of excessive bleeding with prolonged bleeding time with normal platelet count. The diagnosis was confirmed by the platelet function studies and absent response to the ADP, epinephrine, collagen, which is responsible for the platelet aggregation. The Glanzmann's thrombasthenia is very rare congenital autosomal recessive disorder due to the lack of glycoprotein 2B3A, which leads to the failure of platelet aggregation. And the disorder has been reported in the families with consanguinity, but in our case, it is non-consanguineous. The treatment requires treatment is typically platelet transfusion. The patients with mild symptoms respond to desmopressin. It is useful for mucosal bleeding. It can be used in conjunction with the tranexamic acid. The patients are advised to not, we should advise the patient not to use any anticoagulant, platelet drugs, and antithrombolytic agents. Conclusion: whenever dealing with the case of epistaxis, we should be cautious and we should take proper history and complete examination, keeping in mind to rule out all the bleeding disorders. Although Glanzmann's thrombasthenia is one of the rare bleeding disorders, one should be aware of this condition while evaluating patients with the bleeding disorders with normal platelet count and prolonged bleeding time. There is no cure for the Glanzmann's, only prevention is the best. Platelet transfusion is necessary before the invasive procedure, any invasive procedure, and the community should be counseled to avoid consanguineous marriages. The patient should be educated for lifestyle modification and just to avoid bleeding episodes, which include avoidance of anti-platelet drugs, avoidance of the trauma, and maintaining of good oral hygiene. And though it is a rare bleeding disorder, early diagnosis and prompt treatment and proper supportive care carries good prognosis. My references.
You are late by 1 minute, Amma. Okay.
Okay, sir.
Okay. Dr. Gayatri.
Hello, sir.
Okay, you exist. Shruti exists.
Oh, okay, sir. Thanks.
Next, Dr. Gayatri.
Yes, sir. Good afternoon, sir.
Good afternoon.
Is my screen visible, sir?
Yeah, visible. Yeah,
yes.
Full screen, please.
Yes, sir. Good afternoon, sir.
Good afternoon. Start.
Sir, I'm late.
Yeah, you can start, Gayatri.
Good afternoon, sir. Today I'm going to present a case report on cavernous hemangioma. It's a rare benign tumor of the auricle. Hemangioma appear on the external layer of concern for otolaryngologists because of cosmetic and functional dearrangements which they produce. 16 cases of hemangiomas exclusively involving auricle have been documented to date. So my case was a 22-year-old named Muhammad, who is a resident of Kolkata, daily laborer by occupation, came with complaints of mass in the left ear since 1 month, which is gradually progressive, associated with intermittent bleeding, not associated with pain. There was history of trauma due to frequent ear pricking. There was history of hard of hearing in the left ear. On examination, there was a single globular mass involving the left conical region. On palpation, the mass bleeded on touch, and it was non-compressible, non-tender, and there was no positions felt. Later, the patient presented with scar coming over the mass region. Other examinations of nose and oral cavity was normal, and external auditory canal was completely occluded due to the mass. Considering these features, the differential diagnosis like pyogenic granuloma and papilloma was made. Later, the CT temporal was advised for the patients. It showed a tissue mass involving the conical region, and auditory canal and the middle ear was completely normal. So, planned for surgery. Oral mass was surgically excised, and vessel underneath was cauterized with the bipolar cautery under local anesthesia and sent for histopathological examination. The procedure was uneventful. So this is the intra pic showing the which is removed from the conical region. The histopathological report turned out to be a large vascular channels lined by epithelium filled with blood, and there was a dense connective tissues with areas of inflammatory cells like lymphocytes, plasma cells, and foamy macrophages. So based on the histopathological report, the diagnosis was made as cavernous hemangioma of the left auricle. So benign vascular lesions are common in head and neck. Clinical evidence of cavernous hemangioma external ear is extremely rare. Ear lobule is the most common site of auricular masses, followed by tragus, but cavum concha is an infrequent site. It occurs mainly due to the absence of soft tissue. Hemangiomas are of two types: capillary hemangioma and cavernous hemangioma. Cavernous hemangioma often appear on the skin, mucosal surface, and it also the internal organs. They appear as protrusions or masses. They are mainly treated by cryotherapy, radiotherapy, or electrotherapy. So the two steps of management of auricular vascular neoplasms include preoperative endovascular microembolization of posterior auricular artery, followed by the surgical excision of tumor. Surgery is the best therapy with good prognosis and few complications. Prognosis is favorable most of the time, and recurrence is rare. This is the post-op follow-up of the patient showing good recovery, and there was no recurrence of the lesion. So, hemangiomas of external ear are extremely rare and amenable to surgical excision. Accurate imaging is necessary to precisely define the site and extent of the lesion, and also recognizing the feeding vessel. Surgical excision is still the treatment of choice. These are my references, sir. Thank you, sir.
Gayatri, couple of things.
Sir?
First thing is, on examination, you knew that you had a clue that it may be a vascular lesion, isn't it? Because it was bleeding. Yes. What kind of imaging was done? What kind of imaging was done?
CT temporal was done, sir.
Was it done with contrast?
CT temporal.
Was it with contrast? Don't you think it would have added some more value?
Yes, because of the feeding vessel, we can identify and.
Correct. The other thing is, you said.
Yes, sir.
Yeah, what about the follow-up? You said there's no recurrence. How long have you followed up the case?
Follow-up. Then after 4 months follow-up, we did, sir.
All right. Okay. Thank you.
Next, Dr. Shanti Priyanka.
Yes, sir. Good afternoon, everyone. Today I'm going to present a case report on rhinocerebral mucormycosis. A 35-year-old male patient, Raju, farmer by occupation, came with chief complaints of left-sided nasal obstruction, nasal discharge, headache since 1 month, and swelling over left eye since 6 days. Patient was apparently all right 1 month back. Later, he developed nasal obstruction, which is insidious onset, gradually progressive, left-sided, aggravated by taking cold items and relieved by medication. Nasal discharge, which is watery and foul smelling, and there was left-sided frontal headache radiating to the left eye and left side of the cheek region.
He also developed left eye swelling 6 days back and inability to open the left eye and complaint of loss of vision on left side. There was 2 to 3 episodes of epistaxis in the past history, and there is known case of diabetes mellitus since 2 years and using medication. There is no significant past personal history, and general physical examination is normal. Local examination of the nose showed swelling present over the root of the nose, and anterior endoscopy showed DNS to the left, and hypertrophy of right inferior turbinate and left middle turbinate, and the sense of smell is decreased, and all other are normal. And tenderness over frontal and ethmoidal sinuses are present. Examination of the ear, throat is normal, and no palpable lymph nodes. The patient was referred to the ophthalmology department, and the findings are complete ptosis, pupils dilated and not reacting to light. Vision perception of light is negative. Retina pale cherry red spot is positive. Complete vascular occlusion of left eye, indication of central retinal artery occlusion. Diagnostic nasal endoscopy was done, which revealed pus in the bilateral medial meatus. It was sent for culture and sensitivity, which revealed Escherichia coli. Investigations were normal, except WBC count was 21,000, which indicated leukocytosis, and the fasting blood sugars were 256 milligram per deciliter. And the contrast CT scan showed mucosal thickening of bilateral maxillary sinusitis, ethmoidal sinusitis, and left frontal sinusitis. And the lamina piperaceae is eroded on the left side, and the mild proptosis of the left lobe, indication of cellulitis. Surgical procedure, patient was undertaken for the surgery after control of the blood sugars. Functional endoscopic sinus surgery was done under general anesthesia. The findings are thick insputate mucosal secretion in the bilateral medial meatus. Middle turbinate was absent on the left side. Lamina piperaceae is eroded on the left side. The procedure done was bilateral middle meatal androstomy and ethmoidectomy was done, and the greenish discharge present in the sinuses were cleared. Left sphenoidotomy was done, and left orbital decompression was done, and the specimen sent was for histopathological examination, which revealed broad pauciseptate ribbon-like hyphae, including the blood vessel suggestive of angioinvasion, and the granulomatous inflammation due to fungal infection, suggesting of mucormycosis. The postoperatively, the patient was given IV amphotericin B 1 mg per kg per day for 1 month, along with antihistamines and analgesics. Oral itraconazole of 200 mg BD was given for 1 month. Saline nasal dosing was done. We followed the patient for 6 months, and he was completely cured. The prognosis is poor and morbidity is present. Patient recovered well. Coming to the discussion, it is a rare disease caused by opportunistic filamentous fungi involving the nose, paranasal sinus, and the brain in the immunocompromised patient, in which the fungus grows rapidly, aggressively, causing well-defined fulminant and life-threatening condition. The etiology is saprophytic fungal mucor of the class Phycomycetes and family Mucораceae. Inhalation of spores from the fungi living in the soil and organic matter is the most common route of invasion. Pathophysiology, it is almost extend all surrounding tissue, then progress to the brain via ethmoidal sinus, orbital apex, and through bone erosion or through angioinvasion. Invasion of the blood vessel by fungal hyphae damages the endothelium, causing blood clots that occlude the blood vessel, leading to ischemia and necrosis of the surrounding tissue. Invasion of the brain and orbit is through involvement of sphenopalatine and intermaxillary artery. Hyperglycemia depletes the immunity of the body, phagocytosis of leukocytes, neutrophils, and chemotaxis, and local inflammatory responses is depressed in the patient with diabetes mellitus. The use of iron chelator deferoxide makes the iron available in the appropriate form for the fungal growth, thus increases the fungal virulence. Symptoms are one-sided headache behind the eyes, diplopia, and blurring of vision. Other symptoms include nausea, fever, nasal congestion, rhinorrhea, epistaxis, and nasal hypoesthesia, facial pain, numbness, and history of black nasal discharge. The signs showed nasal and orbital cellulitis, redden and swelling of nasal bridge, cheek in the later stages. Blast texture are visible on the nasal or palatine mucosa. Intraoral examination may show palatal ulceration. Differential diagnosis are bacterial sinusitis, allergic fungal sinusitis, aspergillosis, nasal and paranasal malignancy, brain tumor, and pseudotumor cerebral. Evaluation by endoscopy of sinus and biopsy of antral necrotic tissue should be performed immediately. And investigation of sinus is CT scan, which show double density sinus due to thickening of mucosa with hyperdense area. MRI is favored to visualize soft tissue, but it is more expensive. Medical treatment is 4 to 6 weeks of amphotericin B therapy is required to eradicate. And the daily dose is 1 mg per kg, which is tolerated by all patients. Liposomal amphotericin B is endorsed due to less toxicity as compared to high nephrotoxicity of amphotericin B alone. Surgical management is maxillectomy and ethmoidectomy is performed according to the site involved, and their extent depends upon the degree of bone and surrounding tissue involvement. Extension palatal ulceration and oloantral fistula formation when necessitated complete maxillectomy, and swelling with minimal bone erosion need partial maxillectomy. Proper clearance of involved tissue requires excision of more than 1 centimeter of healthy tissue. Orbital exenteration is needed in the case of severe orbital involvement. Intracranial involvement necessitates craniotomy and debridement. Endoscopic sinus surgery and topical administration of antifungal in the debrided area is also useful. Thank you.
There are 2 more
respected judges. Sir, 3 more participants are there, sir. Left over.
Yeah, sure.
Dr. M. Sweta. Sir,
What about Vaibhav?
Yeah.
Yes, sir. He will present after Shweta.
Do you like to ask any?
So who's coming in now?
Dr. N. Shweta, are you
Yes.
there?
Shweta is not feeling well, sir. She's not presenting.
Okay. Dr. Bhuvan.
Yes, sir.
Bhuvaneshwari?
Yes, sir. I'm ready, sir.
You are going to present. Yeah, Dr. Bhuvaneshwari, number 29, sir. Serial number.
Yeah. Got it.
29.
Dr. 29, Bhuvaneshwari.
Okay.
Followed by Vaibhav.
Pranit?
Sir.
Timer.
Yeah. Bhuvaneshwar, start.
Good afternoon, everyone. I'm going to present a case report on hemangioma of sublingual space. A 45-year-old female came with chief complaints of swelling on the right side of the neck for 2 years. She was apparently asymptomatic 2 years back, and later she noticed swelling on the right side of the neck, which was insidious in onset, initially small in size, gradually progressed to attain current size. No aggravating and relieving factors. There was no history of pain and discharge from the swelling, no history of fever, difficulty in swallowing, and change in voice. Past history, she was a hypothyroid and was on medication for 3 years. She had hysterectomy before 3 years. No other significant past history and family and personal history. Her general physical examination was normal. She was moderately built. All her vitals were stable, and she had normal general examination. Local examination, the swelling of size 2 to 2 centimeter in the right submandibular region, extending 3 centimeter laterally from the chin till the anterior border of the right sternocleidomastoid. Smooth surface, no punctum over the surface, no scars, sinuses, and dilated veins. Trachea seems to be in the midline, no thyromegaly. Palpation, inspective findings were confirmed. Swelling of size 2 to 2 centimeter with smooth surface, soft in consistency, compressible, fluctuant, not translucent. Skin over the swelling is pinchable. Swelling does not decrease in size with the contraction of platysma and the right sternocleidomastoid, and it is mobile in all directions. There was no local rise in temperature, no tenderness elicited. Bimanual palpation of the floor of the mouth was then.
Yes, sir.
The oral
Go ahead.
and yes, sir.
Continue.
The oral mucosa was normal. There was no discoloration of the floor of the mouth, but the swelling was appearing when we push the swelling below the mandible in the floor of the mouth. But there was no discoloration or dilated veins. No other positive findings in the floor of the mouth was noted. And the right submandibular gland revealed appearance of fluctuating swelling in the floor of the mouth on the right side. There was no bruit or venous hum noted. I would like to give a differential diagnosis based on the clinical findings of ranula, lipoma, silolithiasis, dermoid cyst, epidermal cyst, branchial cyst, lymphadenitis. Like clinically, we were not able to rule out any of this. Thyroglossal cyst was ruled out because it was not coming like on rotation of the tongue. It was not there. And AV malformation, like there was no discoloration of the mucosa, oral mucosa. So probably maybe it is not. It is not an AV malformation. Cavernous hemangioma, sometimes it presents with the discoloration, reddish discoloration, and probably even that is not there. Pleomorphic adenoma, adult rhabdomyoma, and neurofibroma, like since the swelling is soft, like maybe it is not that. FNS of the swelling was done, suggestive of vascular malformation. Ultrasonography was done, right submandibular gland, 3.2 to 1.8 centimeter lesion with thick internal septation with a noted in the inferior aspect of the submandibular gland, extending laterally till the anterior border of the right sternocleidomastoid, likely hemangioma. CCT of the neck had non-enhancing, ill-defined, isodense soft tissue density noted in the right submandibular space with few calcifications within abutting and displacing the right submandibular gland to rule out slow flow vascular malformation. They were not able to clearly define where the lesion was exactly there. And MRI, they suggested us for MRI, and MRI showed slow flow vascular malformation, likely hemangioma in the sublingual fat space. Medially abutting genioglossus, posteriorly hyoglossus, medially laterally mylohyoid, posterior inferiorly right submandibular gland, and posterolaterally abutting the carotid sheath. This is the lesion that is enhancing in the T2 MRI. Patient was evaluated for fitness, and surgical steps. Incision was given 2 finger breadth below the angle of the mandible, and the subplatysmal flaps were raised. Marginal mandibular nerve was identified and preserved. The digastric intermediate tendon was identified. Hemangiomatous mass was formed medial to the right submandibular gland. Feeding vessels were identified and cut. And hypoglossal nerve identified, preserved. Lingual nerve was preserved. And the specimen was like medial to the mandibular gland, submandibular gland. The hemangiomatous colored mass, discolored mass was found. Histopathologically, multiple anastomotic and dilating vascular channels lined by flattened endothelial cells separated by fibrous septa, showing mallymphocytes suggestive of vascular malformation. Cavernous hemangioma was found. Postoperative was uneventful. Thank you.
Last candidate, Dr. Vaibhav.
Yes, sir. Sir, am I audible, sir?
Yes, you are.
Yes, sir. Yes, sir.
Share your screen.
Yes, sir.
Okay.
Sir, good afternoon to all the esteemed judges and my dear colleagues. Today I'll be presenting a case of spindle cell tumor of the nasal cavity, which is a rare presentation in itself. Introduction. The spindle cell tumor is a unique variant of the squamous cell carcinoma. Most of the spindle cell tumors are malignant. However, and in this case also, a considerable portion of them tend to be non-malignant and are differentiated from the malignant ones by clinical features and histopathological studies and history of progression of the disease, in which the malignant ones are usually aggressive and also lead to loss of weight and the usual malignant syndromes of the tumors. The occurrence of this tumor in the nasal cavity again is very rare, as most common site for the spindle cell tumors as well as the squamous cell tumors are usually the larynx. Coming to this particular case, a 55-year-old male, farmer by occupation, came with the chief complaints of bilateral nasal blockade since 11 months. The blockade was initially on the right side and progressed on to the left from the past 6 months. A history of mouth breathing has also been present since 6 months, and this progressive nasal blockade was insidious in onset and gradually progressive. There is history of a single minor nasal bleed when the patient forcefully tried to clear his nose 5 to 6 months back. There is no history of weight loss or sudden growth of the mass. Past history is normal. There is no history of similar complaints in the past, no history of hypertension, diabetes, any thyroid issues, asthma, hypersensitivities, or any CVA, CKD, CLD, and CHD. Family history, there is no history of similar complaints in the family. Personal history, the patient is an occasional alcoholic and there is no history of smoking. So, and the rest of the history is normal. Coming to the clinical examination, coming to nasal examination, on examination of the right nasal cavity, a pearly white mass was observed approximately 5 millimeters behind the anterior end of the inferior turbinate and was extending both onto the roof and the floor. And on examining the opposite nasal cavity, there was a mild deviation of the nasal septum to the left, and the tumor was seen to be extending into the posterior choana also. On performing the probe test, the mass was found to be firm, didn't bleed on touch, and it was impossible to get around the mass and to locate a particular site of origin. The ear examination was normal, oral cavity examination normal, and the throat examination was also normal. Now, coming to the investigations, routine blood investigations were performed. All the other investigations came to be normal, other than that the patient was found to be HbsAg positive. Chest X-ray, ECG were also found to be normal, and direct nasal examination with the use of an endoscope was done, and histopathology and a piece was removed for histopathological examination. The histopathological examination report came back as a polypoidal mucosal folds lined by respiratory type of mucosa, which contain interlacing bundles of spindle cells. They also contain moderate to abundant fibrillary vacuolated cytoplasm and elongated nucleus, hence the name spindle cells. CTPNS was also performed, in which a radiolucent to radio-opaque mass was seen extending into the right nasal cavity and the nasopharynx with extension posteriorly into the left posterior nasal cavity and the nasopharynx. This is the typical spindle pattern of the histopathology of a spindle cell tumor, in which you can see elongated cells which mimic a spindle. And here we can see the mass extending into the right nasal cavity and pushing the septum slightly towards the left and blocking the maxillary antrum on the right side. Management: the person was managed by under GA. The patient was put in supine position with head slightly elevated, and the mask was removed by a standard fresh procedure, and the left DNS was corrected by doing septoplasty in the same sitting. After removal, the only abnormally observed was that the right middle turbinate was found to be papery thin, mostly due to the pressure atrophy of the given mass. Rest of the intra-op and post-op findings are normal, and the overall outcome of the patient prognosis was fine. The patient was followed up monthly for around 3 months, and then bi-monthly for around 6 months, and the patient prognosis is fine. The patient has no complaints. Now, coming to the discussion part, spindle cell tumors of the head and neck are a very diverse group of tumors. They are usually malignant, but can be benign or simply reactive in nature. In this case, the most probable pathology was reactive, since the patient was a farmer. The most common spindle cell tumor along the upper airway is the spindle cell carcinoma. However, the benign presentations are also being increasingly reported. The most common site for spindle cell tumor of the upper airway is the larynx. Other common sites being hypopharynx, oropharynx, the sinuses, and the nasal cavity. The spindle cell tumor confined solely to the nasal cavity is extremely rare, as in this case. Coming to the differential diagnosis of these masses, benign lesions. Benign lesions come as nodular fasciitis, fibromatosis, fibromas, neurofibromas, leiomyoma, neuralgioma, fibrous histiocytoma, myxoma, desmoid tumors, proliferative myositis, sclerosing angiomatosis, granulation, and sometimes granulation tissues such as reactive granuloma from a foreign body. Coming to the malignant lesions of the differential diagnosis, fibrosarcoma, liposarcoma, hemangiosarcoma, rhabdomyosarcoma, leiomyosarcoma, neurosarcoma, and malignant fibrous histiocytoma. And myxosarcoma is another one of the differential malignant lesions. Thank you, sir. That's my presentation.
Thank you.
Thank you, sir.
Any questions, sir?
Time is up now.
Time is up.
Yeah.
1.5 minutes.
Yeah. Thank you, sir. Sir, thank you, Dr. Satyanarayana, sir, Dr. T.B. Ramakrishna, sir, Srinivas Kishore, sir.
Thank you, Ramesh. I think the effort goes to
I'm very happy.
you. No, effort totally goes to you, Dr.
No,
L.S.
sir, it's a
Reddy,
team
sir.
effort, sir.
No, Dr. L.S. Reddy, sir. I think he's the fire. He's always there, and whenever it comes to state level meetings, he's there. And
yes, sir.
I think it's a overall well-rounded effort, and I think congratulations to all the participants. Yes, because they made the effort to sort of.
All are winners, sir.
Yes.
Here all are the winners.
Yes.
The itself is the winning, sir. The medal or one first and second is nominal, sir.
Yeah.
Right.